seminar on diabetes and fasting under the auspices of IDF Southeast Asia. We have such strong leadership that nothing less may be anticipated. The holy month of Ramadan is knocking, and it is our duty as clinicians and physicians to be prepared and equip ourselves with adequate knowledge so as not only to guide our patients of diabetes beforehand on safe fasting, but also ensure that they feel well supported throughout. Ramadan-focused education is the need of the hour for physicians and patients alike. To that effect, Dr. Banshi Sabu Sir, the IDF Southeast Asia Chair-elect, has rolled out this wonderful learning experience along with astute leaders like our Dr. Azad Khan Sir from Bangladesh, the current Southeast Asia Chair of IDF, and Dr. Shashank Joshi Sir, the immediate past Chair of the IDF Southeast Asia region from India. Without much ado, it is my honor and humble privilege to introduce Dr. Azad Khan Sir and Dr. Basit Sir and welcome them to open this meeting. Professor Dr. A.K. Azad Khan Sir is accomplished physician diabetologist from Bangladesh. Sir is honoris causa medicinae doctorate from Basel and honorary fellow of the University College London. Of course, he is the regional chair of IDF Southeast Asia at the moment, and he's also the president of Diabetic Association of Bangladesh. Also been an honorary member of the IDF, honorary president of Bangladesh Gastroenterology Society and Endocrine Societies, and besides various other important positions with the Bangladesh University and other important bodies. He was also the national professor he was announced as the national professor by the government of Bangladesh since May 2021. He's been awarded the Independence Day Award 2018, which is the highest civilian order from the government of Bangladesh for social services. Welcome, sir. Joining him will be Dr. Abdul Basit Sir from Pakistan. He is an astute physician, diabetologist, and director of the Bakai Institute of Diabetology and Endocrinology. He's also the professor of medicine at the Bakai Medical University, president of the Diabetes in Asia Study Group, Secretary General of the Diabetic Association of Pakistan, and head of the WHO Collaborating Center for Treatment, Education, and Research in Diabetic Pregnancies. Founder chair of IDF MENA region as well, and he's been the founder member of the Pakistan Endocrine Society and the National Association of Diabetes Educators. He is the chairman of the Pakistan Working Group on the Diabetic Foot, and besides other important positions, he's also been the ex-editor of Journal of Diabetology, official journal of the DASG, and is very, very widely published with more than 200 research papers in peer-reviewed journals. Welcome, sir, and with great humility, we pass on the baton to you for welcoming our audience today and also the context setting.
Professor Azad.
Thank you. Yeah, thank you, Dr. Chawla. I think it's a great privilege for me to welcome you all. The topic is very practical and important. I must say here that I'm not a practicing diabetologist, so all my colleagues know. Okay. Although I know a bit of diabetes, but anyhow, but I organize diabetes care. Shashank is smiling, okay. But I have to say a few things, you see. In philosophical language. Number one is that now it has been proven beyond doubt that fasting, some form of fasting is there in all religion, and fasting is good for health, if you do it properly. So this has been evidence-based now. Now, about Ramadan and fasting, I have to say 2-3 things. Number one, Ramadan brings a great opportunity for diabetes. Those who are believers in Islam if they intend to fast in Ramadan, that give them an impetus or extra opportunity so that they bring their diabetes under control before Ramadan starts. And then they learn how to keep it under control. Because they cannot be completely dependent on physician. They have to learn. I think this is a very important thing, that it's a great opportunity for diabetics and people who are involved in diabetes care to give this message, that this has given you an opportunity because you want to fast from religious point of view. So you bring your diabetes under control and learn how to keep it under control even during the. Second thing I want to say, I think all diabetics, if they want to fast, they should ask their physician whether they can fast and how to do it, best do it, and follow that advice. The last thing I want to say is the religion does not dictate that you fast at the cost of your health. So if you truly believe that you are unwell, you are physically not capable of fasting, then you ask your doctor. But if you want to find a pretext not to fast, so you see, those of you who believe in God, you know God, quoting a great Muslim philosopher, Jalaluddin Rumi, that he said God cannot do everything, like God cannot raise the sun from the west, keeping this universe in this form, you see. Like that, you see, an allegorical term. But God knows everything. God is in Bengali we call Antarjan. He knows everything. You can't hide anything from him. So there is no point of finding a pretext. So if you want to fast, control your diabetes even before fasting, keep it under control, take the advice of your doctor. But if your doctor says that you should not fast, you should not do it, because God has made provision that people who cannot fast because of the health reason, they can do what they have to do. That has been dictated into them. I think I have taken too much of your time. Thank you again for inviting me. And I think this is a great discussion. I can see a lot of people who are much more expert than me on this topic. Thank you very much.
Thank you, Professor Azad Saab. I also would like to say certain points. First of all, it's my pleasure and honor to be part of this August faculty. And at the outset, I'd like to congratulate IDF Southeast Asia region. Under your leadership, it is progressing leaps and bounds. And this organization of diabetes and fasting symposium itself speaks out of how much it is timely and needed. So I congratulate you, Shashank Joshi and Banshi Sabu. And Banshu has been tremendous, not only in IDF Southeast, but also in Diabetes in Asia study group. And we are very happy. I am the president of Diabetes Asia Study Group. I'm very happy to be part of the collaboration with this organization of Ramadan and Diabetes and Fasting Symposium by Banshi. So I'd like to congratulate them. I'm also very grateful to my team that we have worked with them to get this seminar going, inshallah. It will be a very successful event. I can see, as you said, from the rich faculty they have chosen for this fasting group. Here, I like to add that Ramadan and diabetes have been a group working for so many years, and it has done tremendous scientific work as well. But as you said, that not only Muslims fast, in fact, in other religions also there is fasting. So Professor Akhtar Hussain, the IDF president, he came up with an idea that we shall have fasting and diabetes group. So he developed a task force in IDF Lisbon last year, of which me and you are also part, and other colleagues are. And Professor Mujahid from Egypt and Professor Yaqub from Pakistan are co-leads of this task force. And they are now working on developing evidences and guidelines for not only Ramadan fasting, but other religious fastings, and as has been proven, intermittent fasting, etc. So this platform will set the scene very nicely for all these kind of collaborations and scientific evidences. I like again once to thank Banshi in particular, but other colleagues of IDF SEA for organizing this event. and also would like DAS to go ahead, inshallah, with further collaborations, expanding the canvas, and wish you a successful event. Thank you all for your attention. Thank you.
Thank you so much, sir. We have Professor Dr. Shashank Joshi, sir, who's been the immediate past chair of IDF Southeast Asia region, also join in. Thank you, sir. Welcome. And we move on to our academic program after these wonderful, wise, and positive words from both Professor Dr. Azad Khan sir as well as Dr. Basit sir. And we start with the first session all about fasting. And I have great privilege in welcoming our chairpersons for the same, Dr. Misbah Kamel, sir, who's a consultant internal medicine and endocrinology, Minya University, Cairo, and who's also the president of the Diabetes in Asia group and member of the IDF task force for fasting and diabetes that Dr. Basit Khan, sir, just referred to. Joining him is Dr. Bharat Sabu sir, who is a chief diabetologist and director at Prayas Diabetes Center, Indore, and also the organizing secretary of the upcoming Diabetes India meeting. Without much ado, let me hand it over to you.
Thank you, Poovi ma'am. Good morning, everyone. I welcome Dr. Shashank Joshi sir, Abdul Basit sir, and AK Azad sir, and thank them for setting up the agenda so well. I have with me Dr. Misbah. Dr. Misbah, would you like to introduce Dr. Shashank Joshi sir, please?
Morning, everybody, and on behalf of all who are concerning with diabetes and fasting in mankind, I am welcoming Dr. Shashank Joshi. Dr. Shashank is a very famous one. He is consultant endocrinologist, and he was the past chair of IDF Southeast Asia and the president of the Indian Academy of Diabetes. And Dr. Shashank has participated in nearly all activities related to diabetes and welfare of people with diabetes, not only in India, but on internationally also. And I think Dr. Shashank will give us a very informative talk about the fasting and mankind, because Dr. Shashank will know this area very well, and we welcome Dr. Shashank. The floor is you.
Thank you so much, my good friend, Professor Misbah Kamel, who is the immediate past president of DSG, as a good friend of ours from Egypt, and Dr. Bharat Sabu. At the onset, I first want to thank Dr. Azad Khan sir, as well as Dr. Abdul Basit sir, for allowing IDF Southeast Asia and DSG to collaborate. We want more members for DSG, and we urge people who are listening to this talk to become members of DSG. We are all members of IDF of our respective regions, whether it's MENA region or Southeast Asia region. Second is, of course, I have to thank my younger brother, Dr. Bansi Sabu. He has been extraordinarily active in this field. And a couple of years back, we wrote a paper on fasting, feasting, and diabetes. As Dr. Misbah, Dr. Azad Khan, and Dr. Abdul Basit said, that fasting is there in many religions. And we are all a part of that IDF task force, which our brother, our current president, Dr. Akhtar Hussain, has put up. And what Dr. Sabu told me actually is, Shashank, you will talk everything but Ramadan, because there are very good speakers who have done evidence base in Ramadan. But you will set the context of how science meets religion, or religion meets science. Because you see, mankind has seen fasting, and mankind has evolved from being a carnivore to herbivore to a mixed diet. So that is the first thing, that we are all human beings. I don't have any conflict of interest for this talk. Okay, my only conflict of interest is that I'm a friend of Dr. Sabu, who's a younger brother to me, Professors Azad Khan, Professors Abdul Basit, Mesbah. They are like elder brothers to me and our mentors and teachers. And Bharat is a good friend of mine. So that's my only conflict of interest. So, whenever religion has met science, there's always been a conflict. And fasting has been there in every religion, but it is most well structured and most well documented in Ramadan. And Ramadan is coming up very soon, next week, 22nd, 23rd, based on the lunar calendar. Of course, there are sects, Shias and Sunnis, and they have different timings of fasting of Ramadan, but usually that is when it is. And it is quite structured. It has a very, very well, ordained calendar. And the calendar is very predictable. But different parts of planet Earth have different timings of Ramadan. So that's something which we need to recognize. And this is most well studied. But just next week, the Hindu calendar is the New Year, on Gudi Padwa Day 22nd. And there'll be a 9-day fasting called Navratri. So my Muslim brothers and sisters need to know that there is a fasting. And just now, in this month, 40-day, there's a Lenten fasting in the Christians. So, but these are soft fasts because they are not as well structured as probably Ramadan is. So my context is to set the setting on terminologies, though Dr. Chawla is going to do a little bit on terminologies, history of fasting, biology of fasting. You will see a lot of that later today. Metabolomics of fasting. There is a new term for everybody to understand, FMD, fasting mimicking diet. Can you believe it? Based on studies of fasting, they have coined a new term in biology and medicine called FMD, fasting mimicking diet, and maybe one take-home message. And then my prayers for everybody, all our Muslim brothers and sisters, and all religions across the earth, and wishing them best for Ramadan, which is coming up. It's a very pious time, it's a very religious time, and we pray for everybody's good health and happiness. So that would be my final prayer for the day. So we all know that fasting is very well defined. It's a partial or total abstention of food or a select abstention from prohibited food. This is the best definition and the simplest definition of if you see fasting very carefully and very granularly. And as a potential non-pharmacological intervention, it improves health and longevity. So remember, if you fast more, you live longer. So my first take-home message is that it's a partial and total abstention from all foods or select abstention from prohibited foods. And it is a non-pharmacological intervention to improve health and increase longevity. And it has been subject to numerous scientific investigations. The three most commonly studied fasts are caloric restriction, CR. The second most commonly studied fast is ADF, alternate day fasting. And third is dietary restriction. So from a science standpoint, an evidence-based standpoint, these are the three fasts which are most commonly studied. So caloric restriction is reduction of calories by a certain percentage, typically 20 to 40% ad libitum consumption. And clearly caloric restriction has demonstrated that it improves health and longevity in diverse group of species. It's not just humans. Whether it is a dog, a fruit fly, a nematode, a rodent, a rotifier, a spider, a non-human primate, a zebrafish, the longevity when you fast and restrict calories by 20 to 40% ad libitum, clearly it will improve health and make you live longer. Additionally, caloric restriction delays the onset of following diseases: autoimmune diseases, atherosclerosis, cardiomyopathies, cancer, renal diseases, neurodegenerative diseases, and respiratory diseases. And clearly from a cardiovascular standpoint, we all have seen that when we follow a caloric restricted regimen, there is decreased resting heart rate and blood pressure. There is increase in heart rate variability and improvement in the left ventricular function. And post-exercise recovery of both heart rate and blood pressure is better. And the endothelial function, which is evidenced by flow-mediated vasodilation, is also seen. From a glucoregulatory standpoint, because we are all into the endocrine and diabetes space, from a glucoregulatory standpoint, the caloric restriction has been shown to decrease fasting glucose and insulin levels, improve insulin sensitivity, decrease body fat percentage, and lower the incidence of diabetes. So the first term is caloric restriction. The second term is ADF, alternate day fasting. It is alternating 24-hour periods during feast periods. Faster may consume food ad libitum, and during the fast period, the food consumption is restricted or halted altogether. Water is allowed ad libitum during all times. In the animal alternate day fasting trials, they have reported extended lifespan as well as retardation or altogether prevention of development of many multimorbidities. There is a new term called multimorbidities or comorbidities like cardiovascular disease, kidney disease, cancers, and diabetes. So clearly from the animal data, when you do alternate day fasting, lifespan improves, and clearly the retardation or delay or prevention of development of morbidities like heart disease, cancers, kidney disease, and diabetes is seen. And from these data from animal studies, when you extrapolate it to human health, we have seen beneficial changes in cardiovascular health, decreased heart rate and blood pressure and sympathetic responses, increased heart rate variability, attenuation of post-infarct chronic heart failure, and gender-specific effects in the glucoregulatory space have been seen. Alternate day fasting improved insulin sensitivity in men, but surprisingly have not shown a variable effect in women. So there is some gender, science issue there. It is for researchers who are listening to this talk. This is a good topic to give. Look at gender impact of alternate day fasting on insulin sensitivity, men versus women. Furthermore, glucose tolerance is unchanged in men taking alternate day regimen, but women partaking in the semen regime experience impaired glucose tolerance. So you see there is a differential impact on both insulin sensitivity and glucose tolerance of men and women when it comes to alternate day fasting. And the final term is diet restriction, DR. So we have CR, ADF, and DR. And DR is reduction of one or more component of dietary intake, typically macronutrients, with minimal or no reduction in total caloric intake. Because some research suggested that neither carbohydrate restriction nor lipid restriction extended life. On the other hand, protein restriction increases maximum lifespan by 20%. And this extension of life may be solely due to reduction in amino acid methionine. So see how science has evolved. That if you just restrict probably methionine, you may live longer by 20 years. So these are some interesting tenets. But moving gears from the terminology, let us move to the history of fasting. And clearly we know that religious fasts have a spiritual purpose. Our Muslim brothers and sisters will undergo Ramadan now from the next week. And clearly the primary purpose is spiritual, to meet the God, whether it is Allah, whether it is the various other gods. And it has a potential to have better physical health. So if you look at health effects of religion fasting, there has been a scientific inquiry, particularly in the last 2 decades. And the most well-studied fast on planet Earth is Islamic Ramadan. So Islamic Ramadan is a representative fasting, religious fasting period, which is not only sacrosanct from a religious standpoint and has a lot of reverence and spiritual purpose to meet Allah, but beyond that has also a significant health impact of the population. Beyond that, well-studied fasts, and now some science has come, but not too much, has been from the Greek Orthodox Christianity in the Nativity, the Lent, the Assumption. Those are the 3 fasting periods in the Greek Orthodox Christianity. The Lent is going on now. There is Nativity and there is Assumption. So that is the traditional Greek Orthodox Christianity. And in the biblical, if you read the Bible, there is a Daniel fast. And there are various fasts in Hindu, Jains, and Buddhist. They are either daily, seasonally, like yesterday was Ekadashi, when there is the 4th day of the lunar month. We have Sankashti, that is once a month. Navaratri comes twice a year, which is 9-day fasting. That is the Hindu fast. The Jains also have prolonged fasting times, very structured like Ramadan, but not very well studied. And we are studying them now, both the Hindu fasts and Jain fasts. And Buddhists have their own fasts, which I'll allude to a little later. So these fasts are either daily, seasonal, and they are very heterogeneous. As I said, the most well-structured, well-documented fasting is the Islamic Ramadan. And in the current era, all other fasts need investigation and a scientific inquiry. But clearly, we have data from Ramadan, and that is why we have all meeting today virtually to learn more about the science of fasting and how our people living with diabetes should handle Ramadan better. So in ancient India and Greece, fasting was performed to achieve increased spirituality. And of course, other religions came much later. And this has been adopted in Muslims, the most well-studied, the Christians, the Jews, the Buddhists, the Hindus, and the Jains. You know that I just wanted to give an example of Buddhist fast because, as I said, Bansi told me talk everything but Ramadan. In the 10th century, Soho, a Buddhist monk, fasted for 7 days. At the end of a 1,000-day walk through the mountains of Hizezan from the old imperial palace in Kyoto. And this is to achieve highest priesthood, just like we have the mullahs and the Maulavis in the Islamic sect, or the Hindu priest, or the Jain priests, or the various fathers and sisters in the Catholic movement. There are these monks, Buddhist monks, and if they have to attain priesthood, they have to walk 1,000-day walk and then fast for 7 days. And then they achieve priesthood. So there are different types of fast. They have religious connections. They have spiritual connections. They have mind, body, and health connections. Because remember, fasting is not only just physical, but it is as mental as physical. And again, I reiterate the statement that the most well-documented, well-studied fast is the Islamic fast in Ramadan. A lot of people got on hypothesis. One of the earliest hypotheses last century was Dr. E.H. Devavi. And he said that we all know there are spiritual and psychological impacts of fasting. These are documented since early time. And while health benefits of fasting were only noticed in the 19th century, Dr. Devi was an early supporter of fasting. But he erroneously came with a new hypothesis. Then, this is the 19th century I'm talking about, that every disease that affects mankind develops more or less habitual eating in excess of supply of gastric juices. But what he probably meant that time was if you eat too much and if you don't fast, you will get all diseases. So Devi was the first person in evidence-based era to document that fact. And in 1880s, when Devi was researching, it was a lot of data published that time in evidence-based literature, which you can still search and find out, that several individual trials of prolonged fasting for 30 to 40 days were reported. And we periodically hear news report of survivors lost in sea or mountains for weeks. And these are all descriptive case reports or anecdotes about the physical and metabolic changes in non-obese people. So remember, a 30 to 40-day fast has been documented, and anecdotes and case reports of these have been existing from 1880s. Then there was a term which Follin and Dennis in 1915 introduced, that fasting is therapeutic. And the reason we are doing this fasting symposium is fasting is not only healing spiritually, but also healing health-wise. It is therapeutic, and it is not something new. In 1915, Follin and Dennis said that fasting therapy for obesity was described, and repeated short periods of fasting were proposed as a safe and effective method of weight reduction. So way back in 1915, Follin and Dennis said that fasting is therapeutic. If you fast, it will keep your weight under control, and it's a very safe and effective method of weight control. And many obese followers of Follin and Dennis experienced different regimens of fasting, and they had studied all types of fasting, as much as 100 days or more. And since 1950s, we have data on metabolism during fasting, and most of them have come from the obese population. Now we know obesity is recognized as a disease. There is also politics of fasting, because we know hunger strikes have been a form of protest. People go on fasting and as a protest. And the first examples came in Roman times, because human fasting was documented then in literature as a hunger strike. And we know that in United Kingdom, the suffragettes performed hunger strike in the early 20th century. You know that our famous Indian politician and father of our nation, Gandhiji, fasted 14 times or more, up to 21 days, as a form of political protest against the British. So the longest political fasting from a non-obese person was a case of Terence MacSwiney, the former mayor of Cork in Ireland, who fasted 74 deaths to his death after his arrest during the English-Irish unrest in 1920s. So remember, political fasting has also been documented. It has been a form of protest and hunger strikes, and also has been now studied in the current times. Collectively, what is the scientific message we learn from hunger strikes, religion, or politics of fasting? It appears that we are human beings, and human beings can survive readily without any food for 30 to 40 days, as long as they are properly hydrated. So if you hydrate well, human beings have an ability to survive for 30 to 40 days. So this is the insights we get from the past, whether they are anecdotal, historical, religious, or political. And I have tried to just collate all the literature, because the literature is very huge and vast, and I've tried to encapsulate in the limited time given to me. And that is as far as the science of history, religion, spiritualism, hunger, and politics of fasting is concerned. But we are scientists, and our brain has to have a metabolic pathway when we fast. And we all know that when we fast, we have some clear-cut pathways which we all recognize. We are all human beings. We all recognize this very well, and we know this well. And you can clearly see in this diagrammatic presentation that the mitochondria is at the seat of the fasting biology. And I'm not going to go into details, because there are speakers who are going to tell us how the brain, how the liver, how the white adipose tissue. White adipose tissue stores the lipids. Liver is a powerhouse of glycogen. The muscles have a lot of amino acids, like branch chain amino acids. The brain is the signaler. How all of them interact in the milieu and signal cells, beta cells, and biochemistry to generate a lot of branch chain amino acids, acyl carnitines, and various metabolic shuttles which are there in our body. And I am not going to go into details of that. But when we look at the molecular biology of fasting, what is fasting doing? From a purely neurological perspective, we know the striatum, the hippocampus, and the hypothalamus increase the brain-derived neural factors, the FGF2, the HSP70, the GRP78, the HO1 is increased. The negative cytokines, so these are all positive cytokines or good chemicals, and they decrease the TNF-alpha, IL-1, IL-6, which are the negative chemicals. So the brain and its processing pathways enhance the network plasticity, increase the neurotropic factors, increase stress resistance. There is neurogenesis, mitochondrial biogenesis, and the oxidative stress and inflammation is reduced in fasting. We have data to show from a brainstem reflex standpoint that insulin is downregulated, IGF-1 and leptin is downregulated, ketones are generated as a protective mechanism, adiponectin and ghrelin is modulated and increased. And simultaneously on the liver, you can see the improvement of insulin sensitivity, glycogenolysis, and decrease of IGF-1 levels. At a cardiac level, you can see the downregulation of the heart rate variability going up, blood pressure going down, stress resistance increasing, and the parasympathetic tone increasing. Simultaneously, at a gut level, we can see that the energy intake, inflammation, and cell proliferation goes down. At the adipocyte level, we see lipolysis and ketogenesis, leptin downregulated, adiponectin upregulated, and inflammation reduced. And finally, the most powerful organ after mitochondria in our body is the muscle. And there is increased insulin sensitivity, enhanced anabolism, increased stress resistance, and decreased body temperature. So this is the molecular impact of fasting at a cellular level. So clearly when we are fasting, we have an adaptive response. And that adaptive response will release chaperones, the various UCPs, the superoxide dismutases, the trophic factors, and they will reduce oxidative stress, improve cellular energy metabolism, reduce inflammation and DNA damage, and they will make us resistant to disease. So fasting has a very high science and biology. So now there is a new science which has evolved through metabolomics, because we are now going into insights of fasting. We all know that metabolomics is one of the most rapidly developing domains in chemical biology. And it constitutes a powerful tool to look at biomarkers, to look at metabolites. What are metabolites? These are small organic chemicals or compounds generated by metabolic activity of living organisms, from bacteria to humans. And today we have science, we have metabolomic studies to provide valuable information about metabolic profiles of tissues, of cells, of media, of fluid, of blood. And we know human blood is convenient and useful to analyze. It circulates throughout the body every few minutes, and it has different physiological, paraphysiological states influenced by genetic, epigenetic, physiological, and lifestyle factors. So the metabolomics of human blood permits us to make a comprehensive metabolic signature of various physiological responses, including fasting, and biological effects of drugs, nutrients, and environmental stressors. So when we look at metabolomics of fasting, 44 is the key number. 44 metabolites increase during fasting, which includes antioxidants, organic acids, and signaling related compounds. The non-targeted comprehensive metabolomics of whole blood increases 1/3 of the metabolites after 58 hours of fasting. In addition, the metabolites of energy production, antioxidative metabolites, are identified fasting markers because they can combat oxidative stress resulting from enhanced mitochondrial activity. And the signaling metabolites contribute to remodeling of metabolic homeostasis during fasting, because there has to be a resetting of the biological apparatus. So let us study that. So what happens when there is fasting? There are fasting-induced metabolites, and the gluconeogenesis is shifted. The branched amino acid turnover, the butyrates and the carnitines substitute as energy substrates. And simultaneously, the various urates, ETs, OAs, PPPs, organic acids, purines, pyrimidines, they all reprogram the signals in our body, increase the mitochondrial activity so that there is no reactive oxygen species generated, and a lot of antioxidants are generated. So when we fast, there are fasting-induced metabolites which secrete antioxidants, improve mitochondrial activity, and signal reprogramming occurs inside the human body. And this is similar. Whether it is a yeast, the experiments first came from yeast, then mouse, and then humans. Periodic fasting in yeast will improve stress response and lifespan increases. Periodic fasting mimicking diet, which is the next term which I'm going to introduce, will show adiposity comes down, cancer comes down, inflammatory diseases come down, immune and cognitive rejuvenation occurs, and lifespan improves. And simultaneously in human beings, you can see diabetes, heart disease, cancer, and aging is improved. So clearly, periodic fasting mimicking diet or periodic fasting is beneficial for health, and we have very strong biological and metabolic underpinnings of the same. So we clearly know the fasting mimicking diet, which is now a new term. So it's not just fasting. Fasting is now a prescription in the dietary practices. It improves immune system, reduces and promotes reduction of inflammation like CRP, increases the brain-derived neurotropic factor, decreases glucose, insulin, and insulin-like growth factor, decreases fat tissue, initiates and promotes autophagy, and destroys cancer cell types. So immunity is improved, cancer is downregulated, regulatory pathways improved, brain function is improved, fat is reduced, and inflammation is reduced. And there are frequencies of this fasting mimicking diet. Once per month, once in every 2 months, once in every 3 months, once in every 4 months, once in every 6 months. And there has been a recommendation. So there is also a recommendation of 50. So remember, what we started as a religious fasting might become a science and a therapy today is how history has evolved and mankind has evolved. So remember my final take home message. I know I have maybe overshot my time a little bit and pardon me for that. But fasting is linked to longevity and mitochondrial health. So if you want to improve and maximize your mitochondrial health, you need to ensure that you, not just for religious purposes, but for good living and healthy living, fasting is crucial. Getting lean, having optimal sleep, having daytime sunlight, doing some cardio and resistant training exercises, red light therapy, avoiding excess puffas, and trying to do some weight training and prayer, including yoga, are important. So remember, fasting is one of the most crucial factors today in not only metabolic health, but also mitochondrial. So I think my final take-home message is that we are in a digitalized world. We should do dopamine detox and dopamine fasting, which is 1 hour of digital detox every day. We are all committed to health and happiness. My prayers to all our Muslim brothers and sisters for happy Ramadan fasting. I also want to know that there are fasts in the Christians, which are now happening, which is the Lenten, and in the Hindus, which will come up for 9 days called the Chaitra Navratri. And I thank the opportunity given to me on talking on this unique subject of fasting and mankind, insights from history to biology. Thank you.
Thank you very much, Professor Shashan. As usual, elegant talk, and you have covered a very sensitive area and was documented, evidence-based, and we still need a lot in the matter of fasting. We have gaps that must be fulfilled. We must also, if Ramadan fasting is somewhat not well documented, but it is somewhat a plethora of consensuses, but still we need evidence-based medicine for all types of fasting, especially those now not linked to religious, but also intermittent fasting for regime, for dieting, and so. So thank you very much for this illustrative talk. And I handled the phone to my co-chair to introduce the next speaker. Thank you, Shashank, very much.
Thank you. Thank you.
Thank you, Shashank sir, for an enlightening talk, actually. Reinventing what we are taught ages ago. So in continuing with that line, how to reinvent this fasting, our next speaker is Dr. Rajiv Chawla, and Dr. Rajiv Chawla, sir, again needs no introduction because he is a very well-known figure. He's hold a position at various places, and he is editor-in-chief of RSSDI annual casebook, and he has been past president for RSSDI 2018-19. He was past president of DIPSI very recently. He has authored many books, various oration, various awards, and we will like to utilize this time in learning from him what is fasting actually and physiology behind fasting and what really happens to the body during fasting. Over to you, Dr. Rajiv Chawla, sir. RX team, can you connect?
Just a moment.
No issues. I think there is some technical issue, and just continuing our talk, Dr. Mesbah, the lecture of
Dr. Bharat, can I intervene? There is a recorded talk for Dr. Rajiv Chawla.
I know, but they are just trying to play it. So in the meantime, I just wanted to talk to Dr. Mesbah.
Yes.
Don't you think our ancestors were so very, I would say, wise? They invented all the things, and we are reinventing it.
Yes, I think the matter, this initiative is very important now. And I think we need a lot. So I see a very remarkable sharing from all of our speakers that deals with the aspects of fasting from all sides. So this will create good ideas to come in the future, because we have eminent researchers. They can give a lot of notion, a lot of time to the evidence-based medicine and fasting. And I think this not only be a duty of the diabetologist, but also from the psychological point of view, from the religious point of view, from the spiritual point of view. This will be a lot to be added to this matter. So I think we are now in the era of exploring all the aspects of this very important matter, fasting on all mankind.
Thank you, sir. Very well said. And now we have our recorded session of Dr. Rajiv Chawla, sir, with us. Also, sir was present here for a brief moment, but it is you can hear now.
Good morning, everybody. At the outset, I am extremely thankful to Dr. Bansi, my brother, Dr. Shashank Joshi, for having me in this very prestigious program. And thanks a lot to my chairs, Dr. Sabu and Dr. Kamil. So it's a great pleasure to be part of this meeting. And Dr. Shashank has already discussed about fasting and mankind. So what I'm assigned to do is to discuss the physiology of fasting, what really happens to the body during the fasting phase, especially the prolonged fasting. So let me tell you, when we talk about fasting, it is actually a practice that involves a restriction of food and drinks or maybe nutrients for quite some time. Fasting has been practiced for a variety of reasons, which range from dieting to religious beliefs, most of the time for religious beliefs. And it is also used as a common practice when we are looking for certain lipid markers and certain other hormonal markers in the morning that we need fasting patient for about 8 to 12 hours. So let me take you through the physiology of fasting. Glucose and fat are the body's main source of energy. We understand that. If glucose is not available, of course, glucose is a preferred source of energy. But if glucose is not available, then the body will obviously adjust by using fat without any detrimental health effects. So it all depends. It's a sort of transitions from fed state to the fasted state, which occurs in several stages. So in stage 1, when you are getting an exogenous source of carbohydrates or glucose, body has a normal usage. And in response to that, you have a release of insulin, and you have actually deposition of glycogen into the liver, and also muscles and adipose tissue. Insulin takes it towards the periphery for utilization of the glucose. Moment there is a fasting for about 12 to 16 hours, it is then that you tend to use glycogen as a reserve, which comes from the liver by a mechanism of glycogenolysis. So within 16 hours, most of the source of glycogen gets used. And if you're still fasting and you are in phase 3, when you're fasting for more than 24 hours, it is here that there is a gluconeogenesis, which happens by free fatty acids and amino acids. And it is routed through the liver, that you have generation of glucose from the liver through gluconeogenesis, so as to maintain energy to the brain, especially to RBCs and renal medulla. I must tell you here that brain always uses preferentially the glucose, same as RBCs and renal medulla. And small amount of glucose is also utilized by muscles. But if there is going to be prolonged fasting, lasting for more than 2 to 4 hours. It is the gluconeogenesis coming from hepatic as well as renal route, so as to provide energy to brain as well as RBCs and renal medulla. But if there is going to be a prolonged fasting more than 4 days, so 4 days onwards, it is then that gluconeogenesis happens not only in hepatic to larger extent into the renal, and it is here that then of course all extra sources of energy in the form of free fatty acids and breakdown of amino acid keeps running. And it is here that the protein conservation phase becomes very, very important. So to sum it up, feeding during the meals, insulin levels are increased. Moment there is a post-absorptive phase, and if you're fasting for more than 6 to 24 hours, after beginning the fast, obviously insulin level starts going down, and there is a breakdown of glycogen synthesis, glucose from the liver for usage of energy, and it usually lasts not more than 24 hours. If there is going to be prolonged fasting for up to 2 days, gluconeogenesis starts, I told you, primarily from the liver. And if there is going to be a further fasting for 2 to 4 days, it is here that ketosis or ketones become the source of alternative energy. And if there is going to be a prolonged fasting for more than 5 days, it is here that protein conservation phase becomes very, very important. It is here the high levels of growth hormone maintain muscle mass and lean tissue so that some amount of protein could be conserved. So immediately fasting has an impact in the form of physiological response, and this is going to be in the form of, I told you, there's going to be insulin secretion from pancreatic cell, which will obviously, once there is a fasting more than 12 to 16 hours, insulin level are going to go down. It is here that glucagon secretion increases from alpha cells of the pancreas, which then lead on to glycogenolysis and glycolysis into the skeletal muscle, primarily into the liver for first 24 hours. And then obviously with reduction in insulin levels, with glycogenolysis and glycolysis going on into the muscles, there is going to be a suppression of glycogen synthesis, and plasma epinephrine release also gets enhanced. So subsequently, over next 2 to 4 days, amino acid oxidation in skeletal muscle is increased, I told you, which work as a source of neoglucogenesis. Glycolysis in skeletal muscle also gets increased, and even aminotransferases reactions in skeletal muscle is also increased. Even ALT reactions in liver is increased, and hepatic gluconeogenesis, at least for another 2 to 4 days, is at maximum. And so subsequently because there is a breakdown of amino acid from protein, so there is a urea cycle which gets stimulated, and protein synthesis obviously is going to be reduced. So main organs which are involved physiologically in fasting are actually pancreas and the liver. The most immediate organ affected by fast actually is immediately the pancreas. During times of low plasma glucose, as insulin is going down, so is glucagon, which starts coming up, and it immediately affects the liver, and skeletal muscle is also affected by the glucagon. And after hepatic glycogen stores are depleted, I told you, which happens as early as maximum 24 hours, body then starts using adipose tissue as a source of energy, and the catabolism of skeletal muscle, which is going to provide the body with amino acids which can be further metabolized. So if you look upon this graph during the fasting stage, the impact of different hormones and molecules which are involved in metabolic pathways, that with immediately onset of fasting 6 to 8 hours, there is going to be a reduction in plasma insulin level. You could see that this green graph, plasma insulin level is going to come down, and immediately from alpha cell of the pancreas, there is going to be an increase in plasma glucagon level so as to increase glucose glycolysis from the liver. And subsequently, you will see that as sugar is going to go down, immediately by neoglucogenesis, that liver glycogen is going to use. I told you within 24 hours, most of the stores of glycogen into the liver get depleted. So if you have further fasting after second day onward, it is the ketone bodies which will increase and which will obviously which will be used as an alternate source of energy, as an alternate source of fuel, and even plasma free fatty acid levels will also go up so as to maintain neoglucogenesis, primarily from the liver, also from the renal, and to some extent also from the muscle. So fasting impacts all metabolic pathways of macronutrients, and especially fasting is going to be almost up to 16 to 18 hours. I told you in lipid changes there is going to be an increased fatty acid oxidation into the skeletal muscle. There is going to be an increased hydrolysis of triacylate glycerol and adipose tissue, and there is going to be increased ketone body synthesis in the liver. Similarly, in the protein also, there is going to be an increased gluconeogenesis in the liver by production of amino acids, and this also increased urea synthesis into the liver. And as I told you, there is going to be a increase amino acid oxidation into the skeletal muscles also. Even in the carbohydrate, you will see that there is an increased gluconeogenesis in liver and skeletal muscle, with increased hepatic supply of glucose to extrahepatic tissue so as to maintain glucose levels within the normal range, so as to have a normal euglycemia for the brain, at least for first maybe 16 to 24 hours. And then there is going to be a decreased glycogen synthesis, decreased glucose uptake into skeletal muscle and adipose tissue. And at hormonal levels also, I told you, as there is a reduction in insulin level, there is going to be increased glucagon secretion from the pancreas, increased epinephrine and norepinephrine secretion also happens. So if you talk about physiology of feeding and fasting both in a non-diabetic healthy individual, you will realize that in response to an oral meal, there is going to be an increase in glucose. To simply put it, that increases insulin secretion, which inhibits gluconeogenesis. Actually, there is a more glycogen storage deposition, but moment you have fasting, there is a poor intake of carbohydrate and glucose. So insulin secretion immediately starts going down as early as 6 hours, which stimulates gluconeogenesis and which inhibits glycogen store formation both into adipose tissue as well as into the liver. So if you look upon the changes in feeding pattern and energy intake during very long fast, you will realize in a normal person who is normal feeding, with every meal, major meals like at breakfast, lunch and dinner, there is enough glucose intake and carbohydrate intake which maintains sugars within the normal range. So throughout you will see that sugars are maintained within the normal range in a euglycemic person, and it is always seen that it never exceeds 140 milligram. In long fasting like Ramadan, you could see that since early morning there is going to be a feeding. So our meal, subsequently, then there is going to be a fast of almost 18 hours or 16 hours at least, depending on the time zone. And then iftar meal, there is a first break of the fast and major iftar meal at the dinner time or 6 to 8 p.m. So there is going to be increase in sugar. Throughout the day, sugars are maintained on the lower side. Similarly, another prolonged fast like Jain fast or other Hindu fast, there is going to be a reduction which lasts for more than 24 hours. There is going to be reduction in glucose level, but throughout physiologically levels are maintained anything between 90 to 140 milligram. There is a very good comparison of sleeping and activity pattern, which also happens with prolonged fasting, like in Ramadan and non-Ramadan periods. So if you compare during the non-Ramadan period, you will realize that there is going to be a good 16 to 18 hours awake period, and then there is going to be a good sound sleep of almost 6 to 8 hours, which is an ideal one during the Ramadan hours, because there is going to be an early morning meal which they are going to take in the form of suhar meal. So that obviously happens somewhere close to 4 a.m. So at pre-dawn, they are going to be awake. After that, they might have maybe a sleep of 2 to 3 hours, but you could see that if you see the overall 24-hour pattern, there is going to be an interrupted sleep pattern which will change the circadian rhythm, and subsequently the hormone pattern, as I'll discuss subsequently, will also change. Not only that, with immediate fasting, there is going to be a reduction in fluid levels. There is also going to be immediate some amount of reduction in body weight. And as you keep fasting for good 16 to almost 24 hours, in the early hours, of course, as the fluid intake is very less, there is going to be some amount of body weight reduction by fluid getting lost, and urine in the morning hours will be much lesser. But subsequently, towards the 24 hours, not only sugar levels are physiologically maintained, and there is going to be a good urine output over next 14 to 16 hours. So if you do a CGM profile for healthy individuals before and during Ramadan, you will realize that there is hardly much difference, except that after the iftar meal, there is going to be an increase in glucose level. But as I told you, physiologically, someone who has normal glucose tolerance, this level will never exceed 140 milligram. Even fasting, in spite of 16-hour fasting, body will physiologically maintain sugars anything more than 90 milligrams so as to provide enough calories to the brain. So another thing what happens with prolonged fasting is that you could see that after day 7 of Ramadan, there is also going to be change in cortisol circadian rhythm during the Ramadan. So changes to sleep and food impact also change the circadian rhythm. So what happens is that cortisol level, which in a normal person are highest in the early morning hours, tend to be lower in patient those who are already fasting for more than 7 days. And actually there is an increase in cortisol levels towards the late evening hours. So let's see what happens in a patient with type 2 diabetes or type 1 diabetes, because then obviously the physiology is going to change. So let's see if there is not going to be any food intake in someone who has type 1 and type 2 diabetes. Obviously, especially if you are talking about a type 2 diabetes obese patient, they have already had either severe insulin resistance or insulin secretion is already on the lower side. So that actually secretes, increases gluconeogenesis and sets in ketogenesis much early, especially in type 1 diabetes patient. So all type 1 diabetes patients with prolonged fasting are not only at a greater risk for developing ketogenesis, even type 2 diabetes patient, by virtue of having low insulin levels or maybe severe insulin resistance, the effective levels are not very good. So there is a blunting of insulin levels in these patients. So with prolonged fasting, they are going to maintain their sugars through neoglucogenesis from the liver. And I told you, second day onwards, there is going to be ketogenesis. Ketone bodies are going to be alternate source of fuel. So they are also at a little greater risk for developing ketoacidosis, even if they are sort of stable otherwise prior to the fast. So mean glucose monitoring CGM profiles from people with diabetes before and during Ramadan, you could see that immediately after iftar meal, there is going to be an increase in sugar level in these patients. Not only that, these patients are also at a greater risk for developing dehydration and little high risk for thrombosis, because all type 2 diabetes patient or type 1 diabetes patient, those who are fasting for long, especially in hot and humid climates, they are at a greater risk of dehydration and they are already having a prothrombotic state, especially with hyperglycemia, they are at a greater risk for developing thrombosis. So not only hypovolemia, but orthostatic hypotension at times, especially in elderly frail patient, might happen. But it has been seen that hospitalization because of coronary events or strokes have not been really demonstrated in these patients as a result of fasting. So the perceived benefits of fasting are that not only there is going to be an improvement in the endocrine system, glucose tolerance is going to be better, beta cell survival will improve. In the reproductive system, there could be a better reproductive longevity, oxidative stress goes down, markers of inflammation, total cholesterol, LDL goes down, HDL level comes up. Even in the nervous system, cognitive benefits happen, cognitive memory improves, and hippocampal neurogenesis also happens. In stem cells, regeneration also happens, which contributes towards better immune response during the phases of fasting. That is why religious fasts are practiced all across the globe. Not only that, fatty acid oxidation increases, high density lipoprotein, I told you, increase, C-reactive protein goes down, cognitive function improves, and pancreas, in the pancreas also, not only there is a reduced beta cell apoptosis and glucagon secretion goes up, even in the gut it has been seen with prolonged fasting, gut microbiota richness also improves, and muscle also tend to have much better fitness. So fasting can actually mediate inter-organ communication. That's a very complex slide. I'll put it very, very simple. There is a better communication between the liver and the brain into the beta cells. All the markers of inflammation are going to go down. There is going to be a browning of fat and improved thermogenesis, which will improve over our chemostaxis also. Not only that, there could be a better regeneration of the cells also, whether you are talking about, I told you, reduced beta cell apoptosis, even as a result of fasting, markers of inflammation will go down, and neuronal response also improves, stem cell response also improves. So immunity levels and oligodendrocyte regeneration also happens, and there is going to be a better differentiation, and this also improves muscle differentiation also. So fasting actually protects the body from all toxic agents. Maybe if patient is undergoing chemotherapy and if patient follows repeated fast, there is going to be an improvement into their immunity response. Also, therapeutic response to those chemotherapeutic drugs will be much better. It is possibly because of synergistic effect with metformin, with other antioxidants. It also could be because of strengthening of host immunity. It also could be because of enhanced chemosensitivity. I told you, overall macrophage response becomes much better and side effects of the drugs are much lesser. So it has been seen that prolonged fasting actually improves overall aging through nutrient missensing, epigenetic alterations happen, stem cell, I told you, response is much better, mitochondrial dysfunction gets corrected, and even genomic instability also gets corrected. So overall aging gets sort of checked if you are doing a regular fasting. So to conclude, a prolonged fasting like in the month of Ramadan or other Hindu fast can precipitate dramatic changes in meal schedules, in fluid intake, sleep pattern changes, and even circadian rhythm changes, which changes the hormone response also. It has a very strong impact on hormonal levels and their normal rhythms. A shift in cortisol circadian rhythm towards reduction in cortisol level in the morning to evening happens. There is a reduction in morning adiponectin levels, large increase in morning leptin levels, and reduction from morning to evening growth hormone levels also happens, and there is a modest reduction in testosterone also, and all these have a very positive impact even on gut microbiota. So all fasts, may it be Ramadan or Hindu fast, can induce epigenetic changes to genes. There's going to be a favorable physiological changes, decreased body weight, and favorable effects on the lipids are going to be there. So people with diabetes, particularly those with type 1, must seek an advice before going for a prolonged fasting, and it has to be a shared decision between a patient, physician, and maybe a religious advisor whether this fast is going to be absolutely well tolerated by the patient. The patient is having euglycemia, well controlled on drugs, or maybe type 1 who is well controlled on insulin, then there is no harm doing in prolonged fasting. Thank you very much. I'll stop sharing here and will stand by for any question answers. Thank you very much.
Thank you, Rajiv sir. Yes, sir, please go ahead, Dr. Mesbah.
Thank you very much, Dr. Chawla. This is a very illustrative talk, but my comment is, although all these beneficial effects of Ramadan fasting, the disruption of circadian rhythm due to loss of the sleep cycle can lessen the benefits and make sometimes the matter is not fruitful.
RX team, can you mute?
You hear me? You hear me, Dr. Chawla? About the circadian disruption. The circadian disruption due to altering of the sleep times can lessen all these benefits, and also individualization. Your bottom line that this must be advised between the physician, the patient, people with diabetes, and the religious. Is very important to get this in concern to get these benefits, but all these benefits must be augmented if the circadian cycle is not disrupted.
I think very true. It's a very good comment that longer is going to be the duration of fasting, more are the chances that circadian rhythm will change, and there is going to be change in the hormonal release pattern also. As I said in my presentation, growth hormone pattern will change, so will leptin and adiponectin expression will change, and cortisol level, instead of being highest in the morning, will be much higher towards the evening. So I think that is what is going to be the normal physiology. But in all those patients, those who are type 2 diabetes, long-standing patient, or type 1 diabetes patient where you might have an autonomic neuropathic component significantly already set in, there the disruption of hormonal change or circadian rhythm may be much more abnormal, much more blunted actually. But in all euglycemic patient and normal glucose tolerance patient, definitely with the prolonged fasting like Ramadan or Jain fast or alternate day fasting, there is going to be a positive change in circadian rhythm.
Thank you very much.
Thank you, sir. A wonderful talk, actually. Wonderful talk indeed, talking about the physiological effects of fasting. So moving further, we would like to see it is so much beneficial to have a patient go on fast, but to show light on risk stratification of fasting in person with diabetes, we have none other than Dr. Krishna Seshadri with us, who is a renowned endocrinologist consultant, Chennai Diabetes Endocrine Clinic. And he is a professor in endocrinology and medical education, board member of Sri Balaji Vidyapeeth and MGM Health. He has received various awards, associate editor of Journal of Diabetes in Developing Countries, and editor-in-chief of Thyroid Research in Practice. So over to you, Dr. Krishna Seshadri, for the session.
Hello, and thank you for asking me to be part of this very important and prestigious meeting. I'll speak about the stratification of fasting, and for the purposes of clarity, I will stay as close to the IDFDA recommendations for this risk stratification as possible. While most of what I would speak would apply to the Ramadan fasting, I will, wherever possible, make associations and comments about the other kinds of fasting that is being done. As we all know, that the main risks associated in fasting with people with diabetes are hypoglycemia and hyperglycemia, dehydration, and diabetic ketoacidosis. It's interesting to understand that Ramadan fasting should be really classified as the Ramadan intermittent fasting from a clinical perspective. We should know that there are other intermittent fasting protocols, which is a time-restricted eating, which is a daily short-term fast. Again, the Ramadan fasting can come into it if closer to the tropics at least. The alternate day fasting, which is again an ad libitum feed with a day of low calorie consumption. There are modified alternate day fastings. Then, of course, there is periodic fasting, which is complete fasting for 1 to 2 days per week, which many people do now. And then there is, of course, modified periodic fasting. The interest in fasting, of course, has increased with animal data about longevity and, of course, other benefits that people have perceived over a period of time. Some of these are part of clinical trials that include caloric restrictions that look at anywhere between 10 to 40%. Alternate day fasting, periodic fasting, time-restricted fasting, all have some amount of data to support them. What we don't know much about is long-term fasting, other than studies that were done in the 70s, 80s, and 90s. And of course, now we have calorie restriction mimicking diets where there is modification of the diet that mimics a fasting diet, that looks at macronutrient balance, ketogenic diets, etc. This is the data that I was alluding to that showed that, for example, when bacteria or yeast or C. elegans were moved from a high-calorie environment to a low-calorie or a food-restricted or a calorie-restricted environment, their longevity increased. And we do not have human data to support it. This has spawned an industry of fasting-based diets, adoption of fasting in people's day-to-day lifestyle, and that include diabetics with whom that we are most concerned today. Also remember that fasting has been an integral part of religion. The Catholic religion talks about Lent. Islam, of course, is famous for the Ramadan fasting. Some of the most difficult fasting routines are part of Jainism. The Hindu religion, to which I belong and many of my countrymen do, has fasting that spans anywhere between twice a month to some people who do up to 8 to 10 days a month. And thankfully, the fasting is sort of variable and dependent on your ability, which the word that is used in Sanskrit is called yada shakti. So it could be anywhere between nirjala, where not even water is consumed for a period of 12 to 36 hours. It could be sajala with water. Then, of course, it could be nirahara with no food, or alpahara, small amount of food, or falahara. And coincidentally, we are in also a season of Hindu fasting, starting with there are 2 Navaratris a year, Vasanta Navaratri and Sharan Navaratri. And so the Vasanta Navaratri and Sharan Navaratri are all 9 days or 9 nights of fasting. And people do fasting either without water or with water, or of course with fruit, with modest diet, of course, with some fasting and a lot of diet. And these have changed over a time. For example, people would say that in the olden days, people would lose weight after Ramadan, but you would see that many patients actually come with a weight gain and worsening glucose after Ramadan. So modern day has changed many of the religious fastings. So how do you stratify this? First is, of course, age. More than age, I would add the word frailty here. We need to start thinking about frailty indices. The frailer you are, the greater is your risk when you fast. The diabetes that you have, the duration, glycemic status are important. Are there complications? Do you have frequent hypoglycemia? Have you had diabetic ketoacidosis? Have you had stroke, thrombosis? Pregnancy, of course, for many of us is a no-no. And cognitive function, whether you're able to maintain the rigors that come with a fast and, of course, the monitoring and others. Do you do physical labor that requires a caloric content? What about your previous fasting experiences? Has it been good? Has it been uneventful? And the hours, for example, in religious fasting, if a person in Chennai, for instance, probably have less than 12 hours of fasting during Ramadan, but in Sweden that would really go up to 20 hours. So, and we use the Ramadan example for any kind of fasting simply because it has been the most studied. So the length of the fasting hours, as I said, are you closer to the tropics where it's a fixed length, or are you in the extremes? The season, are you in the northern hemisphere, the southern hemisphere? What is the weather? What is the geographic location? What are the social changes in your area? And of course, past experiences. When it comes to diet, what is the kind of diabetes that you have? Type 1s suffer a lot more, but they are a little more predictable. What is the duration of diabetes? The longer you have, the greater the chances of complications. Do you have nephropathy, or do you have a cardiovascular illness where hypoglycemia can put you into risk? What kind of therapies do you take? Are you on insulin when complexity increases? Are you on a DPP-4 inhibitor where the risk of hypoglycemia is much low? Or are you in between the sulfonylurea where the risk of hypoglycemia is significantly higher? Are you going to the fast with good control, or do you have bad control? Are you hyperglycemic frequently? Or more importantly, can you recognize the symptoms of hypoglycemia? Also important, can you get to a doctor or a nurse or a clinic if you need help? On top of this, we have factors concerning the individual. Are you younger or older? Women tolerate some of these fasts well, some of them don't. What kind of work do you require to be outdoors? Can you be indoors? What is your meal pattern? Do you exercise during fasting? Of course, what is your motivation? And of course, personal preferences. The IDFDA risk categories are very useful. They are very pragmatic and based on some degree of evidence. And they look at patients who fast during Ramadan, and I think we could use these for other kinds of fasting. So they talk about this. One, the category 1 is the people who should not fast. That is those who have had severe hypoglycemia, those who have diabetic ketoacidosis or hyperosmolar coma, recurrent hypoglycemia, poorly controlled type 1 diabetes, any recent acute illnesses, and a pregnancy with pre-existing diabetes or gestational diabetes treated with insulin, people on chronic dialysis of CKD 4 and 5, advanced macrovascular complications or old age with ill health, right? So in this group, there are some people who would still exercise their judgment that we do want to fast. If they do, at least they should be educated about the risks, have access to the healthcare, must be tried to convince that they should be monitoring them, preferably, use a more modern way of monitoring that includes, an AGP, and give recommendations for medications. One of the simplest ways is to sort of reverse the schedule so that they start taking their medications at the break of the fast. And a commitment that if they have complications, that they will break their fast and stop it if they have worsening medical conditions. I think we can't impose our values on our patients, but we could negotiate some ways by which self-harm is reduced. The category 2 is a high risk which should still not fast, right? But these include diabetes with sustained poor glycemic control, preferably type 1 diabetes who are well controlled should also not fast. Well controlled type 2 diabetes on multiple or complex insulin regimens should not be fasting. Pregnant type 2 diabetes or gestational diabetes should not be fasting. Anyone more than the KGIO stage 3 should not be fasting. If you have stable macrovascular complications, you still should not be fasting. Comorbid conditions with additional risk factors, intense physical labor, and those drugs that can affect cognitive function. Again, the same negotiation if they insist on fasting. Education is the key, empowerment is the key, access to healthcare is the key, monitoring is the key, and a negotiated agreement that you can try it if you want to, if you have to, but you should be prepared to stop it if required. For these people can exercise their judgment to fast. These include those on just lifestyle therapy, on drugs that don't increase the amount of hyperglycemia, those are on incretin-based therapy, SGLT2 inhibitors, and of course a single basal insulin. Again, one of the simple things that we do in our practice, and I'm sure we can discuss this during the therapy sessions, is to just reverse, especially in Ramadan and other intermittent fasting, is to just reverse their schedule, especially if they're eating through the night. And the sleep structure education, again, self-monitoring is very important, or just a medication as recommended. One of the nice ways that things that again that our IDF guidelines have suggested is a simple risk score that I think is worth using for anyone undergoing fasting that includes other religious fasting such as Navratri. It has several elements that looks at, so diabetes and its duration. If you have type 1 diabetes, there is 1 point. The duration of more than 10 years, 1 point. Presence of hypoglycemia is graded from 1 to 6.5. Hypoglycemia unawareness getting the highest score. Level of hypoglycemia, if they're uncontrolled, it's highest with less than 7.50. Unstable or stable complications. Low EGFR has the highest risk score. Pregnancy with or without targets, and of course frailty and impaired cognitive function. Type of treatment, multiple insulin regimens, mixed regimens having higher scores. Sulfonylureas, especially glibenclamide, has a single point. Self-monitoring is indicated. History of acute complications. Physical labor. Previous fasting experience that has been negative or positive. And the duration of fasting was more than 16 hours. That's because the change in the breakdown of lipolysis over 16 hours. If the patient is more than 6 hours, it is high risk. These are very high risk of developing complications when fasting during Ramadan and Navratri. They should not fast, and if they insist, they should have care and monitoring, as we talked about. Those who are at moderate risk, if many of these patients will choose to fast anyway, it's a personal decision, but But while we agree with their decision, we should not tell them that we should continue to engage these people, and at least a decision that to when to stop fasting and when to recharge should be there. People with low risk are generally okay. However, if there's a change in circumstances, the risk scoring changes, and therefore this is an annual risk stratification that needs to be done. There's a real life data from Bangladesh again that showed that patients still wanted to fast despite having a moderate to high risk. But despite knowing these risk, patients insisted on fasting. Again, they are exercising a value judgment. While we may disagree with what they choose to, we cannot give up on them, and they need to be saying, "Look, yes, I understand. I would really be happy if you can't. If you think that I should talk to your spiritual guide, I'm happy to do it. But then if you still want to do it, let us know if there is a problem. Monitor yourself. We are there for you. Despite, irrespective of your decision, we are there for you." I think that is the approach that healthcare providers should be taking. Patients who are stable, patients free of deteriorating complications can fast. This is from Pakistan Medical Association journal. So to summarize, for any fasting, whether it's Ramadan or do a risk assessment. I think the Ramadan risk assessment is very, very applicable for the Navratri. Focus the education, make sure there's a healthy diet and physical lifestyle. We do a frequent monitoring. The patient can afford CGM or AGP. Choose medications that are of low risk for hypoglycemia, and if necessary, reverse the treatment regimen, and we'll talk about it, I guess, in the treatment section. There are some digital tools. This is a Ramadan risk scoring that's available on Google Play. This is a Ramadan risk rate that is also available on both Google Play and Androids. And patients can self-use it. Doctors can use it in the clinic. These are very, very useful. I hope this was useful for you. I'm happy to take any questions. Thank you again for this wonderful opportunity. And thanks for having me part of this exceptional meeting. Thank you so much.
Thank you very much. But one comment for the risk stratification score. The new score is just a consensus. It is not based on randomized controlled trials. And I think to put figures or numbers like this is not very wise. The old stratification of the high or very high and moderate and low seems to be more close to the reality, especially after assessment of the and individualization of the risk of the patient for fasting. So my point of view is that we need to validate this risk score by randomized controlled trials, and we link it to the old one, which is more broad and can be more informative and more safe, because simply you cannot say that diabetes for type 2 diabetes for 10 years more risky than type 2 diabetes for 9 years per se. This will take 0, this will take 1. And also, how can we stratify those or at risk as pregnant, as type 1 diabetes, those on multiple dosage of insulin, and those with renal impairment per se. So I think just to put this score, and if this score is less than 4 or 3, the fasting is obligatory, not obligatory. Fasting is not obligatory for diabetic patient, because even in Islam, we have this as a disease, and the disease is exempted from fasting, whatever the degree. So this is my comment.
An excellent talk, Krishna sir. I just had a question, because many times even the patient is not able to gauge whether he is culprit or he is falling into hypoglycemia or some adverse event during the fasting period. So what is the best advice, one advice which you want to give to patient regarding this risk stratification? Just to keep it simple, because it is a little complex for the patient to understand. Sir, please unmute yourself.
Can you hear me now?
Yes.
See, the score is only a substitute for your judgment, right? Your clinical judgment and the way you work with your patient is probably the best way to do this, and it has to be individualized. The simplest rule is, look, if you don't have to fast, don't fast. But if you feel strongly about it, make sure that we have planned this, that we have looked at your information, that we have assessed your comorbidities. We have both agreed that it's all right for you to fast, but knowing that these are the red flags, increase the monitoring. If you have access to a more modern method of monitoring, do it. And if there's any problem, stop and inform me. I think at this point of time, this is the amount of a lot of common sense actually works into it, more than just being rigidly following, as Dr. Kamel talked about, some kind of a stratification score. Individualization of the patient, working with them, and telling them, look, we are there to help you. I think that's what I would do, Bharat.
Very well said, sir. Thank you. Thanks for enlightening talk. Thank you. Over to you, Dr. Mesbah.
Okay, our next speaker, my dear friend, Yaqub Ahmadani. Dr. Yaqub is a consultant dietitian, and he is a leader of diabetes study group in Pakistan since a lot of time, and we are sharing activities together. And he is now the co-chair for the IDF Diabetes and Fasting Task Force that I am honored to be a member with him. And Dr. Yaqub has a very remarkable experience in diabetes and fasting, especially in Ramadan. And he is one who is always going to the reality, and they have his studies and his group approaching the what is going in reality in Ramadan. So Dr. Yaqub Ahmadani, I think we will enjoy your talk about fasting, and we will see now how elegant it will be. Dr. Yaqub, the floor is yours.
Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillahir Rahmanir Rahim. Can you hear me?
Yes.
Okay. So I would like to thank, first of all, to the organizer, Dr. Banshi Shabu, that he has given me this opportunity to talk on this very important subject, which is very favorite to me. And much of the subject has been covered by the previous speaker, and I think I will just revise what he has said. Pre-fasting assessment, assessing the person with diabetes before plan of fasting. So, of course, the points have been discovered, but just a repetition, the prevalence of diabetes is increasing in the Muslim population, and a significant number of people fast.
Yaqub, we have no PowerPoint.
You
are not sharing your presentation.
Okay.
Please share the presentation.
Sir, yes.
You see? Can you see now?
Not yet.
Can you see?
Not yet.
Can you see the screen now?
No, just a blank screen.
Okay.
Yes, now.
Okay, you can see now.
Yes, please do it as play the screen. Play the PowerPoint. Full screen.
Full screen, okay. You can see the icon here, full screen.
Slideshow. Turn to the slideshow.
So the icon is not here, so I cannot.
Okay. Anyhow, we can follow this.
Sir, in upside, the button is from current slide. Please press the button.
Okay.
Yes, now okay. Yes, go on.
Yeah,
yes.
it's done.
So the prevalence of diabetes is increasing among the Muslim population, and a significant number of people fast during the month of Ramadan. Around 150 million Muslims worldwide with diabetes are there, and around 116 million of people choose to fast during Ramadan. And as you can see that against the global rise in diabetes of 46%, the rise in MENA region, the sub-Saharan Africa and Southeast Asia, the rise is enormous. And these are Muslim-dominated areas. So these people, they have the obligations to fast. And so it's a number, the people are in millions, and we have to talk about this very important topic. Assessing awareness level of our patient and the risk assessment is an essential part of all diabetes and Ramadan recommendations. And for this purpose, we always invite our patients and ask them to come before Ramadan, that is 6 to 8 weeks before Ramadan. That is very important in order to make their assessment whether they can fast safely or not, or what are the risk factors in them. So all individuals are asked to see their physician 6 to 8 weeks before Ramadan. And this visit is for the assessment and for the education of our patients. So assessing the risk factors, first of all, the type of diabetes. So people with type 1 diabetes as compared to type 2 diabetes are graded as a high-risk group, and they should be given proper care and proper education if they want to fast during Ramadan. So, but not all patients with type 1 diabetes have similar risks. Some people may be having low risk, some people may be having more risk. So this is the point that we have to first see what type of diabetes they have, and whether what are the other risk factors, the risk indicators in people with type 1 diabetes. So people who have good awareness about hypoglycemia, people who have good glycemic control before Ramadan, and people who have knowledge and willingness to monitor the sugars throughout Ramadan, and they have the ability to adjust their medication as needed, they can, under medical supervision, fast safely during Ramadan. On the other hand, people with type 1 diabetes, if they have a history of recurrent hypoglycemia, if they have hypoglycemia unawareness, if they have poor diabetes control, and if they have brittle diabetes, they are non-compliant to medical treatment, or if they are unwilling or unable to monitor their blood glucose, they are advised not to fast. So type of diabetes is one of the risk factors we have to see. And regarding hypoglycemia risk, we can have an assessment of hypoglycemia risk by asking them to fast during the preceding months before Ramadan, like in Shaban or in Rajab, they can fast for 2 or 3 days and to see whether they can safely fast without any hypoglycemia risk. So this is one way of assessing people of whether they develop hypoglycemia during the fast or not. Age and duration of diabetes is again important. Very young age and very old age, people can have problems. So these group of people, age, we need to be, they need to be educated more and taken care of more, and they have to be, if they want to fast, they are to be under medical supervision. Of course, with duration of diabetes, the more you have years of diabetes, poor control, you can have more comorbidities along with diabetes, and that can give you more risk. So it's important that the duration of diabetes, if it is more, you may be having more comorbidities. So they are to be educated more and taken care of more. There are variability indicators like people who are weak, who are slow walking speed, who have low physical activity. They're reporting exhaustion or unintentional weight loss. These are the frailty index indicators, and we have to take into consideration by assessing these patients for fasting. Occupational history, it's important that people who are doing physical labor, doing outside work under the sun, physical labor, they are more prone to get complications as compared to those who are working under in the inside area. Similarly, the pregnancy, while assessing these patients for fasting, we have to look into this point that in the reproductive age group, females, if they are pregnant or not, because pregnancy with diabetes, you require a lot of monitoring, and you require certain tight targets. In order to maintain tight targets during pregnancy, these are to be assessed, and many a times we advise them not to fast while they are pregnant. History of recent acute complications like hyperglycemic complications or hypoglycemic complications, or DKA, history of hyperglycemic hyperosmolar state, or recent hospitalization for any reason. These patients are to be assessed and advised accordingly. Chronic complications in our patients, very important. The two more important complications, the most important complications are CKD and CVD. Like chronic kidney disease, we have to assess their kidney functions, their eGFRs, what are the levels, and then we can advise them according to the renal status of our patient. And if they are stable, then they can fast safely. If they are not stable and the eGFRs are changing and if they are in the volume depleted or over hydrated conditions, then they can have problems. So CKD is important. The other thing is the CVD, whether they have cardiac disease or not, whether they are symptomatic or they are not symptomatic, whether they have chest pain, shortness of breath, or orthopnea, things like that. So we have to take into consideration the history of cardiac symptoms and whether they are already known cases of ischemic heart disease or other cardiac disease. And then we have to look into the stability of that condition, whether they are symptomatic or they are stable enough. With stable cardiac disease, people with diabetes can fast. There are several studies on CKD and on CVD during Ramadan, and people have fasted. But again, as was discussed earlier, that it has to be individualized. Each patient should be seen as an individual, and the risk of fasting must be assessed individually. Previous Ramadan experience is very important. If a person has fasted in the previous Ramadan without any complications, then this person is likely to be can safely fast during this Ramadan. Of course, during this year, if he has developed some complication like CKD or CVD or any other complication, then you have to reassess this person. If there are no complications added to his profile, then if he has fasted safely during his last Ramadan, maybe this time also he can fast safely. The glycemic control is important, and we do, for assessment purposes, before Ramadan, we have to check their HbA1cs, and if they are well controlled, they can safely fast during Ramadan. And if they are not so well controlled, they may get some problems. Although this researchers have shown that people with poor glycemic control have good control after Ramadan. The HbA1c improved, and the meta-analysis on pre-Ramadan education have shown that glycemic control improves with education, with medical adjustments, with dietary precautions, or the control actually improves during Ramadan. Medication history is again, for assessment purposes, you have to look into what medications your patient is taking, and of course, certain medications give you more risk of hypoglycemia as compared to the other. And we have to, especially when they are taking sulfonylureas or like the SGLT2 inhibitors we have published recently are safe to be used during Ramadan, but there are certain people who should be taken care more seriously, should be seen, like elderly people, people with renal impairment, people with hypotensive tendencies, those with the risk of dehydration, and those who are taking diuretics. These patients should be cautiously seen, and SGLT2 inhibitors can cause problems in these sort of patients, but otherwise it is safe to be used during Ramadan. So the drugs are important to be seen, what drugs they are on. And regarding sulfonylureas, if they are taking sulfonylureas, many of our patients, because of cost, they are taking these cheaper drugs like sulfonylureas. And among sulfonylureas, all sulfonylureas are not similar, and then we have to look into the better, the second generation sulfonylureas like glimepiride or gliclazide as compared to glibenclamide, which is dangerous because it can cause severe prolonged hypoglycemia. So for Ramadan purposes, we advise people not to use glibenclamide, but they can use glimepiride or gliclazide, of course, with dose adjustment and timing adjustments. So this is important. And of course, insulin is another drug which can give you hypoglycemia, and you have to adjust the doses. And of course, the basal insulin as compared to mixtures are better during Ramadan, and of course, analogs are better than human insulin. So we need to, before Ramadan, if they are coming, we can switch them to better insulins in order to have safe fasting. There are certain misconceptions, and we have Professor Shabeen Naz from Pakistan has published one data, and she is among the audience as well. So she has published many years back that there are misconceptions among our patients about needle break, about insulin use, about dose of insulin, about physical activity and diet during Ramadan. So we have to look into that factor as well. And while assessing these patients for fasting, we need to know whether they have misconceptions or not. And if they have misconceptions, we have to remove those misconceptions so they may be able to fast safely. So we need to know whether they know about Ramadan-specific diabetes education, like risk of fasting, if they have any risk factors, if they know about glucose monitoring, about diet, about fluids, about physical activity and exercise, about medication adjustment during Ramadan, and when they have to break the fast, the symptoms of hypo and hyperglycemia. So this has to be assessed. Also, the dietary assessment, people don't know about what sort of eating they should be doing during Ramadan. At sahur and at iftar, they overdo at iftar and they underdo sometimes at sahur. So we have to assess whether they know about what to eat and what not to eat while assessing these patients. So the pre-Ramadan visit is for the purpose of assessing the patients for the risk of fasting, and doing all the right things that we have discussed already. And as a result of this, and the other purpose of pre-Ramzan visit is to educate our patients about these factors. So it has been shown that with pre-Ramazan focused education can have greater glycemic control, you can have better self-monitoring of glucose and treatment, and you can have sustained motivation in adhering to advice. So, and they have this thing throughout their life. This is 1 month where they can learn self-control. They can learn how to manage their diabetes effectively. I thank you for your attention.
Thank you, Akub. As usual, you have a very informative talk about especially pre-assessment and education and awareness and individualization of the assessment. And it make me very happy to listen to you while insist that those who are not willing to monitoring their blood sugar and they have hypoglycemic risk, especially if there is an awareness, must be exempted from fasting. But although our patients insist to fast, we cannot do nothing except to help them by good advice and strict supervision. So we'll come now to the end of our session. I was very honorable to listen to 4 eminent speakers, and before this to share this session with Dr. Sabo and our first speaker was Dr. Shashan. He's talked about the mankind and fasting and donating that fasting is a healthy maneuver practiced by the people since all the years and on the whole spectrum of peoples, and even non-religious fasting now is going on. And followed by a very elegant talk about the physiological changes in fasting, noting that circadian rhythm must be respected to get the benefits from fasting, because the circadian change of hormonal release will be disastrous and lessen or decrease the benefits of fasting that all are documented. Then we will go to the risk stratification and what is the old, what is the new, and we agreed to have individualization and risk stratification accordingly, and the advice must be shared by both physician, patient, and religious peoples. And at last it was the presentation of Yaqub, and he focused about the Ramadan pre-assessment and education and monitoring. By this, I thank very much the organizer. I thank the Southeast Asia Society and our desk also society. Thank Banshi, thank Azad, thank Abdul Basit, and thank my co-chair Dr. Sabo for this elegant session. And the phone is you, Dr. Sabo.
Thank you, sir. Thanks a lot, first of all, for summarizing it up for the audience so very well. I would like to thank, first of all, our 4 speakers, Dr. Shashank Joshi, Dr. Rajiv Chawla, sir, Dr. Krishna Sheshadri, and Dr. Yaqub Ahmadani for wonderful talk regarding all about fasting. And I would like to thank Southeast Asia IDF for giving me this opportunity over here, my elder brother, Dr. Banshi Sabu, Dr. Azad Khan, sir, and Dr. Abdul Basit, sir, for setting up this platform so very well for this very important topic. So we will close this session, and I would like to invite Dr. Purvi Chawla ma'am and Dr. Amit Kumar Dey for taking proceedings from here. Thank you.
Thank you very much, Dr. Bharat Sabu, and to all the chairpersons and speakers of the previous session for setting the to this webinar on diabetes and fasting. So we will now move on to the next session, where we will be discussing about the modifications which will be required during fasting in terms of diet, physical activity, and the medications. And to start with the first session, I would like to invite Ms. Cheryl Salas. She's a registered dietitian, certified diabetes educator, and an insulin pump specialist. She's also a founder of Nurture Health Solutions with a rich experience of over 22 years in the field of dietetics and diabetes education. She's an advisory council member of PAD, recipient of Alan Drash Fellowship in 2021. She's been an author and co-author in various national as well as international publications. She has also been a speaker at several national and international conferences and has publications in peer-reviewed journals, presented papers at various national and international conferences, and won the first prize at IDACon 2012 and IAOH 2016 for the best oral paper presentation. So with her extensive experience, I would like to invite her for the first talk. Ms. Cheryl Salas, please.
Congratulations and welcome, Cheryl.
You're on mute. Please go ahead.
Can you see my screen?
Yes, yes, yes.
Okay, thank you so much, Dr. Amit Kumar, for that kind introduction. And it's really a pleasure. And I've been listening to the session since morning, and there's been such interesting deliberations on this very, very important topic. And the topic given to me is culinary modifications in fasting. And I think when it comes to fasting or feasting, food becomes a very, very important and integral part of the entire thing. And therefore, I think a session on this is so pertinent. And thank you so much to Dr. Sabu and the entire team for giving this topic equal importance. So one is, if you look at fasting, it is a ubiquitous religious practice. And if you look, there are so many different kinds of fast, be it from any community the person is from. You have the Ramadan fast, which is going to begin. You have the Lent, which is going on. You have Ratta, you have Chovihar, you have Ekasana, Vyasana, Karva Chauth, Ambil, Vattapurnima, and Ekadashi, and so many more fasts which are there. And the Hindu religious text, which is the Smritis, sanctify fasting as a way of life. And the Smritis also state the need for Yata Shakti for fasting, implying that the rigorous forms of fasting are for the able-bodied, and those who are infirm, ill, need not fast and do only symbolic observations. Now, this is again by the Quran. Why, and I have been working very closely with, people from the Islamic community, and we see that, they, when it comes to fasting, they're extremely diligent about it. And it is basically a self-discipline to acquire self-control and sacrificing one meal for the poor. And in fact, even water is not consumed during the fasting period. And this is one of the most strictest forms of fasting that we have seen in any religion. Now, if you look at the Ramadan fast, again, it is fasting from sunrise to sunset in the evening without any food and drink. There's Sehri, which is also known as Suhoor, which is the pre-dawn meal. Finish the meal by around 4:15 a.m. Iftar is breaking of the fast, which is at sunset. And iftar should be light, breaking one's fast with dates, as well as praying before iftar are both mentioned in the Hadith literature. Sunset prayer, then there's dinner and Taraweeh, which is again a special prayer after food, which is between 8:30 p.m. to 10:30 p.m. Again, this needs to be kept in mind, especially when we're looking at our patients. Monitoring becomes very important because there's a lot of physical activity as well during the prayer itself, and therefore it's important to look for hypoglycemia during this time. Fasting during Ramadan, the principles, it is one of the 5 pillars of Islam. It's obligatory for all healthy adult and adolescent Muslims from the age of 12 years. Abstinence from eating, drinking, use of oral medications, and smoking from pre-dawn to after sunset. However, there are no restrictions on food or fluid intake between sunset and dawn. And this is the basic challenge that we all encounter, and this is what we need to address. Exceptions are sick, old, prepubertal children, women during menstruation, pregnant women, women nursing her child. Now, patients who insist on fasting, like the other speakers have also alluded to, that a lot of people, even though they are at risk, they insist on fasting, and again they need to be managed, and the entire fasting period we need to monitor and follow up with them very closely, because they need to be adhering to the recommendations of their healthcare team to achieve a safer fasting experience. Now, strategies to ensure safety of individuals with diabetes who choose to fast include Ramadan-focused medical education, which starts much, much before they even intend to start fasting. The pre-Ramadan medical assessment, including robust assessment of hypoglycemia awareness, following a healthy diet and physical activity pattern, modification of insulin regimen, and frequent SMBG or continuous glucose monitoring, and also modification in terms of OADs. Now, there are guidelines, and ISPAT guidelines clearly have recommendations for fasting for children and adolescents. And then we have the IDF-DAR guidelines, which the previous speakers have already discussed. The major risks associated with fasting in people with diabetes are hypoglycemia, dehydration, and hyperglycemia. And therefore, close monitoring of these patients becomes extremely important. Now, SMBG, and today we also have CGMS, which has really done a world of difference, to our clinical practice. And again, titrating the insulin doses for patients who are in the insulin pump, again, adjusting the basal doses as well as the bolus becomes important. And I think Professor Yusuf has already, alluded to this point, that there are a lot of myths when it comes to SMBG during the fasting period. And therefore, we have to inform the persons that SMBG or, CGMS is perfectly all right during the Ramadan period, and it does not break the fast, as that is the common myth. Now, when we're looking at fasting and what we're experiencing, especially during the Ramadan period, in the period when they can eat, that is post-iftar, there is excessive eating, and sometimes we see that people are eating late into the night, sometimes even up to 2 o'clock in the morning, large portions of meals, and there is insufficient sleep. The foods are often high in fat, sugar foods, and there's beverage intake, in the sense they will have ruh afza, they'll have some drink which is high in sugar. Fast eating leading to overeating, especially after they break the fast. And again, there's dinner and sometimes late night snacking. They will skip sehri because they're not able to wake up in the morning. And definitely there is a change in physical activity and food habits, which could lead to weight gain. Again, since the time of iftar is around 7 p.m. and, they will break their fast with dates and water, and then move on to having the snacks, which are often very high in fat because they're the fried snacks, and again, followed by a heavy dinner. And therefore, we see that the glucose levels post-prandial, especially post-dinner, are very, very high. Such lifestyle contradicts the essential requirements and the spirit of Ramadan. Again, when we're looking at medical nutrition therapy, the principles are that definitely we need to give adequate amount of calories, but well balanced in terms of macronutrients and micronutrients during the non-fasting period, that is from sunset to dawn, to prevent hypoglycemia during the fasting period. Again, very important is to distribute the carbohydrate intake among meals to minimize postprandial hyperglycemia. Individuals with diabetes and HCPs giving consideration to, they should give considerations to comorbidities such as hypertension, dyslipidemia when formulating the MNT plans. Again, very important is to divide daily calories between sehri and iftar, plus giving 1 or 2 snacks, give well-balanced meals, include all the major food groups to ensure that the new foods are nutrient dense and there is enough diet diversity. So fruits, vegetables, whole grain cereals, pulses, nuts, poultry, fish, and dairy. Include low to moderate glycemic index, high fiber foods like barley, whole wheat, sweet potato. Again, when we're looking at oats, instead of choosing instant oats, it's better to choose rolled oats or steel cut oats. Then there's broken wheat, brown rice, beans, lentils, which will release energy slowly before and after fasting and therefore prevent hypoglycemia later on. Water should be taken liberally during the non-fasting periods to keep hydrated, because especially Ramadan comes during the summertime and therefore dehydration can become a big, big concern. Include water-rich fruits. And if you see during the summers, there are a lot of water-rich fruits and vegetables which are available. Like you have the watermelon, you have the ice apple, or what we call as tadgola. You have the musk melon. So you do have a lot of water-containing fruits available during this time, and patients should be encouraged to choose those fruits. Again, when it comes to vegetables, celery, lettuce, cucumber, spinach, all of them would be ideal to consume. Proper processing of non-vegetarian food can be of help using cooking methods like roasting or boiling instead of using frying as a method. Avoid intake of high sugar foods, especially sharbats, ruafzas, etc. Especially also there is a lot of sweet consumption that we have seen during the period where they can eat, and that definitely needs to be controlled, and patients need to be advised about alternates, which I'm going to be discussing in the slides to follow. Moderate intake of coconut and cashew nuts in preparation of curry and sweets. Avoid spicy foods to prevent heartburn and acidity, and avoid caffeinated drinks such as aerated drinks, coffee or tea, because that can cause dehydration. This is the distribution, especially when we're looking at the Ramadan nutrition plan. We have to distribute the carbohydrates and from the calories that we are recommending for the individual. So at suhoor, around 30 to 40%, which is 3 to 5 exchanges, depending again on the on the person, or his age, gender, etc. Iftar snack is around 10 to 20%, that is 1 to 2 exchanges. Iftar meal can be 40 to 50%, that is 3 to 6 exchanges. And a healthy snack, if required, at bedtime, which is 10 to 20%, again 1 to 2 exchanges. One exchange is roughly around 15 grams of carbohydrate. Now, when we're coming to suhoor or the sehri tips, this is the pre-dawn meal or the suhoor. It's very early in the morning. Most often people do not have time to sit and cook elaborate meals because they would wake up, they would pray, and then eat the meal, and again sometimes go back to sleep. So again, it should be enough in terms of adequate in terms of its nutrition, in terms of calories, carbs, slow release carbs, so that it also gives enough energy for the day-long fast ahead. Again, very important is to make healthy choices, drink enough of water during the sehri period, because, that is the only time that they can drink water. Otherwise, there is a high chance of dehydration later on. Avoid fruit juices, because then that can cause spikes in glucose levels. So we have to give them alternatives in terms of what beverages they can choose from. Avoid caffeinated beverages. When opting for savory dishes at suhoor, make sure that they're not too salty, because that can make them thirsty and they cannot really have water during the fasting period. Include complex carbohydrates which are lower in glycemic index to make sure that the glucose levels are sustained and there is no postprandial hyper or hypoglycemia. Avoid high GI foods, because that can cause postprandial hypoglycemia. Again, meal at the sehri should be taken as late as possible, especially when fasting for longer than 10 hours. And this is an example of the pre-dawn meal. You can recommend milk with almonds, and then one of these options which are easy to make because the pre-preps can be made a night before. So chilla or pancakes is very simple and easy to make. It doesn't take more than 5 minutes if the batter is already pre-prepared. You can make a dalia or a millet or an oats upma, or it can be an overnight oats, or you can just have oatmeal, or you can have egg or paneer veg wrap. Again, these are very, very easy things to be made in the morning, and this can be consumed by the entire family. It will also ensure the blood glucose levels are in range, and it keeps them full for a longer time. Now, breaking of the fast, I think this is the most important thing, and this is where we see most people go wrong. Again, traditionally, the fast is broken after sunset and begins with the eating of dates and drinking water. So start by drinking plenty of water. That's the first thing that we tell our patients, because it will help rehydrate and also reduce the chances of indulgence, because a lot of people would overindulge during the period when they can eat. Limit dates to 1 to 2 each evening. Again, do not go and overdo dates. Avoid caffeinated beverages to prevent dehydration. Try and have clear soups, because one is it will give satiety. It will also help to maintain the water and mineral balance in the body. Choose low glycemic carbohydrates like we've spoken in the past. Moderation in traditional sweet intake and fried foods is strongly recommended, because this is what we see, that typically people will go out, and especially I'm from Mumbai, and you see some streets of Mumbai completely crowded with people, trying to indulge in all their favorite foods. Individuals to be advised to refrain from an unbalanced diet with too many servings of sharbats and sweets with added sugar. Now, this is the culinary modification that we can do and recommend to our patients, which the entire family can be encouraged to do. It's not only the person with diabetes, but we believe that the entire family should eat healthy because we have a large population of people with pre-diabetes, not even knowing that they have diabetes or any other medical condition. It could be hypertension or it could be dyslipidemia. So instead of chicken fry, opt for chicken tikka. Instead of ruafza, we can give them other options. It could be coconut water with chia seeds, especially because if it's in the summertime, they need to hydrate, and we can give them, easier options. It can even be a lemon juice with, sabja seeds, which is basil seeds, which will hydrate them and also prevent any kind of heartburn. Instead of having a fried moong vada or any kind of vada, they can actually make moong vada in an appam maker. And this is easily available, very economical. So you need not invest in expensive air fryers. We always suggest them that you can get this at any shop which sells, vessels. And this is a very handy thing. They can make all their vadas in this appam maker. Instead of aloo vada, again, you can recommend, pulse-based options such as a moong tikki or chana dal or a moong gappe. And they're really tasty. You have it with green chutney, which is coriander mint chutney, and it really gives you good satiety. It's high on taste. And again, it's very, very good for blood glucose because it is made with pulses, and pulses do have lentil carbs, which have a good effect on your blood glucose levels. Again, instead of aloo chaat, we can recommend a sweet potato chaat. Again, if you look at sweet potato, the glycemic index of sweet potato is actually lowered on boiling. Adding lemon to food will also help to lower the glycemic index. So when they're making chaat, we always ask them to squeeze a little bit of lime, add some vegetables so that you get more volume, lesser calories, and also lesser amount of carbohydrates. So that will also give them good amount of satiety. Ragda is also another good option, which is commonly consumed during this time. And they have ragda with aloo tikki. We can tell them to exclude the aloo tikki, exclude the sweet chutneys, and just have the ragda with chutney, and it tastes really good, gives good satiety, and keeps the blood glucose levels under control. Again, instead of a nargisi kebab, they can make egg muffins again in an appam maker, and this is really delicious. So you just take eggs and beat it along with a lot of vegetables and then put it in the appam maker and have it, and it's extremely tasty. A lot of our children also enjoy it. Instead of firni, which is again very commonly consumed during this time, in case they want to have it once in a way, it's fine. They have to monitor the blood glucose levels, watch their portions, and also watch what are the other, carb-containing foods that they're consuming. But this cannot become a regular feature. We can give them other options such as a chia seed pudding, which is extremely tasty, low on, on carbohydrates, but again very, very good in terms of good fats, as well as it keeps the glucose levels under control and provides the much needed satiety. They can add strawberries if they are in season at that point of time. Again, when we're looking at dinner, it has to be a well-balanced meal, making sure that all the food groups are included to ensure nutrient density and diet diversity. So we can recommend them either a chapati or brown unpolished rice. Today, there's a lot of talk on millets, and fortunately in our country, we have a lot of different kinds of millets which are available. We are also celebrating the International Year of Millets, and there's a lot of emphasis on the use of millets, and millets definitely have a good impact on blood glucose control. It also gives higher satiety because it's got more fiber. So if you want to substitute rice with millets, that's a good thing to do. Or they can do a broken wheat or a dalia pulao, which is also known as lapsi in certain parts of our country. And club that with dal, sprouts, or chicken, fish, and egg, again, to ensure that we're getting good quality protein, because when we mix cereals with pulses, cereals are lacking in certain amino acids which are there in pulses, and pulses are lacking in certain amino acids which are there in cereal. So therefore, when you combine cereal and pulse, it becomes a good quality protein. Chicken, egg, fish is already a good quality protein. But again, very important is the method of cooking it. And along with that, definitely a vegetable. If vegetable is too cumbersome to make, then at least a salad or sauteed vegetables. Curd and buttermilk are other options, especially because of the summer season. If you want to stay hydrated, buttermilk would be a good option, where they can have curd with water, add a little bit of pepper powder, a little bit of salt, jeera powder. Salt can be excluded as well. And then also add certain mint leaves. It really tastes good, gives good amount of satiety, very, very low on carb, very low on calories as well. So we have to give them options. Just telling them not to eat is not the solution. In fact, we have to tell them what they can eat so that they do not even remember or think about foods that they should not eat. Now, some other fast in India, and these are my last few slides. Again, when we're looking at the Hindu fast, Hinduism constitutes the world's third largest religion with over 1 billion adherents. Hinduism does not enjoin its followers to practice mandatory fasting. There are different kinds of fast, again, when it comes to Hinduism, where they would eat certain foods or they would fast for the entire day, or there are even week-long fasts that are observed. You have Karwa Chauth, where the wife is actually fasting for her husband. You have Guru Purnima, you have Hoy Ashtami. In fact, today in Karwa Chauth, you have even the husbands fasting for their wives, and both of them would fast together. You have monthly fasts such as Ekadashi, Purnima, Pradosha. You have the Navratri fast, which is, there's a lot of physical activity because a lot of them would be dancing every evening, playing Garba, and it's over a period of 9 days. It's one of the most beautiful periods, especially in our country. Again, fasting without taking adequate safeguards may predispose persons on glucose-lowering medication or insulin to hypoglycemia. Persons who abstain from water and other liquids during the hot Indian summer run the risk of dehydration, dyselectrolytemia, and hypotension. And I'm not only talking about Indian summers, it could be anywhere in the world. Again, the composition of the pre-fast meal should be such that it provides enough slow-release calories. So very important is to include lentil carbs, whole grain cereals, etc., because they give you the slow-release carbs as well as calories. So complex carbohydrates with low glycemic index and proteins fulfill this need. Addition of unprocessed cereals, especially on millets, fruits, nuts, lentils to the pre-fast meals reduces its glycemic index and allows energy availability for a longer period of time. Very important, we've discussed this in the past, is water and low calorie and low carb containing fluids, such as you can have buttermilk, you can have lemon water. So we have to give them these kind of options. Serving of meal supplements may be added to the pre-fast meals or intra-fast liquids to prevent hypoglycemia. And the Navratri fast, which lasts for 8 to 9 days, are commonly observed in North and West India. Though considered as fast, usually we see there's a lot of feasting that also would happen. So foods consumed are high in carbs, high glycemic index, and they're also energy dense. Glycemic control is often poor or inadequate during this fast. Now, very important is to advise our patients to avoid consumption of fried and sweet foods and give them alternatives. They can have milk and unsweetened milk products. They can have fruits, boiled vegetables, and permitted whole grain cereals are the few healthy options. So the healthy options during this period can be buckwheat pancakes. In fact, buckwheat is commonly consumed during this period, and buckwheat is a pseudo cereal. It is also known as puttu in Gujarati. So it's buckwheat and it's easily available. In fact, crepes in most cafes are actually made with buckwheat, and they're really good. They're low on glycemic index. You can make a dhokla out of it. You can make a upma out of it, and it's extremely good in terms of giving satiety. You have samo. Samo is nothing but barnyard millet. So it's a form of a millet, which is again commonly consumed at this period. You can make various items out of samo. Either a samo khichdi, you can make a samo pancake or a crepe, or it's called a chilla in our country, or a pudla. Then you have sweet potato, which is again commonly consumed. And today sweet potato is even available locally everywhere. It's very easy to find sweet potato. So in case somebody is really busy and cannot really make something, sweet potato is easily found. And that can be consumed with curd, and usually they consume it with curd during the fasting period. Fruit with yogurt is another good option. So this is some of the options. That are extremely delicious, they're tasty, and can be followed by the entire family. Also very important is it do not take too much time to make. Again, adding peanuts or so peanuts, again, in the past, used to actually tell people not to add it to the food because he thought it's high on fat. And at that time, fat was a villain and carbs were good. And, in today's times, we say carbs are something that you need to watch out for, and good healthy fats are good to consume. So actually, addition of peanuts to the food will reduce the glycemic index. And also because it's a good form of fat, which is your MUFA fats, it gives you good satiety and it will help you stay full for a longer period of time. So there are a lot of things that needs to be unlearned and learned again. So to summarize, thorough pre-medical assessment and fitness to fast is very important. I think it's very important that the doctors should encourage and advise their patients to come and see a dietitian or, before they even embark on the fasting period, so that they're ready and their glycemic control is also good. Structured counseling. So very important is to work as a team, work with their caregivers, work with their family members, and make sure that it's a family thing. Insulin and OADA titration, which is going to be discussed in the in the sessions to follow. Regular monitoring, I think, very important. And today with CGMS, we can actually see which food is having what impact on their blood glucose levels. And that makes compliance even more better, adherence to the treatment even more better, because they can see in real time what is really happening, with certain kinds of foods. Disciplined eating, and I think today we're talking about bringing back the joy of eating. So whether it's fasting or feasting, very important is to remove the fear of food from people's mind and help them enjoy the food, help them enjoy every festival, whether it's the feasting time or it's the fasting time, help them to enjoy it and remove the fear of food. And I think this is what we have been able to do today, because there's so much of advancement in nutrition science as well. Mild exercise during non-fasting period, again, focusing on that becomes very important. Like I said, in the Ramadan fast, certain, especially during the time of prayers, there is automatically a lot of, physical activity that happens. So thank you so much for your patient hearing. It was really a pleasure to be with all of you this Sunday afternoon. Thank you.
Excellent talk, Cheryl, and as always, very practical, well scientifically balanced as well. So thank you for that. I have one question. In your practice, do you often see patients losing weight after prolonged fasting or actually gaining weight?
No, I think that's a very good question, Dr. Purvi. And that's what we say is like intermittent fasting. So if it's done right, a lot of people would lose weight. But we really don't know whether they've lost muscle mass and they've lost water weight, because they regain it also very, immediately. But when we see that when they, consult us and follow up with us, this is a good period actually to begin. And a lot of people see benefits of doing the fast, and if they can continue to curtail their food and curtail the, the time in which they're eating, it becomes very easy for them to then follow it. So we see both sides of the, of the spectrum, right? From gaining weight to even losing weight, depends on how they're doing it.
Absolutely. And I think one thing that is very, that makes them really happy is if there is reduction in the dosage of medications. Even post that, if they continue to maintain that regime or, cut down on the calories, there's a distinct, control over not only glycemia, improvement in other metabolic parameters also, and then reduction in medication, which makes them the happiest. So
I agree with you. In fact, a lot of people, in fact, I had a patient who had fibromyalgia and IBS. And in fact, he, post doing the Ramadan fast, he actually saw a lot of benefits. In fact, his symptoms really improved and he started feeling better. And he's decided that I'm going to do this for a long period of time. And he actually continued to do it. And today he's actually my brand ambassador. Everywhere he goes, he's actually, it's like walk the talk. And then a lot of patients are referred just looking at him because he's lost some 40 kilos post doing this and doing it the right way. So yes, it does work.
Fantastic. It inspiring. So thank you for that. With that, are there any other questions? With anything else?
Yeah. So wonderful presentation, Ms. Cheryl. And I think you've highlighted it in details, regarding the Ramadan fasting and also the other types of fasting. So just from you, there's one challenge that we face is that the patient doesn't often, we don't get to connect with the patient just before the fasting starts. So like in that case, what challenge do you face, especially in terms of giving them the advice for that post iftar meal? That is where they kind of tend to mess up more with a lot of high glycemic load and binge eating. That's what you have also highlighted in your presentation. So how do you kind of advise them? Do you do that during your normal consultation time, or you usually call them for a review consult? Because that's
I think that's a very good suggestion, Dr. Amit, and very good question that you've asked. But honestly, whenever we meet the person and we know that, okay, Ramadan is approaching, like we have patients who will consult us and maybe not consult us in 1 month pre-Ramadan. We would actually take that opportunity to also plan for them the Ramadan time. So we do that, and today we've seen that really helps because they already have a ready reckoner with them to follow when they start fasting. So we start talking about it right, maybe, 4-5 months before itself, saying that, okay, this period again, we ask them to come for a follow-up. And that is something we would definitely focus on.
Absolutely. Right. Okay. Thank you very much. Once again, very, very good talk. Thank you.
Thank you so much.
Well said. I would like to tell you, it's fasting is not, it's like a marathon. So, you need to start practicing very weeks in advance, not the last days. So So yes, wonderful talk. On to the next one, because physical activity is as important, and a lot of our patients and colleagues want to know whether they must or must not exercise, and then what kind of exercise or physical activity would be fine for the fasting period. So a great honor and privilege to invite Dr. S.R. Arvind sir, who is the Director and Chief Diabetologist at Diacon Hospital, Bangalore in India, and also course director for the PG Studies of Health University, RGUHS and RSSDI. He's been the past president of RSSDI as well as Diabetes India, and is a trustee as well. He has several publications in peer-reviewed journals and has been an integral researcher in phase 2 and 3 clinical. Now, invite Dr. Sir to take stage.
I've been the president of Diabetes India, speaking to you. Hello, good morning to everybody. This is Dr. S.R. Arvind, the president of Diabetes India, speaking to you. Sorry, I was not able to be present live today, so I have recorded my talk. And we're going to have a great webinar organized by IDF and the Southeast Asian chapter of IDF on diabetes and fasting. I would like to thank all the office bearers, Dr. Azad Khan, the president of SCA, past president Dr. Shashank, and the President-elect, Dr. Banshi Sabu, for having invited me to give this talk. My talk is going to be on exercises during the period of Ramadan, especially while we are fasting. I will try to share my slides now. I think there's been a lot of discussion on what exactly we need to teach our patient when it comes to physical activity and exercise during the Ramadan period. When I looked at the literature, actually you don't have too many clinical trials. Yes, you have articles, but you don't really have RCTs to actually talk about what is an ideal exercise that we need to prescribe to our patients who would like to do physical activities, especially during the period of Ramadan. Now let's just look at what happens to the body during the period of fasting, and the physiology of fasting during Ramadan is something that's very important for all our doctors to know. Now, if you just look at this particular slide, and this is taken from Diabetes and Ramadan, the guidelines, just look at the normal feeding pattern, what is happening. Now we have breakfast early in the morning, and then between 6 and 6 during the daytime we are actually eating, and then there is no activity and we sleep. But this is completely reversed during the Ramadan period of fasting. In fact, you fast from the sunrise till the sunset, and then the activity of eating starts. Now, what are the physiological changes that is actually happening during this fasting period? Now, we must remember the meal patterns and the schedules are completely altered. There is an imbalance as far as the fluid intake is concerned because of this change. And the circadian rhythm and the sleep cycles change. In fact, it is told that the sleep may actually come down by almost an hour to hour and a half. And those ladies who are working, it may come down. So they do feel sleepy during daytime. So they may actually sleep more during the daytime. Especially coming to diabetes, and Ramadan fasting can increase the glucose variability and the risk of both hyperglycemia and hypoglycemia. And this is known to the doctors. There is a reduction in sleeping time, as I said earlier, by almost an hour. Changes to indicators of body clock mechanisms have been demonstrated, which can affect many hormonal rhythms. And there is a gradual shift in the proportion of fluid utilization from carbohydrate to fat as the fasting day progresses. Now, continuing the physiological changes during Ramzan fasting, despite there being changes to activity patterns and reduction in energy expenditure, there is no significant change in the total and resting energy expenditure during a Ramzan fasting. Several studies have shown up a twofold reduction in insulin sensitivity during Ramzan fasting, and the hormonal changes during Ramzan fasting includes the reduction in the morning adipolectin levels, large increases in the morning leptin levels, and reduction in morning and evening growth hormone levels. All these are important to understand because when you are giving exercises, we must be clear about the physiological changes and the hormonal changes that are happening to the body. Let's see what happens when we exercise and during Ramzan fasting. The body starts using energy from fat stores, especially if you are exercising during the daytime. Hypo and hyperglycemia can occur depending on an individual during fasting. Suppose the patient has low levels of insulin and already in a hyperglycemic state, his hyperglycemia can worsen. Somebody with the normal insulin values who is under good control, if he tries to exercise, he can actually go into hypoglycemia. Dehydration is a possibility, and this is something that you have to keep in mind. And especially, some of the countries can have very hot weathers, so it's always advisable that you are taking care of hyper, dehydration. Three important things when we talk of exercises. And studies have shown that 30 consecutive days without performing any physical exercise or activity can also reduce the strength and the physical fitness. So it is important that we remain active and do physical exercises and activities during the period of Ramzan. And we must discuss with the doctors what is the right exercise that we need to do. So here we talk about risk stratification, and I am sure you would have heard lectures about it. So the risk stratification is a must before exercises are advised. Now, what are the benefits of exercise while fasting? In fact, this includes increase in fat loss, especially in people towards the end of the fasting period, towards the evening if they fast. This is one area where they can actually lose some weight, and it helps to control the blood sugar levels. It maintains the physical strength and endurance. It maintains the healthy body and the metabolism, prevents the muscle breakdown, and you feel fresh and you feel less tired. In fact, exercise always makes you feel good, and if you stay active to mainly perform the rituals and prayers. In fact, some of my Muslim patients would ask me, Doctor, the Tarawih prayer itself is a good exercise, and we may not be doing it on a daily basis, but at least during the period of Ramzan, all of us do it regularly. The number of times we have to stand up and then bend down again, that itself can be a good exercise, but that itself will not be sufficient. Now, when do we exercise during Ramzan? This is a question that all your patients are going to ask you. Before iftar. Now, this is where a bit of a controversy. I will not go into the controversies, but I would just say that if you are comfortable doing your exercises before iftar, because that is towards the end of the fasting, and then you break it by taking liquids, and then you have your food. So you start doing the exercises maybe 1 to 2 hours prior to iftar. I would even suggest the patients that you just start about an hour before or even half an hour before iftar, so that in case you feel uncomfortable, dizzy, or you think you have hypoglycemia tightness, at least you can break the fast and then take some liquids at that time. But generally it is told 30 to 45 minutes before iftar in a person whose risk stratification is low is probably an ideal time. In fact, many have been talking about fasted cardio in type 1 diabetics and also in non-diabetics. This is practiced, but unfortunately, we don't have any clinical trials to say that we can actually advise fasted cardio to our patients with diabetes during Ramadan. It's always preferable to exercise in a cool environment because at least the chance of dehydration comes down. After iftar, drink sufficient fluids to replenish salt and minerals lost. Now, after iftar, I think this is the time, but most of the people prefer. Because in case if they have hypo, they have to break the fast, which they are not comfortable with, even though you can always make up for it. And then our religious practices allow us to do another day of fasting or so, in case if you happen to break your fast for any of the medical purposes. But you start the exercises after iftar. It's advisable that you perform the physical exercises at least 2-3 hours after your meal, because at least 2 to 3 hours later, the digestion would have taken place and then you will be comfortable to do the exercises. And again, as I said, cool environment, because definitely the dehydration chances are low. Now, what are the tips for exercising during Ramadan? Well, you can perform exercises for 30 to 45 minutes at least every day in a cool environment. Avoid aggressive and high intensity exercises, especially during the summers while you are fasting, and summer is there this time in most of the countries. Choose a plan and a convenient time to exercise. It doesn't matter whether it is before iftar or after iftar. You have to be comfortable, discuss with the doctor, and then choose a time. Eat 2 to 3 hours of interval between meals and exercises. Reduce the physical inactivity such as sitting idle for extended periods of time. Many people do that. They just keep walking around during daytime. That itself become an exercise. And going for a walk, of course, is one of the best ways to do your exercises. After iftar, wait for 2-3 hours. Go for a walk, maybe for 30 to 40 minutes. I think that would be a great exercise in most of the people. And stop exercises immediately if you experience any dizziness, nausea, difficulty in breathing or chest pain, because you have to evaluate whether it is hypo or something else, and drink sufficient fluids to prevent dehydration. What are the safe exercises during Ramadan? There is nothing like a safe exercise. If you are already trained and if you are fit, you can do several types of exercises. Or if somebody really is not that good in exercises and is lazy and just in exercises, I think a brisk walking, he can climb the stairs. People can do yoga, swimming, tai chi, cycling, low intensity exercises that people with diabetes can definitely perform. It all depends on what you have done earlier before. Do not really start a new exercise pattern. Individuals can perform all the exercises, no to that, maybe 5 times a week or 150 minutes as we tell in non-diabetic, as we tell in all our patients. And this is good enough even during the Ramadan period. And as I said earlier, never start a new exercise routine during Ramadan because you don't know the energy expenditure. Even if you want to start a new exercise, make sure you do it after iftar. And if something happens, you can still break the fast. You don't have to worry about breaking the fast at that time. And remember to monitor the blood sugars at all times before and after the exercises. So in summary, plan doing exercises, but never overdo it. Consider dropping the intensity for a few weeks. You can always make it up when once the Ramadan fasting ends. Remember to monitor blood sugars very frequently during fasting daytime. You have guidelines as to when you should actually do it. Now with the availability of CGM, if one can afford a CGM, I think it's a very, very good option to monitor your blood sugars. Fasting during Ramadan carries certain risk for patients with diabetes. This is something that we have to remember. Persons with diabetes should undergo pre-Ramadan assessment before starting the fast, and also should be guided by the healthcare professionals on meal planning, physical activity, glucose monitoring, and timings and dosages of medication in order to have a safe fasting. Thank you so very much. With this, I will stop sharing my screen. I hope you will all have a good webinar, and I'll be happy because my senior colleagues will be there, Dr. Shashank Banshi and others will be there. They should be able to take the questions related to exercise. I did see that there are fantastic guidelines on what exercises do, but most of the time, I still prefer to tell the patients, if you are used to 30 minutes or 45 minutes of walking, please do it 2 to 3 hours after your iftar meal. Make time to do this. Come back, have a hot shower or probably lukewarm shower, and then try to get good sleep. And continue your normal activities during the period of fasting, whether you are a businessman, an executive, whether you have to travel or you have to stay at home, it does not matter. Practice doing this well before the fasting starts. In fact, fasting makes you much more healthier. You don't have to be afraid of exercises during fasting month of Ramadan. All the very best. Thank you so very much for this opportunity. Bye-bye.
Thank you for that fantastic overview on physical activity, exercise, and fasting. Dr. S.R. Arvind sir, that was very, very comprehensively covered. So thank you for that. And a very positive note that one doesn't need to stop at exercise, but just with adequate precaution, we can safely suggest, what can be done and how it can be done. And that can avoid mishaps in our patients of diabetes. So great message there. Is sir there? Then we can take some questions.
I don't think sir is online at the moment.
Okay, so then we may proceed with the...
Yes.
We'll proceed with the third talk in the session. A very dynamic speaker, Dr. Amit Gupta. And it's great pleasure for Dr. Amit Dey and me to welcome him. He's a physician diabetologist from Greater Noida. He's director for Center for Diabetes Care. Also, he's been the member of the advisory group for American Diabetes Association, currently the National Executive Committee member for RSSDI, also the Joint Secretary of Diabetes India, and Advisory Council member for ACP India chapter. I could go on and on, but a special mention that besides the important positions he holds, he's also been an awardee of several prestigious awards, including the Padmakar Tripathi Young Scientist Award. So without much ado, I think I welcome Dr. Amit Gupta to deliver his talk on modifications of anti-diabetic agents during fasting, especially the oral ones.
Thank you, Dr. Purvi, for the kind introduction, and thank you, Amit, for being there. And I think it has been a fantastic webinar going on since today morning. And we have discussed so many aspects, and I think use of OAD is something which is always at the forefront. And all the patients with diabetes, they are very concerned that how to take their medications, and we are also concerned that how to modify these medications. So in the next few slides and in my presentation, I will be talking about the OAD modification in fasting. But at the outset, I would like to thank Dr. Bansi Sabu, Dr. Azad Khan, and Dr. Basit from Pakistan for giving me this opportunity to present in front of such a wonderful audience. So I'm going to talk about how do we modify the drugs, oral medications. I will be sticking to the oral medications only because the speaker next to me will be talking about the use of insulin in fasting. So we know that during the fasting, there can be metabolic changes and there will be change in the eating hours. So one of the main risks which comes with the fasting is that the blood glucose levels may exhibit a great variability in their pattern, because whenever you are breakfast, you're likely to eat more. And whenever you are eating more, there are chances that the blood sugar will go up. And with the prolonged fasting, and when you have a longer period of nothing to eat or nothing to drink in between, the chances of hypoglycemia. So large variability can be there. and the measure needs to be taken to minimize the risk of both hyperglycemia as well as the hypoglycemia. So during the fasting, it is indicated that the first thing which should be done is that those people who are on oral anti-diabetic drugs and enrolled in any kind of fasting, they should practice self-monitoring of blood glucose, and the frequency of self-monitoring of blood glucose can again be determined by the type of drugs they are on. And sometimes the adjustment of the anti-diabetic medications are required so that they can be adjusted as required. As we know that most of the studies are done in pre-Ramadan, but this is a flow chart which tells us that how to assess a patient before we take a decision about the modification of the oral anti-diabetic drugs. We need to quantify the risk. We need to understand the role of the SMBG, which may again be decided upon the fact that what kind of OAD the person is taking, at what time of the day the patient will be starting the fast, at what time of the day the patient will be breaking the fast. Also, when the patient will be exercising, what kind of exercise patient will be engaged in, and what is likely to be the meal plan and the fluid plan. For example, there are certain fasts where the patient will not be taking anything, and not even fluids during the fasting hours. So it is important to understand the pattern which they are going to follow and the medication adjustment which is required. So this requires understanding of the detailed medical history, aspects of the diabetes and ability to self-manage, presence of any kind of comorbidities, the individual's prior experience in managing diabetes during Ramadan fasting. So this is very, very important, that how that person actually behaved during the previous past experiences of the fasting, and how the sugar levels they were keeping at that time. Again, there are many factors like individual's ability to self-manage diabetes, and what are the other risk factors involved which can increase the risk of hyperglycemia as well as the hypoglycemia. So based on this, we can classify the people with diabetes into three categories: the low, moderate, and the high risk. So those who are at low risk of hypoglycemia, at moderate risk of hypoglycemia, at the very high risk of hypoglycemia. So somebody who is on multiple daily injections of the insulin, there may be more chances of hyperglycemia, hypoglycemia. Those who are on sulfonylurea kind of drugs, they will again be at a high risk of hypoglycemia. So it is recommended that one thing is very, very important, that whenever any patient, if they develop any symptoms of hypoglycemia, documented or undocumented, if the blood glucose levels, they fall below 70 milligram per deciliter, they should break their fast immediately, because this can lead to more severe levels of hypoglycemia and compromise their life. Recheck within 1 hour if blood glucose levels are still between 70 to 90 milligram per deciliter, and if the blood glucose levels are more than 300 milligram per deciliter, again somebody has to rethink about the fasting process. So what are the medication adjustments which we need to do? So this is again going to depend upon the type of the medication the person is taking, and also what are the potential risks, and therefore needs careful attention when formulating the treatment plan. So we know that the metformin, in most of the guidelines, metformin is at the top of the chart, and people with diabetes, they will be taking metformin because it is one of the first class recommendation, and is at the top of the chart in all the guidelines. So if somebody is taking metformin only once daily, so no dose modification is usually required, and it is advised that the patient should take that metformin dose at the time of the iftar, that is at the time of the opening of the closing of breaking of the fast in the evening. If somebody uses the twice daily dosing of the metformin, again we don't need any dose modification, is usually not required, and somebody can take it after the iftar as well as the suhoor. So these are the two times when a person will be taking the metformin. Somebody who is taking 3 times metformin, then morning dose can be taken before or after the suhoor, and the combined afternoon dose we should combine it after the iftar. So afternoon dose can be shifted to the evening time. So we should avoid the afternoon dose because the patient will not be taking anything in the afternoon. If you are taking a prolonged release metformin, again the no dose modification is usually required unless until there are some other compelling reasons, and it is preferable to take the metformin at the iftar. So this is the change which is recommended by various guidelines in the diabetes by the different associations also, and the diabetes and Ramadan study group. Coming to the sulfonylurea, again we know that a large number of patients, they take sulfonylurea. Sulfonylurea, they come with a risk of hypoglycemia, and with prolonged fasting, the risk of hypoglycemia is certainly likely to increase. So how do we counter that, and what are the adjustments they are required? So if somebody who is on sulfonylurea taking once a day, if we are giving it in the morning hours, it is better to give it in the evening hours, just before the breaking of the fast. And in patients with well-controlled blood glucose levels, the dose may be further reduced. So if somebody who is having a very good glycemic control, you may consider reducing the dose of sulfonylurea during the fasting period. Also, if someone is on twice daily dosing, then the evening dose, that is the iftar dose, remains the same. And in patients with well-controlled blood glucose level, the suhoor dose should be reduced. So the morning dose can be reduced because after that, the person will be having a prolonged level of the fasting. Same can be applied to the other types of fasting, whether it is a fast in the Hinduism like Navratra, or it is a Jainism fast. So it depends on what kind of fasting pattern somebody is going to observe. Also, we need to understand that the older sulfonylureas like glimepiride, or the much longer acting sulfonylureas, they have a very high risk of hypoglycemia, and they should be avoided. If somebody is on those drugs, it is better to avoid these drugs during the fasting period. And second generation sulfonylurea like gliclazide and the glimepiride, they can be used in preference to the older generation sulfonylureas. So this is the change which is required for the sulfonylureas. Coming to the AGIs, there are no RCTs which have been conducted on acarbose or the voglibose in people with type 2 diabetes during fasting during Ramadan. So no dose modification is considered, and it is because the action of the AGIs is totally insulin independent, and they depend on the meal when you take. So whenever you are skipping the meal, the AGIs are not required, but at the time of the meal, whenever somebody is taking a meal, whether in the morning or in the evening, they can easily adjust the doses and adjust the timing of the AGIs, and they can be taken safely at that time of the day. This is thiazolidinediones. We know they have low risk of hypoglycemia exists with the pioglitazone. However, no dose adjustment is required during the Ramadan or the other fasting things. And it is again recommended that we take these medications with iftar rather than the suhoor. And also the individuals should not be switched onto this class of medication close to the Ramadan, as it can take up to 3 months for an optimal anti-hyperglycemic effect of these drugs to be reached. So if we want to have a good glycemic control, and so medication like pioglitazone is not something which is recommended to be introduced just before the starting of the Ramadan or any prolonged fasting. So it is better to take the drug in the evening, and no dose adjustment is required with the thiazolidinediones. We have short-acting insulin secretagogues like repaglinide, and the daily dose of short-acting insulin secretagogues may be reduced or redistributed to 2 doses during Ramadan according to the meal size. So if somebody who was on 3 doses of the repaglinide or meglitides, so they should be given 2 doses only, and the dose can be reduced according to the size of the meal. So the short duration of the action of these agents make them appealing for use during Ramadan, as they can be taken before iftar and suhoor, and they carry a low risk of hypoglycemia. So this is about the short-acting insulin secretagogues. The DPP-4 inhibitors, again, a very interesting class of drugs. They does not require any treatment modifications, and there are various studies which they indicate that the vildagliptin or sitagliptin, they can be effective in improving glycemic control. And both these class of drugs, along with other gliptins, they have lower rates of hypoglycemia during fasting, so making them suitable treatment options during the fasting periods. So these drugs do not require any treatment modification during the prolonged fastings also. Again, SGLT2 inhibitors, this is something we know that SGLT2 inhibitors, whenever we recommend the use of SGLT2 inhibitors, we know that these people will have excessive urination, diuresis also. There is increased thirst sometimes. Some of the recommendations, they do exist. So whenever we are prescribing SGLT2 inhibitors, we should take care of 2 things. SGLT2 inhibitors, they should be initiated at least 2 weeks to 1 month prior to Ramadan. So it is not a drug to be started during the month of Ramadan or when somebody is already into the fasting. They are recommended to be administered at the time of the evening meal, because water consumption is increased after taking SGLT2 inhibitors. Thirst may increase, urination may increase. So it is better when the patient is breaking the fast, so the patient is able to drink a lot of fluid, and adequate quantities of fluid can be consumed after the evening. If the indication is cardiovascular or renal protection, then the pre-Ramadan initiation should be conducted, and however a lower dose may be considered. If required, the dose can be increased. Increasing fluid intake during the non-fasting hours of Ramadan is recommended, and SGLT2 inhibitors do not require treatment modifications during Ramadan or any other fasting. However, if an individual is on multiple medications, we need to see whether this combination is going to increase the risk of hypoglycemia or not. SGLT2 use when fasting during Ramadan should be in accordance with the usual safety and prescribing measures as recommended by the e-drug safety manual. So this is the RSSDI 2022 guidelines and recommendation for the management of type 2 diabetes during Ramadan. And the Research Society of Study of Diabetes is an affiliate member of the IDF, and they have given certain guidance. And this table somehow summarizes that. With metformin, we have already explained that take at iftar. If BID doses, take at iftar and suhoor. TID doses, skip the afternoon dose and take it in the evening, combine it with the evening dose. Sulfonylurea, again, it is better to take at the iftar, BD doses. Morning dose, you can reduce to the half, and evening dose can again be considered if required to be, if reduction is required. However, the full dose can be given. Glinides, again, you would like to skip the afternoon dose. In the morning and the evening dose can be given. Most of the drugs like thiazolidine, diones, DPP4 inhibitors, acarbose, SGLT2 inhibitors, GLP-1 receptor agonists, they also do not require much adjustment. However, with GLP-1, the dose should be titrated 6 weeks prior to Ramadan, and no dose adjustment is required. So titration should be done at least before the fasting period. And with this, I would like to say that if somebody is having a longer duration of diabetes, multiple comorbidities, renal impairment, and if they are at higher risk of hypoglycemia, then we need to have special consideration for those who are they require comprehensive counseling and advice on diet, lifestyle, and drug dose modification. And newer technologies can be included, like continuous glucose monitoring, which allows more flexibility in blood sugar testing, as well as understanding the patterns which they are going to have during the fasting period. So in conclusion, I would like to say that individuals on multiple anti-diabetic therapies will find themselves at a greater risk of hypoglycemia. Dose titration, dose reductions are required to mitigate this risk of hypoglycemia. A pre-Ramadan follow-up and a post-Ramadan consultation is recommended. Post-fasting consultation is recommended to reorganize the treatment for this special group of patients. And with the correct advice and support, most of the people, they will be able to observe the fasting correctly and with minimal risk of hyperglycemia as well as the hypoglycemia. Thank you. Thank you very much for your patience listening.
Thank you, Dr. Gupta, for the extensive lecture on the modification of the OADs during fasting. And I think you've extensively covered all the points. So just a quick tip from you before we can take in any questions from the audience. I'm sure there would be many questions coming in regarding the modification of OADs. So, we find that most of our patients, especially after iftar, as I said earlier, they consume a lot of high calorie food and a lot of high glycemic load goes in there. So how do you advise your patients to synchronize their drug regimes? Would you prefer acarbose or avoglibose in this period during the fasting days? Do you make any changes in the molecules during the fasting period?
Thank you, dear Amit, for asking that question. My take on this would be that whatever Dr. Sharil has told, that how to modify the diet. So we should emphasize on that also, that how to break the fast, how to start the fast, what kind of food they should plan. So this is going to decrease the risk of any kind of hyperglycemia as well as the hypoglycemia. However, if you talk about the OADs, again, it will depend on the individual profile. So it cannot be said that all patients who are on fasting, they should be prescribed acarbose or any other AGIs. So it is again patient-based, patient-centric, and it can vary from person to person depending on what kind of meal exactly they are planning.
Thank you. Thank you very much. So do we have any more questions? Otherwise, we can move on to the next speaker. And we have Dr. Wasim Hanif from UK. And Dr. I will request my next chairperson, Dr. Shubhajyoti Ghosh, to kindly introduce Dr. Hanif and take over the session. Dr. Ghosh, please. If you could kindly introduce Dr. You're on mute, Shubhajyoti.
Yeah, thank you. Thank you, Dr. Amit. So for our next speaker, like after the session of diet, exercise, and OADs, we have an eminent speaker, Dr. Wasim Hanif, to discuss about insulin modification. So our sir is a professor in the Department of Diabetes and Endocrinology, consultant physicians also. He is an honorary professor of medicine in the University of Warwick. Then he's a director of advanced diabetes course. He's on the board of governors as a trustee of Diabetes UK and non-executive director of DMJ on its board. He's an eminent authority on diabetes, obesity, and ethnic health. Then his research interests includes diabetic kidney diseases, diabetes prevention, cardiovascular diseases in diabetes, diabetes in Ramadan, obesity, ethnicity, and tackling health inequalities. Like if I need to speak about sir, it will be like an extensive one. So with this, I just want to welcome Dr. Hanif, sir, for the next deliberation on insulin modification.
Thank you, Dr. Ghosh. Let me just share my screen.
Welcome, Dr. Wasim Hanif, sir.
Oh, thank you, Purvi. Thank you very much.
Looking forward to this one.
Okay, it's an absolute. Can you see my screen? Yeah. Thank you. It's an absolutely pleasure and honor to be presenting this, and I am really thankful to my friends and colleagues, Dr. Banshi Sabu, Dr. Abdul Basit, Dr. Azad Khan, Shashank Joshi Puri for inviting me to give this talk. So this talk is mainly based on the IDF guidelines, and I did the chapter on insulin modification. So that is what I'm going to be doing today. So in my talk, I'll try to cover the following points regarding insulin and Ramadan fasting. So is there an evidence for the use of Ramadan fasting? And I'm using Ramadan as an example to cover fasting in other faiths as well, because most of the research is done in Ramadan. We are going to look at whether insulin analogs or human analogs should be used. We should look at which regime do we use. How do we adjust the doses of insulin at the start of Ramadan? How do we titrate the doses during Ramadan, and how technology is proving to be a game changer? So when it comes to fasting in Ramadan, especially in people who are on insulin or those who have got type 1 diabetes, the 4 complications that we have to really consider are hypoglycemia, which is probably the main one, which can occur during the time of fasting. Hyperglycemia is when it occurs during the time of non-fasting hours. And then we have the whole kind of fear of diabetic ketoacidosis if things don't go well. And that is the potential of dehydration leading to increased thrombosis, especially in countries with very warm weather. Now, when we do the risk stratification or the factors that affect fasting and diabetes in Ramadan, and this is something very important because one set of guidelines or rule cannot apply to all our patients. So there are a number of factors that need to consider. The first and probably the most important are what I call the diabetes-related factors. So this is the type of diabetes, whether it's 1 or 2, duration of diabetes, the presence of diabetes complications, what therapy they're taking, previous controls, prone to hypoglycemia and awareness, and access to care. The other factors are the factors that relate to Ramadan, because Ramadan, the duration of Ramadan tends to vary in different countries. In the UK, during the summer months, the fasting can be as long as 18 hours. And in countries like Norway, it can be more than 20 hours. Similarly, the weather, if it is going to be very hot, like it happens in the subcontinent and in some of the Gulf countries, that can have an impact. And then the personal factors, the occupation, the meal pattern, the exercise, which have been covered in previous talks. Now, in the UK, this is the guidelines that we published from South Asian Health Foundation UK about a couple of years ago during the COVID pandemic. And because the duration of the fast in the UK is very long, our guidance put anybody who's on any type of insulin at a high risk of fasting. And this is mainly related to the duration of the fast. The DAR idea of guidelines, which I was a part of, actually looks at insulin in a different way. So it puts insulin risk as no longer automatically assessed as increased, and risk is weighted according to the regime of the insulin use. Say, for example, if somebody is on multiple daily mixed insulin injections, they are put at 3. Basal bolus or insulin pump is lower at 2.5. Once daily mixed insulin is 2 and basal insulin 1.5. And these are the scores that are added to the idea of DAR risk calculator. And if it is between greater than 6, then the patients are generally advised not to fast. So what it means is if somebody is on insulin, but his other risks are not there, then they can fast. So what is the data that this is based on? So this is the DAR-MENA study, which is an international prospective study, basically looking at various insulin regimes, especially insulin regimens, and looking at the risk of hypoglycemia. And what it actually showed was that if you look at people of 4 weeks before Ramadan and during Ramadan, there is definitely an increased risk during Ramadan, but the risk is not high enough for us to discourage our patients from fasting if they are managed appropriately. So what has happened is that impact of optimum diabetes care on safety of fasting in Ramadan in adult patients with type 2 diabetes on insulin therapy. And what this study shows is that if there is an optimum diabetes care provided to the patients, then the risk of hypo, especially both with basal and intensive insulin therapy, is not really increased, which is quite reassuring. So the question is, how can we adjust insulin therapy? How do we individualize treatment? Where do we continue the current therapy, adjust doses of current therapy, adjust timing of doses, change to a different drug, change to different combination of drugs, change to different forms of current therapy, and a combination of the above. Now let us examine the evidence. Now the most important thing is to have practical considerations. Many individuals on insulin therapy elect to fast irrespective of their risk levels. And this has been shown in a number of studies and from a meta-analysis that the number of people who are insulin that continue to fast, although it varies from country to country, can be anything where between 50 to 70%. Care should also be given to the glycemic control. And this is very important. If somebody has got good glycemic control and are well motivated, the risk of hypoglycemia is reduced substantially. We should always individualize treatment, taking into account patients' educations, preferences, diet, and lifestyle. There are various recommendations from various authors about which insulin regime should be used and what are the adjustments that need to be made. But the important thing to understand is that when you're changing the insulin regime, make sure you do it much before Ramadan, as a lot of things can go wrong if it is done just before Ramadan, as non-adherence and additional support may be required. And the most important thing is the pre-Ramadan glycemic control will determine whether insulin dose reductions are required or not. So you don't have to consider reducing in every patient. So what is the evidence? So let us look at the basal evidence. Now, these are the observational trials have demonstrated safety with basal insulin when used in combination with oral agents, which is probably the most common insulin regime used in many places. Most of these studies have used analog insulin, and also it's important to emphasize, and this has been reconfirmed by a number of religious scholars of all Islamic thought, that administration of insulin either by subcutaneous, intramuscular, or intravenous routes do not cause a breaking of Ramadan fast. The Orion trial, with insulin glargine and glargine 300, showed a majority of the participants were able to fast for the full month of Ramadan. There was low incidence of symptomatic hypoglycemia and no episodes of severe hypoglycemia. And it demonstrated that glycemic control can be successfully intensified in Ramadan. Now, there have also been a number of studies that we've been involved in which we've used basal insulin along with a GLP-1 receptor agonist. And this has been our own studies, the Treat for Ramadan and others. And all these studies have shown when using liraglutide or lixisenatide, either with insulin or sulfonylureas, does not really increase the risk of hypoglycemia when you compare with sulfonylureas. And this is the study that was the Lexiram trial, which was led by my good friend, Dr. Rakesh Sai from India. And this actually showed in this trial, lixisenatide was used with a basal insulin glargine, along with sulfonylurea with basal insulin. And it showed that when it comes to all the markers, be it any hypoglycemia on treatment period, pre-Ramadan or during Ramadan, favored the lixisenatide and basal insulin combination. So what are we going to do in terms of, and when it comes to prandial insulin, again, it shows that it may reduce hypoglycemia. This is comparing insulin analogs with human insulin. And the prandial insulin analogs could be associated with lower risk of postprandial hyperglycemia as well when compared to human insulin. And insulin analogs are injected just before a meal or even after a meal, so can be administered at the time of iftar or suhoor instead of 30 minutes prior to the meal. When it comes to the premix insulin, which are the most common insulin regimes that is used, there is the options of using a higher dose of premix insulin at iftar and changing to alternative insulin regimes. Now, this is one of the most significant clinical trials. This is with Rysodec, the IDEC aspartate combinations. And this is from a randomized controlled trial, and this can show that Rysodec can be used safely in Ramadan. And statistically, it has lower incidence of overall hypoglycemia, about 74% reduction, and it demonstrates similar glycemic control. So what are the changes that are recommended in terms of the actual management? So when it comes to the medical management of premix insulin, the recommendation is the once daily dosing should not take a normal dose at iftar. If there is twice daily dosing, then take normal dose at iftar and reduce the suhoor dose by 20 to 40%. If 3 times daily dosing is there, then the afternoon dose needs to be omitted and adjust the iftar and suhoor doses. And this can be done through a titration regime, which is shown below. Where very high doses are used, a change of 10 to 20% of the dose may be more meaningful dose change. When you're using long or short-acting insulin, the recommendation is that the once daily long-acting insulin dose should be reduced between 15 to 13% and taken at iftar. And if it is twice daily, then take the usual morning dose, which may be the higher dose at iftar, and reduce the evening dose by 50% and take it at suhoor. With the short-acting insulin, the normal dose is taken at iftar, omit the lunchtime dose, and reduce the suhoor dose by 25 to 50%. The most important aspects of somebody who's on insulin and fasting is to check their blood glucose levels. The recommendations are merely to test the blood glucose levels at least 7 times a day, which is quite a bit, but it is highly recommended. And also to reassure the patients that testing the blood glucose levels during fasting does not break the fast. Now, with the presence of the continuous glucose monitoring, which I'm going to be checking briefly, this has been quite an important game changer. The other important thing is to what is called as a trial fast that can be done before Ramadan. In patients who are on insulin, it's highly recommended, as the patient will be able to actually see what is happening and modify their diet and fasting schedule. So in the next few slides, Mr. Chairman, we're talking about diabetes in Ramadan, how can technology work? A few weeks ago, we had a conference of the South Asian Health Foundation UK Royal College of Physicians, where the whole emphasis was on technology and how technology is making almost anyone with diabetes who wants to fast during Ramadan being able to do it safely. And we know the changing landscape. So instead of doing self-monitoring blood glucose, we are moving to either intermittent CGM or real-time CDMs. Instead of HbA1c, we are talking about the time in range. And there's the whole thing about the open loop, hybrid closed loop to closed loop systems. One of the important things to understand, and this I always emphasize, is the relationship between self-monitoring blood glucose and HbA1c levels. And this is in all people with diabetes. And what it actually shows is the more you monitor your blood glucose levels, the better the HbA1c it is. And especially in people who are of mature years. So therefore, monitoring of any kind will improve glycemic control. And we've got lots of options now these are some of the options that are available for us to do either intermittent or real-time glucose monitorings with scanning or without scanning, with clear alarms for hypo and hyperglycemia. The other question is that this is a very interesting study, basically looking at the insulin requirement in a pump during fasting in people with diabetes. And what you could see is the way it fluctuates during the fasting hours and non-fasting hours. This is again a study in glycemic control during Ramadan fasting in adolescent and young adults with type 1 diabetes. And it actually confirms that Ramadan fasting is feasible in people with diabetes using automated insulin delivery systems, which can achieve safe and significant optimization in glycemic parameters while minimizing hypoglycemia in a real world environment. So when it comes to the insulin pump therapy, the important thing is education. When it comes to the basal rate, it's usually recommended to reduce the dose by 20 to 40% in the last 3 to 4 hours of fasting and increase dose by 0 to 20% early after iftar. When it comes to bolus rate, normal carbohydrate counting and insulin sensitivity principles apply. So, in summary, insulin can be used safely in appropriately selected person. Now we have evidence of IDEC aspartate, rhizodite, glargine, U300 trio with lower risk of hypoglycemia. Insulin therapy must be individualized for patients considering basal control, education, preference, and diet. Self-titration and monitoring are essential if insulin is to be used safely. And the most important is education, empowerment, advanced technology, and new therapies can provide effective risk mitigation strategies for fasting with diabetes. The important and challenges that we have is health literacy, digital literacy, access to technology, and recent therapies remain barriers, especially in the developing world and the ethnic minority groups, even in UK. These are my references and these are my co-authors I would like to thank. Thank you very much.
Thank you. Indeed, that was a wonderful presentation about insulin modification and how to do during the Ramadan. That is just an example like how to do the modification during fasting. Also, we have learned about it. So now, if there is any more questions for Sir, then we can take the questions, or else let's move to the next session. So for the next session, I would like to welcome our Dr. B.M. Makkar sir. Basically, the next session will be on about the practical tips during fasting, what to do, what not to do. And after the earlier session about monitoring during fasting, our sir gonna speak a lot about glucose monitoring during the fasting. So, sir is director of Dr. Makkar's Diabetes and Obesity Center, New Delhi. He's the president of RSSDA, honorary secretary of IDO. He's also chairman of RSSDA Delhi chapter, member, executive board of Diabetes India. So he's a member of ASE International Committee, and so he's also a professor, business committee of ASE DSN from 2017 to 2020. So he's a course director for advanced certificate courses in diabetes in collaboration with Prevalent Clinic and ESD 2010 till date, and have a publications in a lot of books, national and international journals. So with this, I would like to welcome Dr. B.M. Makkar sir. So it's all yours now.
Good afternoon, everyone. Am I audible?
Yes, are you audible?
Thank you. Good afternoon, everyone. At the outset, I would like to thank Dr. Bansi and team for giving me this opportunity. And I am sure a lot of it has been covered about glucose monitoring during fasting by my previous speakers, and I was listening to the brilliant talk by Dr. Wasim. So a lot of things have already been covered, which makes my job simpler. But glucose monitoring remains an integral part of managing glucose, and is important whenever we are having situations when we are expecting a lot of fluctuations in the glucose levels, and fasting happens to be one of such situations. So I will share my presentation. Can you see my presentation now?
Yes, sir.
Okay. So the topic I am covering is glucose monitoring during fasting. I don't have any disclosures for this presentation. We all know that there are a number of religious reasons when fasts are observed, and most common reason for observing a fast is actually a religious reason. So although there are a variety of religious fasts across Southeast Asian region, the most important one happens to be the Ramadan fasting, which is the longest period of fasting that is observed in the Muslim religions. There are a number of religious fasts observed in India, but they usually are limited to 1 day a week fasting, which is 24 hours, and the duration doesn't exceed 24 hours. And the variability of duration of every phase of fast makes it very difficult to study the changes in physiological responses, that especially in people living with diabetes. There are a number of Hindu fasts, though they are not mandatory. Most Hindus observe day-long or week-long fasts, and some of them are very commonly known are Karwa Chauth, Guru Purnima, Ekadashi, Makar Sankranti, Holi Ashtami, and so on. And some of the Hindus observe fast 1 day every week. It doesn't need to be a religious reason. Some people are observing fast on Mondays or Wednesdays or Fridays or Tuesdays. And then there are reasons which are, like Navratris, when there is a fasting period of 9 years, which happens twice every year. And the fast is observed from dawn to dawn, that is the sunrise to moonrise or starrise. So daytime fasting period. There is another fasting period which is called Prayushan, which is observed by Jain community. The fast is for a period of 8 to 10 days, but it is different from other Hindu fasts that the fasting period is from the dusk to dawn. And then, of course, we have Ramadan fasting, which goes through a period of month, which is the 9th lunar month of the Islamic calendar. Fasting during Ramadan is one of the
5 pillars of Islam and is obligatory for all healthy Muslims from the age of puberty. Though individuals with some illnesses and serious medical conditions, which include some people with diabetes, can be exempted from fasting, or people having acute infections or pregnancy, but many of them still fast anyway. So it is of paramount importance that people with diabetes who are fasting are given appropriate guidance and receive proper care and are able to manage their glucose levels nicely through the fasting period. Recently, International Diabetes Federation, Diabetes and Ramadan International Alliance have provided a substantial update on previous guidelines on Ramadan fasting. We have a small, component of fasting and diabetes in the recently published RSSDA clinical practice recommendations for managing type 2 diabetes. Now, what happens when somebody is fasting? So fasting or food abstinence, which is for a defined period, initiates a number of metabolic and physiological changes and adaptations that need close monitoring. So the very fact that there are changes in the physiological processes and there are metabolic adaptations happening, this leads to changes in glucose levels, which needs to be monitored, because if we don't monitor glucose, we don't know what is happening. And this is especially important in people with derailed metabolism, conditions like diabetes, and people with diabetes or pre-diabetes must fast only after appropriate risk assessment and counseling with healthcare practitioners as well as religious leaders to inform decisions. Now, hypoglycemia and dehydrations are the major common complications during fasting, and they are associated with fasting through, though hyperglycemia may also occur due to the overindulgence in food during the meals. In individuals with diabetes, insulin resistance and or insulin deficiency can lead to excessive glycogen breakdown and a surge in the gluconeogenesis or ketogenesis, especially in people who are poorly controlled as far as the glucose control is concerned, leading to sudden hyperglycemia, ketoacidosis, dehydration, and even thrombosis in some of the cases. So these things have to be kept in mind when we are looking at people with diabetes who are observing fast, especially for the prolonged period. Now, for monitoring glycemic control, we have different tools. The most commonly used ones are the SMBG, A1C, fructosamine, and continuous glucose monitoring. Now, during the fasting period, the tools like glycated hemoglobin, which is giving you average glucose over 3 months period, and fructosamine test, which will provide average glucose over preceding 2 to 3 weeks, are not much of use because you want to see the glucose changes happening day-to-day basis. So the most important tools are SMBG and the continuous glucose monitoring. Now, for SMBG to be useful, we have to use it in a structured way. That means we have to monitor glucose at the right frequency, at the right time, and in the right situation. And this is what is the structured testing. So SMBG is testing and recording of blood glucose either by patient himself or carer. Specialists need to be predefined, and it is critical for managing patients with diabetes to understand their glucose levels in the real time. SMBG gives you at that particular point, it gives you a real time value, and if you are doing it at multiple points, it gives you an overall picture of how much glycemic variability is happening and gives insights into how diet, exercise, and medication are impacting the glucose levels and what needs to be modified. So it helps in informed therapeutic decision making. So structured SMBG is basically nothing but a methodical approach to blood glucose monitoring at predefined level times every day to understand a blood glucose pattern throughout the day and how it is impacted by diet and exercise, and making the therapeutic adjustments based on those understandings. Now, these are the glucose graphs during Ramadan in people with without diabetes, healthy individuals. So if you see there is not much change that happens during Ramadan period. There is a small spike which happens if after iftar, which is usually the heaviest meal, but it still stays in the normal range, and there is not much variation happening in people who don't have diabetes. But what happens in people with diabetes who are fasting, especially those who are on insulin or glycemic or oral anti-diabetic agents like sulfonylureas, there are sharp fluctuations, especially after the meals, if the dose is not properly matched or not, planned in advance. And there are wide fluctuations, and these people may have high risk of hypoglycemia as well as hyperglycemia. So if you look at the key components of the focused education program for during fasting, the guidelines clearly recommend that blood glucose monitoring has to be in place. And it is an important component of not only education for people with diabetes, but also for managing diabetes during the fasting phase. Now, diabetes and Ramadan guidelines suggest that you have to measure glucose 7 points of time, especially in people who are on hypoglycemic agents or insulin. And it has to be right from the beginning of pre-dawn meal, before the meal, then 2 hours after the meal, then in the noon time, to make sure that there is no hypoglycemia happening, then in the late afternoon, before the evening meal, after the iftar meal, and again anytime when there is a person having any symptoms suggestive of hypoglycemia or any feelings of being unwell, so which may be due to hyperglycemia, dehydration, impending ketosis, and so on. SMBG helps clinician and patient to achieve the desired level of glucose, helps preventing hypoglycemia and hyperglycemia, and helps ensuring safety of the patients, empower patients to take care of their own treatment, make adjustments in their lifestyle and medication and diet also. But it has certain limitations. It requires repeated finger stick to obtain a blood glucose level, only provides a single point in time measurement, no information about what is happening in the glucose levels before and that, after that particular time of testing, and may result in inappropriate decisions if it is not testing. And it also is dependent on the patient decision to self-monitor. Patient thinks I'm feeling well, I don't need to test, so patient will not test. So as I mentioned, when you are doing SMBG, you are testing at certain points of time and you have real-time glucose values. But if you look at the way the glucose variability may be there, you may be missing a lot of information in between those points of testing, and patient may be actually getting into hypoglycemic range as well as hyperglycemic range. And that is where the role of newer techniques like continuous glucose monitoring comes. So SMBG is like a ECG, which gives you a fixed graph, and you don't know what is happening before and after that. While CGM is like a Holter monitoring, which is telling you how the heart beat or heart rhythm is behaving over 24 hours or 48 hours period. We also know now from a number of studies that glycemic variability in patients with diabetes is associated with increased risk of hypoglycemia, increased risk of micro and macrovascular complications, and mortality independent of the glycated hemoglobin level. So we have to control glycemic variability also, which is an important part of managing diabetes. Now, if we compare SMBG, and look at the various parameters where it is not helpful, doesn't tell us much detail about the glycemic variability or the rapid glycemic variations, and it also doesn't give us the direction in which the glucose changes are progressing. And the overall reliability of data can be limited because it is operator dependent also, and enables it doesn't help us having the kind of management of diabetes that can be achieved with more frequent monitoring or something like continuous glucose monitoring obtained information. It also does not tell us how much time is being spent in the desired range of glucose values by the individuals during 24 hours period. While on the other hand, if you are using a continuous glucose monitoring tool, you can have the information relating to the wide fluctuations in the glucose levels, the variability of the glucose level, and also, overall profile, whether the glucose levels are in the range, they're going up, they're going down, and so on. And the major goal of monitoring is to keep the people with diabetes for their glucose levels for maximum time and range. So the idea is to increase the time and range, decrease the time above range, and certainly decrease the time below range where there is risk of hypoglycemia. And the normal recommended ranges in people with type 1, type 2 diabetes, we all know, is that we should have most of the time glucose values in range of 70 to 80, 180 milligram per deciliter, at least for more than 70% of the time. And the range below, time below range should not exceed more than 5%, of which not more than 1% should be level 2 time below range, which is the range of glucose levels going below 54. So now we have smart CGM tools which can connect, where a sensor is applied to the individual and is constantly giving you glucose values ranging between every 5 minutes to 15 minutes, which can be seen on your phone or on a controller in Libre Flash. And these tools not only give you an idea of how glucose variation is happening in the preceding few hours, they can also tell you an overall trend where the glucose is going up. So it shows that glucose level is rising from here or declining from here, and it can also show you glucose is high or low. And this tool with Libre Flash, it also has the ability to measure glucose using a stick or measure ketones also. So there are tools now available which can help us monitoring these people nicely and preventing severe hypoglycemia, severe hyperglycemia, and reducing the glycemic variability. This is, from the RSSDA Clinical Practice Recommendation Guideline 2022, which clearly states that during the fasting, the one should test blood glucose level regularly and frequently, especially if one is feeling unwell and if there is symptoms of hypoglycemia. And self-monitoring blood glucose should be tested as prescribed by the healthcare provider. Fasting is observed. Now, if you look at the guidelines for diabetes and Ramadan guidelines, this has given a risk score. And if you look at the risk, overall risk during the fasting period, the total risk of more than 6 is considered high risk. And if you look at the self-monitored glucose, if it is not being performed as indicated, then this adds 2 points to the risk score. So this is the importance of monitoring. If you are not monitoring well, you are actually significantly increasing the risk associated with fasting. Now, this guideline further states that SMBG must be performed regularly throughout the fasting hours and whenever there are feeling of being unwell. And if accessible and available, CGM or flash glucose monitoring should be the preferred method of monitoring blood glucose levels as compared to the glucose meter measured SMBG. With that, I conclude my presentation. Thank you so much for having me. If there are any questions, I'll be happy to take that.
Thank you, sir. It was a wonderful presentation. So with this, I would like to welcome my co-chair, Dr. Abdullah Al-Hamak.
You are muted.
So you are muted. Please unmute yourself.
Thank you so much for this visit. If there's any question for Dr. Mukhtar, okay, they can write it down in the icon of questions. Okay, let us start with the second one, the second speaker. Okay, so okay, I'm very delighted to introduce Dr. Parasite from Sri Lanka. Dr. Parasite is as MBBS, MD, and FRCD from London, and also from University of Columbia, graduate, National Hospital of Sri Lanka. He's a professor in medicine, University of Colombo. He is a consultant endocrinologist, National Hospital for Sri Lanka, past president, Endocrine Society of Sri Lanka, past president, Diabetes Federation of Sri Lanka, over 150 research publications in peer-reviewed international high-impact journals. He's epidemiology of diabetes and NCDs, and also is in preventions of diabetes and diabetes remission. And also his expertise in diabetes genetics and thyroid disease. So please join me to welcome Dr. Parasite. Dr. Parasite, the floor is yours now. Are you there, Dr. Parasite? Parasite. Okay.
Good afternoon. Greetings from Sri Lanka. First of all, let me thank Bansi and the other organizers for inviting me to talk to you on this topic, the structured education during Ramadan fasting in this IDF and the DASG symposium. This is the structure of my talk today. And if you look at the Muslim population in the world, this is about nearly 2 billion, and this comprises about 25% of the world population. So any matter that relates to the health of the Muslim population is very important in the perspective of the global health. If you look at the religious perspective of the Ramadan fasting, this is considered an act of spiritual health by Muslims, and then they consider it's a religious obligation. However, according to the Holy Quran, particularly people who are at risk of fasting, like the pregnant women, nursing women, those who are sick, and those who are traveling children are exempted for obvious reasons. Although the Holy Quran exempts such groups from fasting, majority of the Muslim diabetic patients still want to fast during Ramadan. And this has created a new challenge, a medical challenge, particularly for the diabetic fraternity. And the effects of the Ramadan fasting on glycemic control is variable. Some epidemiological studies have looked into the effect of Ramadan fasting on the health of the diabetic people, and particularly the EPIDA study is a large study which has looked into over 10,000 people in 13 countries, predominantly Muslim countries. They have looked on the epidemiology of the diabetes and fasting, and they have shown that about 43% of the patients with type 1 and 79 with type 2 wants to fast or reported fasting during the Ramadan. And also they have also shown that there's an increased risk of hypoglycemia, which is about 4.7-fold in type 1 and about 7.5-fold in type 2, as well as increased risk of hyperglycemia and the emergencies like DKA in people who are fasting, particularly those with type 1 as well as type 2. And also these studies have shown the increasing the importance of the Ramadan fasting and the importance of the medical healthcare professionals to be aware of the potential risks of fasting for their patients, and also what efforts they should be taking to mitigate these risks. There are several myths about the Ramadan fasting among people, and they think that everyone, irrespective of the physiological status,
or pathological states like illnesses should fast. And also they feel that blood testing should not be done during fasting, and also they think that insulin injections, if needed, should not be given during fasting. And some people think that fasting should not be broken at any cost, even at the risk of their own health. So if you look at the potential and the probable as well as definite health complications due to fasting associated with Ramadan fasting, definitely I have already shown the risk of hypoglycemia as well as hyperglycemia, and then risks of diabetic ketoacidosis as well as hyposmolar status in type 2 people, and then possibility of dehydration and associated increased thrombotic risks as well as ketosis. Therefore, ladies and gentlemen, we need to have a multi-pronged program to mitigate these risks for our patients, Muslim patients with diabetes. We should have an awareness campaign to get the support of the religious leaders, the community, and the healthcare professionals, and the patients themselves and the families, the carers, for such a program. And then we need to have a structured program for the healthcare professionals as well as a structured program for the patients and their families. So, proper diabetes Ramadan care plan should constitute a pre-Ramadan assessment and the structured education and care plan as well as the post-Ramadan assessment. If I take you through such a program, the overall aim is to reduce the risks of both hypoglycemia as well as hyperglycemia in our patient. So we need to start this process several weeks, ideally about 4 to 8 weeks before the Ramadan, and then we need to get the patients for risk assessment to see whether they are really fit to fast during the Ramadan period. Are there any factors that hinder them from the safe fasting? And then after that, we need to decide whether if they are at high risk, we should try to get them not to fast at least this year. And if they improve their health, we can say you can fast next year. If the people have low to moderate risk, we can allow them to fast with adequate precautions. And then we need to then give them proper education about do's and do nots during the fasting, as well as discuss about the meal plans, exercise, hydration, nutrition, sleep, and also about the needs of possibilities of changing medications and the timing, and also we need to look into their individualized management plans, the review plans, and also how they can get help if it is needed. And we should always try to give them some, fallback options, who to contact if problems arise. And here is a standard risk categorization for Ramadan fasting, where based on their risk for hyperglycemic emergencies, excursions, hypoglycemia, ketosis, infections, organ failure, complexity of insulin regimes, and other support, and their mental status, we categorize them as very high, or moderate to low risk. And this categorization is very important on allowing or not allowing them to fast. And the components I have already touched upon that. Of a structured education program should include meal planning, physical exercise, glucose monitoring, if possible or needed, ketone monitoring, on recognizing and managing hypoglycemia, hyperglycemia, and the dosage and timing of medications, and when to stop fasting, as well as on the other sick day rules. Coming to some specifics about meal planning and dietary advice, we should generally tell them that you should not deviate greatly from your usual healthy balanced diet. This is very important. And also, particularly since they take quite a bulk after the breaking fast time in the evening, and also during the night, during the prayer times, we should encourage them to have less or slow energy release foods such as whole grain wheat, semolina, whole unpolished rice and beans and cereals and so on. And also we need to make them healthier by also encouraging other healthy options like low fat diets, discouraging high fat saturated fats, and also particularly we should discourage harmful dietary practices like high volumes of high carbohydrate rich kanji or porridge. They take big volumes of porridge. I have seen sometimes in our patients sweetened beverages, sweets, short eats, which they take during breakfast time. Then physical exercise should be generally encouraged. What should be encouraged is light or moderate exercise on a regular basis. And also they should generally avoid rigorous exercise, unaccustomed exercise, as well as exercise during hot, humid times and under the hot sun. And also, I have already briefly touched upon this. We need to get some help through the local GPs and other healthcare workers or the nurse assistants, educators, and about need of medication change and other assessment, including the SMBG, and ideally a fasting assessment of A1C, creatinine, electrolytes, and will be helpful. We need to also stress upon that the blood glucose monitoring is not prohibited during the fasting period. And also, if the patient is not already trained, they should be equipped and trained on self-monitoring of blood glucose, and also should be encouraged to check as necessary, and they should be given individualized plans. If available and affordable, newer techniques like CGMS, flash monitoring has been shown to be safer and also more useful compared to conventional monitoring. This is a very typical sort of a very labor intensive monitoring that is usually good for high risk people with type 1 diabetes. 7-point monitoring has been suggested, but again, this might have to be individualized based on the patient's risk as well as the patient's willingness and the affordability and so on. And also it is important to empower people to recognize and manage complications, both hypoglycemia and hyperglycemia, and also they need to be told when to break the fast, and also they should be told about the need to seek for help whenever it is necessary. And then I told you about the times that they should know when to break fast, particularly if they are going into hypo, glucose less than 70 milligrams per deciliter, or if they are going into hypoglycemia, glucose going above 300 milligrams. And also if they develop any acute illnesses, infections, any psychological issues, as well as deterioration of the general health and well-being, both physically and psychologically, should be considered factors to consider breaking the fast. And people who drive for occupation or other reasons should be also assessed for the safety of driving for the patient as well as the others, very important. And also again particular education on recognizing and avoiding hypoglycemia, and if they deliberately miss meals, or if they deliberately take too much medications to control the risk of hypoglycemia, and these sort of things should be addressed with the driving people. And particularly, we need to have special characteristics of a structured education program. It should be delivered in the patient's own language, not in another language. This is ineffective if you deliver this in another language. And also should involve the patients, carers, healthcare professionals, as well as religious leaders, and also particularly the diet and other things should be delivered in ethnic specific educators, dietitians, or nurses.
Now, coming to the end of the Ramadan fasting, the people have a festive called the Eid al-Fitr. The Eid is a very highly celebrated festival where there's a lot of sharing of food, overindulging, eating, drinking, especially sweetened beverages. Therefore, the educators and the education should particularly target this period, because this is a period where people can go into hyperglycemia and DKA, as well as hypoglycemia if they try to self-medicate to counteract the high carbohydrate and glucose load. So after the Ramadan period ends, we should have the post-Ramadan assessment to reinstate them back in their previous regimes, if appropriate, with necessary adjustments, and should look into what has happened to them during the Ramadan period, glycemic assessment, whether they had hypoglycemia, DKA, HHS, infections, deterioration of general health. How did they cope with the Ramadan fasting? All of which will be very useful in deciding how and the manner they should be fasting in the next fasting period. And it is also very important that in all of our care plans during Ramadan fasting should nicely harmonize with what is told by the religious leaders and the fraternities, and the medical and religious fraternities should work hand in hand in the same language, in the same tone, so that the people will not have misunderstandings and the conflicts. And particularly this is very important in the countries where there is non-Muslim predominant countries, and particularly when the healthcare is delivered by non-Muslim or non-Islam healthcare professionals. They should understand the context, the religious importance of fasting, as well as the beliefs and the faiths of their patients. And they should always empathize with the patients, and also understand the potential risks and how to mitigate them during the fasting. And here there are the recommendations given for changes in the medications during fasting. Since there is there's separate standalone lectures on this, I'm not going to detail, but the principle is that the patient should not go into hypoglycemia in the prolonged fasting period, as well as they should not go into hyperglycemia, particularly during the period they predominantly take calories from the evening, the breakfast to the dinner, generally at late night. So the medication dosages and the timing should appropriately change to prevent both hyperglycemia as well as hypoglycemia. Pregnancy is an important period, and usually people who are pregnant or nursing are exempted from fasting. But if somebody who is pregnant and want to fast, then we need to respect their wishes. But however, if they are at very high risk, we might have to speak to the family and also get the help of the religious leaders in showing them the dangers, and also telling them that once they complete a successful pregnancy, they can always fast the next year. And again, similarly, people with other comorbidities like the chronic kidney disease, congestive cardiac failure, because they are also on medications like diuretics, they are at high risk of hypovolemia, as well as they are frail. Sometimes they can go into hypoglycemia and their overall health can deteriorate. So we need to carefully assess them to see whether they are really fit for fasting, and if not, should we discourage. If they are not very sick, if they are very keen on fasting, we should try to help them with support and intensive and close monitoring and support and necessary modifications. And there are several education programs that have been done in the world. I would like to highlight this READ program, Ramadan Education and Awareness, which has been done in the United Kingdom. And this has been done as a study. They have taken one group who followed the program and the other group who did not follow the program. And you can see the comparison of the two groups. the group A, who had the education, had the slightly, reduction of their weight, whereas the other group had weight gain. Again, hypoglycemia was less in the group that had the education, which was the otherwise in the group who did not have the education. And even at 1 year, those who had the education had stable, unchanged HbA1c, whereas the group who did not have the education had increased their HbA1c. And even in those who had hypoglycemia, it was predominantly in patients who was on sulfonylurea in this group who followed the education. And then we can see that the benefits of a good education program in Ramadan has over-lasting effects even beyond Ramadan. So, ladies and gentlemen, Ramadan fasting has huge implication on the health of our Muslim brethren, Muslim patients. And then we need to start the evaluation before Ramadan to make sure that they are well prepared and safe for fasting. And a structured education program should involve the patients, their carers, the healthcare professionals, as well as, when it is needed, religious dignitaries. And then the education and other adjustments should be individualized based on the type of diabetes and the comorbidities and the social and economic context and the facilities available. And then we should make Ramadan fasting an opportunity for improving their overall diabetic status and the overall health of the patient as well as the community. And again, let me thank Bansi and the organizers for inviting me to talk to you today. And also I wish happy fasting period for our Muslim colleagues, which is going to come very soon. Thank you very much again.
Thank you so much, Dr. Barasat, for this interesting presentations. I will give the floor for my co-chair, please.
Okay, so just moving on to the next topic, like we have learned about monitoring and structured education during fasting. So now, even though after learning a lot, we do find sometimes some hypers and some hypos in our patient who are in people living with diabetes who are having fasting. So to explain and to give some practical tips, I welcome Dr. Sanjay Agarwal, sir. He is a fellow for American College of Endocrinology. He is a fellow of American College of Physicians. He is an honorary secretary, Governing Council of National RSSDI. He is associate editor of International Journal for Diabetes for Developing Countries. He is a member of the writing committees for RSSDI guidelines on inpatient management of hyperglycemia, consensus on glucose monitoring in type 1 and type 2 diabetes, RSSDI ESA clinical practice recommendation for type 2 diabetes patient, guideline on the management of diabetes and heart failure, diabetes and oral health, diabetes and thyroid disorders. He is an author for the book called Clinical Atlas in Diabetes. He is a chief editor for RSSDI Insulin Monograph. And is a faculty at various national and international meetings. And he's also a mentor for postgraduate programs. So with all this, may I welcome Dr. Sanjay Agarwal, sir, for his deliberation. And the floor is all yours, sir.
Thank you very much, Dr. Ghosh, for this kind introduction. And I would like to thank Dr. Bansi Sabu and the organizers of the meeting for giving me this opportunity to present my lecture today. I'll just share it, and I hope you can see my slides.
Yes, sir.
Yeah, thank you so much. So today I've been asked to speak on hyperglycemic and hypoglycemic responses during fasting. And some of this data has already been presented by the earlier two speakers. So I'm going to reiterate some of that data as well as present some new data as it comes in, to assess how do we really need to look at fasting as we do in patients with diabetes. Now, if you look at the CREET study, what it really did tell us that 94.2% of Muslims with diabetes tend to fast, and they tend to fast for more than or equal to 15 days. Now, when you break that down, you can find that, almost about 67.6%, that's the vast majority, almost about 2/3 of them tend to fast every day, and about 1/3 tend to fast close to, more than 15 days, but not every day. So obviously, patients who tend to fast
tend to have special challenges when they have presence of diabetes. Now, this was also reiterated by the Dietary study, which said that almost 79% of Muslims tend to fast for at least 15 days during Ramadan. Now, how does the body respond to general fasting when you tend to fast for a prolonged period of time? Now, usually the earliest response is glucose mobilization. If you look at the first graph, it is when you eat food, your immediate response of glucose absorption tends to occur from the gastrointestinal tract in the postprandial and the post-absorptive period. Now, when you fast, in the postprandial and the post-absorptive period, you tend to get more of a glucose uptake by the liver and the muscle and storage in the form of glycogen. And of course, the other tissues sort of converted, into amino acids, fatty acids, and all those things. Now, when you have fasting, there is a remobilization of glucose that tends to happen into the bloodstream by the breakdown of glycogen, and there's a gluconeogenesis that tend to happen. And the first thing in response to prolonged fasting is there is a glycogenolysis that happens. When your fasting continues, there is a conversion of amino acids to gluconeogenesis, and that's where then there is a sustenance of glucose metabolism that tends to happen. And in prolonged fasting, you have a conversion of fatty acids to ketones, and then ketones becomes the fuel source. So if you look at the last sort of slide, the last part, you find that there is a prolonged ketonemia that tends to happen to maintain the energetics because of lack of glucose in the circulation. Now, how does it respond in patients who are, obese versus non-obese and in genders? You find that as glucose tend to go down, men or women, the free fatty acids tend to go up and the ketones tend to go up. And they sharply increase more in women obese subjects. The insulin tends to come down, the glucagon tends to go up, and the growth hormone tends to go up. These are sort of responses to fasting. And the growth hormone response is more marked in women obese subjects as compared to men obese subjects. Now, what are the other effects that tend to happen? There's a weight loss that tends to happen in both the sexes in obese, and not so much in non-obese. The total urinary nitrogen excretion tends to increase, and the urinary mineral excretion, whether it's calcium, magnesium, phosphorus, sodium, potassium, tend to go up. And this is more marked in non-obese subjects, and whether it's men or women. Now, this graph was already shown by Dr. Brijmakkar, and in normal subjects, you can see here that there's hardly any glucose variation, because in response to fasting, there is a mobilization that tends to happen, and there is not much of a glucose variability that happens in the bloodstream because of the counter responses to maintain blood glucose levels in the blood. But in patients with diabetes, you tend to get, a sharp response of lowering the blood glucose towards, the pre-iftar time, when there could be accentuated hypoglycemia. Now, this is more marked when somebody is on a secretagogue or an insulin, where this hypoglycemic response may be happening. So, and then this hypoglycemic response is countered by a hyperglycemic response. Now, they may be because of counter-regulatory hormone levels, or because of eating at that point of time during iftar, when you get a hyperglycemic response. But what it tells you is a failure of compensatory mechanism to happen during the fasting period, where you can get a hypoglycemic response because of inadequate responses for gluconeogenesis. Now, key risk factors associated with fasting is hypoglycemia, hyperglycemia, presence of ketoacidosis, or because of inadequate circulatory volume, there could be dehydration and thrombosis. Now, all this sort of increases the risk of fasting and fasting-related complications in patients with diabetes. I just want to talk about hyperglycemic responses as we see. And you can see here that in meals in iftar are calorie dense, and they cause a significant and rapid rise in the blood glucose levels. In the EPIDARE study, it showed that hospitalization for severe hypoglycemia were increased in patients with diabetes. And this was not only for type 2 diabetes, but it was also significantly, or it was increased insignificantly for individuals with type 1. But there was a tendency for increase of hospitalization even in type 1 subjects. If you look at the hypoglycemia in the EPIDARE study and the number of severe glycemic complications per month, you find that there is a non-significant tendency to increase during Ramadan in type 1, but they were significantly a bit on the higher side in type 2 patients and in the overall population. But patients who fasted for more than or equal to 15 days, severe hypoglycemia and ketoacidosis were sort of non-significantly increased in type 1 during Ramadan. And they were marginally sort of, increased in patients with type 2 again during Ramadan. This was an interesting paper in the Saudi Pharmaceutical Journal, which said that higher rates for hypoglycemia than hypoglycemia were noticed in Ramadan fasting in patients with uncontrolled type 1. This was a pilot study which involved adult patients with uncontrolled type 1, A1C of more than 7%, who insisted on fasting during Ramadan, and the patients who were from the Maternity and Children's Hospital Medina in Saudi Arabia. They were all put on Medtronic CGMS that was used to monitor the glucose levels for 3 consecutive days during fasting. 22 patients were enrolled. Mean age was 22 plus or minus 6 years, and they had a duration of 10 years, almost up to 10 to 11 years. And the mean A1C was 9.3. What did this show? That basically most of the patients use a basal bolus, except for one patient who was on pump. The sensor glucose profile typically followed a pattern which was characterized by exaggerated increase after iftar, which was a sustained overnight, and second, rapid rise after suhoor with a prolonged glucose decay over the daylight hours. The average sugar levels were around 200, and there was a higher rate of hypoglycemia, 48%, than hypoglycemia. These were all in type 1 patients. So what are the factors that contribute to higher risk of hypoglycemia? They are probably because after iftar, people tend to have a more carbohydrate-heavy meals with fried foods. They tend to have high saturated fats. There could be more consumption of sweet drinks and desserts. Patients may tend to eat more at suhoor to avoid hypoglycemia in the day. And perhaps people may sort of readjust the insulin levels and probably down titrate it to avoid hypoglycemia. So because of inappropriate reduction in the insulin as compared to the blood sugar responses, you may tend to get a hypoglycemia that may happen. Also, physical activity levels tend to fall during the daytime of Ramadan. Let me talk a little bit more about hypoglycemia. It's usually because of decreased food intake, which is a well-known risk factor, and rates of hypoglycemia are several folds lower in patients with type 2 diabetes when you compare it with type 1s. This was, a prospective cohort study by Lok et al., who reported that rates of hypoglycemia to be 1.6 times higher during fasting compared with non-fasting periods. And this was more in type 1 patients as compared to type 2. In the CREAT study, it showed that hypoglycemia incidence during Ramadan was associated with significantly increase of, hypoglycemia during. It showed that hypoglycemia incidence, which happened before Ramadan, was associated with significantly increased risk of hypoglycemia during Ramadan. So if patient tended to get hypoglycemic episodes before the onset of Ramadan, then they were at a higher risk for development of hypoglycemia during Ramadan. And in the EPIDARE study, type 1 and type 2 patients had a 4.7-fold and a 7.5-fold increase respectively in severe hypoglycemia during requiring hospitalization. This was also possible because if patients were on sulfonylurea or insulin, then there was a significantly higher incidences of hypoglycemia. And if patients were on sulfonylureas and more than or equal to 2 anti-diabetic medications, then there was a significant increase in the MAGE excursions. Remember that the higher number of combination pills and if insulin was part of that, then people tend to have a higher rates of hypoglycemia. Some of the other factors that influence hypoglycemia during Ramadan is, of course, seasons. So in warm weather, people tend to eat less. In cold weathers, people tend to eat more. Then geographical locations in tropics versus temperate climates. Fasting duration, so you tend to get longer days during summer, so the fasting period tends to increase, whereas in winters, the fasting duration tend to be smaller. Time since diagnosis, so longer the duration of diabetes, the higher risk that you tend to get. Gender, anthropometric measures, dietary behaviors, and pre-fasting educations are all possible risk factors which can cause hypoglycemia. This was an interesting study which said that diabetic hypoglycemia during Ramadan fasting, and what this mentioned was this was a cross-sectional multi-country observational study enrolling approximately 1,800 population. They were majority from North Africa, Arabian Gulf, Saudi Arabia, and Indian subcontinent. And hypoglycemia was reported in 290 patients, which was approximately 16.8%. They were particularly affecting people with type 1 and in insulin-treated patients in general. And age was significantly lower in the hypoglycemia group. Now, these are the typical patient responses to hypoglycemia. And you can see here that, they contacted the nurse educator, omitted some medications, got urgent appointment to the clinic, continued the same but stopped observing the fast, did nothing, increased frequency of blood glucose monitoring, attended primary care doctor, or reduced or changed the frequency of dose. So in majority of the people, they tended to, almost 2/3 people tended to break fast. Although they broke their fast, they really did not report to the emergency room and they did no action on it. So this was a very interesting thing that really came out of it. Some of the commonest responses that came out of the study was reducing the dose or frequency of medications, attending primary care providers, which was about 25%, and increasing the monitoring, which is about 20%. And fasting was interrupted by only 67% only of those who experienced hypoglycemia. Recourse to emergency services was pursued by less than a quarter. And in the country-wise analysis of the rates of hypoglycemia, the greatest was in Egypt in about 51% and lowest in Pakistan, which was about 3.5%. It is important that patients should be educated to recognize the symptoms of hypo and hyperglycemia, and this should be always a counseling session before they decide to undertake the fast. And if they realize that there is a problem and they're at a high risk for complication, then they should be dissuaded. Or if they do undertake the fast and develop any symptoms, then they should break the fast. I think this was already alluded to by the previous two speakers, that we need to test the blood glucose more frequently. 7 times is what is recommended, and this was already mentioned earlier. A little bit about elderly populations. So people who are more than or equal to 65 with diabetes were significantly more likely to break the fast than younger, less than 65 years. And fasting-related complication seems more likely in elderly with diabetes, and that can be due to hypo or hyperglycemia. And this is more marked in patients who've got impaired renal function. Choose your medications correctly. Make those adjustments to lower the risk of hypoglycemia. And this is the rest of it has already been talked to by the earlier speakers. So when you use secretagogues or insulin, choose the appropriate dose and monitor your patients more closely. As far as possible, use drugs which do not cause hypoglycemia. Some of the patient education that needs to be rolled out: eat a balanced diet during non-fasting hours, stay hydrated, monitor blood glucose levels, break the fast gradually. When breaking the fast, start with a small meal containing complex carbohydrates, proteins, and healthy fats, and avoid sugary foods and drinks. And exercise regularly during the non-fasting hours. So this is to prevent hypoglycemia. And to prevent hypoglycemia, again, more or less the same thing. And you need to monitor blood glucose levels, hydrate adequately, and adjust your meal timings. I just want to end up by saying that Dr. Bridge-Makkar did tell us about the RSSDI guidelines and the risk profiling. This is the IDF and DAR risk categories, and they have got 3 categories where category 1 is very high risk. So all those patients who fall in any of these risk categories should probably, be asked not to really undertake the fast. They should be evaluated very carefully if they insist on it, and they should be educated. Then you've got, of course, the high risk categories. Again, you need to have all these people who belong to that high risk category, and they should be educated, ask again to monitor the blood glucose, and they should be prepared to break the fast in case of complications. And in case they develop worsening of any medical condition, then they should be told to stop. And then, of course, the third category was the moderate and low risk, where you can give structured education, ask them to continue the fast, and you can adjust the medication dose. Some of the people who should be asked to avoid fasting are people with A1C of more than 10%, ladies with pregnancy and lactation, acute peptic ulcer, severe bronchial asthma or pulmonary tuberculosis, cancer, cardiovascular disease, recent angina, or myocardial infarction and hepatic dysfunction. So I just want to say that fasting in culture can be used for protest, therapy, or prayer. The decision by an individual to fast must always be respected, but educate him and guide him to the best of our ability so that we can make it safe for him. Thank you very much for your patient listening.
It was indeed a wonderful presentation. So if there is any question, you can take the question, or else I will hand over to my co-chair to introduce the next speaker.
Is he here?
I think we will let the audience to put their questions in the icon of the chat icon. So let us proceed now with the last speaker, Dr. Bijawit. Dr. Bijawit is the General Secretary of Diabetes in Asia Study Group, and he's also the Project Director of Center for the Global Health Research, a consultant diabetologist, and Director of the Santinongar NH Center in the Bangladesh Association, Diabetes Association. Completed his diploma in diabetes medicine from UK and his PhD from University of Oslo in Norway. He took advanced training in diabetology from Newcastle Diabetes Center, UK, and in Australia. He's working out in Center for Diabetes Strategies, Prince of Wales Hospital in Sydney, Australia. And I think it's a lot of things that we just for the sake of the time. He's also the curator of National Diabetes Guidelines and COVID and Diabetes Guidelines, Guidelines 2019, and the Conception Care Guidelines. He authored about 50 international publications. So please join me to welcome Dr. Bijawit, my friend and my colleague, Dr. Bijawit. The floor is yours now. You can proceed.
Bishwajit, welcome. And thank you, Abdullah, for kind words of introduction.
Dr. Bijawit, he's going to talk about the fasting in special population, especially in type 1 children. This is the title of his presentation. Bijawit.
Yep. Can you hear me?
Yes, yes.
And my slide is visible?
Yes.
It is not working great.
Hello. So your slides are not visible. Please share with me.
Is okay?
Yes, sir.
Yeah. Thank you, speaker, for your kind introduction. And respected chairs and all the audience, good afternoon. The title of my presentation is Fasting in Special Population. This will include type 1 children, pregnancy, and with comorbidities. But before going to my presentation, I would like to give my sincere thanks to Dr. Bansi Sabu, Chair Elips, IDF Southeast Asia for organizing this webinar and also invite me for this presentation. So I am starting with type 1 diabetes and fasting. So like the type 2 diabetes, type 1 diabetes also increasing worldwide. If you see the data by the IDF Diabetes Atlas 2021, they reported that the 1.2 million children and adolescents below 20 years have type 1 diabetes. The study conducted in the different type points have shown the majority of the type 1 diabetes have the desire to fast during Ramadan. If you see the slides, the EPDED study conducted in 2001 reported 43%. The Almina type 1 diabetes study conducted in the 2016 reported 76%, and the global survey conducted in 2020 reported almost 70%. People with type 1 diabetes have the intention to fast. And the mean number of the fasting day was 26.9 and 23.7 days in EPDA, the type 1 and the global survey, respectively. That's mean the good number of the people with type 1 diabetes, they want to fast. But we should know their risk levels and the adverse events related to the fasting. If you see the slide, IDF DAR risk score categorize type 1 in the high risk, well-controlled type 1 diabetes, and categorize poor control type 1 diabetes in the very high risk group. That means indicate that they should not fast. But my last slide have already shown that the majority of the type 1 people, they want to fast. So we should know the adverse, the events related to the Ramadan fasting in type 1 diabetes. The DART Global Survey 2020 once have already reported the high rate of the hypoglycemia, which was around 60%, hyperglycemic almost 45%, and 6.8% severe events leading to hospital admission. Not only that, EPDA study conducted in 2001 also reported 5-fold increase the severe hyperglycemia and 3.2% increase of the severe hyperglycemia in type 1 diabetes during Ramadan. One of the study conducted in the Diabetic Association of Bangladesh, they mentioned that they reported that the high HbA1c is not a reason not to fast during Ramadan in children, adolescents, and the young adults with type 1 diabetes. It's because they reported that child, adolescent, and the young adults with type 1 diabetes with poor glycemic control can fast safely during Ramadan with proper education and intensive monitoring. I repeat it again, with proper education and intensive monitoring. But if you see the slide,
They also mentioned that the hypoglycemia was one of the common acute complication. However, they did not find a significant difference in the hypoglycemia between the well-controlled and the poor-controlled group. So what should be the management plan, the type 1 diabetes plan for fasting? All patients should schedule a visit with healthcare professionals 6 to 8 weeks before Ramadan, which is recommended by the IDF the guidelines, to assess, to stratify the risks and develop an individualized management plans, which includes dietary history, patient experience during previous Ramadan, and third one, the patient's ability to self-manage diabetes. The structured education for all patients, which includes risk quantifications, the role of the SMBG, going to break the fast, going to exercise, fluid and meal plannings, and finally the medication adjustment during fasting. So we already know that the type 1 belongs to the high risk and very high risk groups. Therefore, they should be advised for the 7 points of the SMBG in a day. But they should know when they have to break their fast. So blood glucose levels less than 70 milligram per DL, the blood glucose more than 300 milligram per DL, and if they have the symptom of the hypoglycemia or have acute risk occur. So I've already mentioned the 7 time points, which include pre-dawn meals, morning, midday, mid-afternoon, sunset meal, which is called the iftar, 2 hours after iftar, and any time when there are symptoms of hypoglycemia or hyperglycemia or feeling unwell. Now come to the nutrition plans. So they advise about the 3 principles of the Ramadan nutrition plans, which includes divided an adequate amount of the calories between the shahur, iftar, and if necessary, 1 or 2 snacks. Meal should be balanced with 45 to 50% carbohydrate, 20 to 30% protein, and less than 35% fat. Third one, the design meal using the Ramadan plate methods. Avoid sugar heavy as desserts. Low GI, high fiber carbohydrate are preferable. Hydration should be maintained between the meals by drinking water and non-sweetened beverages. 7 was the take sure as late as possible to minimize the rate of the hypoglycemia. 8th one is the adequate protein and the fat should be consumed at shore to induce satiety. 9th was the iftar should be begin with water to rehydrate and 1 to 2 days to raise blood sugar. And the final ones, low calorie snacks such as fruits, nuts, or vegetables may be consumed between meals. Now come to the physical activity. Research is limited on the exercise pattern of the people with type 1 diabetes during Ramadans. But similar to the meal routines, exercise pattern in Ramadan differ between the countries, culture, and the need for the school attendance and the season that the Ramadan comes in. So what should be the physical activity plans? So we should recommend the moderate level of the activity be maintained during Ramadans and average vigorous activity in the hours before the sunset meal, where hypoglycemia is most likely. Finally, the management issue related to the insulin. Studies have shown that if poor glycemic control is found, that means HbA1c more than 9, the insulin treatment regimen should be adjusted as necessary and reevaluated once again before the start of the fastings. Additionally, the rationale for the revised insulin regime should be explained and emphasized to all the patients. Insulin analogs are preferred over conventional insulin regimes. Frequently, SMBG is essential, and if possible, feasible through CGM or the flash glucose monitoring. So they have also shown that the advanced insulin technologies is very promising in allowing for safe fastings. IDF DARC guidelines also recommended some dose adjustment based on the type of the regimen. If someone on the insulin pumps, basal rate should be reduced 20 to 40% for the last 3-4 hours of the fast, and 10 to 30% increase for the first few hours after iftar. For the bolus, same principle as per to Ramadans, and they should be advised CGM method for monitoring the glucose during Ramadans. If someone of the basal bolus with analog insulins, basal insulin should be reduced 30 to 40% and to be taken an iftar. For the rapid analogs insulins, dose at the show to be reduced by the 30 to 50%, pre-lunch dose to be skipped, and the dose around iftar to be adjusted based on the 2-hour post-iftar glucose readings. They should 7-point glucose monitoring methods of the monitoring during Ramadans. If someone of the basal bolus with the conventional insulins, intermediate insulins dose should be the usual pre-Ramadan morning dose to be taken in the evening during Ramadans, and 50% of the pre-Ramadan dose to be taken at the shore. For the regular insulins, dose at the evening meal remained unchanged. Short dose to be 50% of the pre-Ramadan evening dose, and afternoon dose to be skipped. And they should advise 7-point blood glucose monitoring or 2 to 3 staggered readings throughout the day. And finally, the premix, either analog or conventional, shift the usual pre-Ramadan morning dose to iftar and the 50% of the pre-Ramadan evening dose at the shores. And advice should be given for the glucose monitoring. They should have at least 2 to 3 daily readings, and whenever any hypoglycemic symptom develop. Now come to the hyperglycemia in pregnancy. Again come to the IDEP 2000 reports. They reported the 1 in 6 live births, which is the 21 millions affected by the hyperglycemia in pregnancy, and of them 80% have mothers with gestational diabetes. So what is new regarding the hyperglycemic pregnancy and fastings? Ramadan fasting study have shown that the Ramadan fasting in healthy pregnant women is associated with some biochemical changes, which include increasing the triglyceride, free fatty acid, and ketones, and decreasing the glucose and insulins. Study also shown that the healthy pregnant woman that fast during Ramadan can safely do with no significant effect to the mother of the fetus. Pregnant women with the hyperglycemia need to achieve tight glycemic target for both fasting and postprandial blood glucose level to avoid adverse pregnancy outcomes. The fourth one, evidence from some countries indicate that 70 to 90% of the pregnant women observe the fast. All those surveys suggest that they may not manage the full month. It is important they may not manage the full month. So, what's the recommendations for the pregnant women? They have a plan for fasting. Patient education prior to Ramadan is essential to ensure mother and fetus safety regardless of their fasting decision. Regular assembly should be conducted, and at the very last one, before the sunset meal, 1 to 2 hours after meals, once while fasting, anytime feeling unwell. And the target should be fasting between 3.9 to 5.3 millimole per liter, and postprandial less than 6.7 millimole per liter. Pregnant women must break their fast if they feel unwell, blood glucose drop below 70 milligram per DL, or identify reduction in fetal movements. Patient treated with the insulin should have the doses adjusted according to their insulin regimen. Now come to the physical activity. Women should be advised to maintain normal physical activity while fasting, and the Tarawih prayer is considered as the exercise and should be taken into consideration when insulin doses adjustment are made. Now come to the nutritional care and meal planning. Pregnant with diabetes should seek dietary advice before Ramadan. The importance of the healthy eating during Ramadan is emphasized regardless of the fasting status. Abstaining from the high calorie meals is essential.
Fruit juice and the sugary drink should be avoided. Salty food should also be avoided, and caffeine intake should be limited. Pregnant women should also be encouraged to eat food rich in fiber and to drink 2 to 3 liters of water a day. And finally, pregnant women with diabetes must take sugar as late as possible. Now come the insulin-treated pregnant women. So I've already mentioned the type 1s. So we follow the same, the methods of the adjustments. If someone in the insulin pumps, basal rate should be reduced to 40% for the final 3 to 4 hours of the fast, and 10 to 30% increase for the initial few hours of iftar. For the basal bolus disease, same principle as prior to Ramadan, and reduction the dose post-shower by the 20%. And they should advise CGM. If someone with a basal bolus with the analogs, 30 to 40% reduction of the basal insulins. For the diabetic insulins, dose at the shore to be reduced 30 to 50%, cleanness to be skipped, and the dose at the iftar to be adjusted based on the 2-hour post-iftar glucose readings. They should be advised 5 to 7 point glucose monitorings. Now come to the basal bolus with the conventional insulins. Insulin, morning pre-Ramadan dose to be taken at iftar, and 50% of the pre-Ramadan dose to be taken at the shores. And for the regular insulin, dose at the iftar to be adjusted based on the 2-hour post-iftar glucose readings. Short dose 50% of the pre-Ramadan evening dose, and afternoon dose to be skipped. They should be advised 5 to 7 point blood glucose monitorings. And finally, the premix, which include both the analogs and the conventional, shift the morning pre-Ramadan dose to the iftar and inject 50% of the pre-Ramadan evening dose to the shores. They also advise 5 to 7 point blood glucose monitoring. Now come to the elderly with Ramadan fasting. What we know, age alone is often used as the risk factor for fasting during Ramadan. Many elderly individuals still fast during Ramadan, and guidance is needed to help these individuals fast safely. The most important things, elderly people with diabetes, particularly consideration needs to be given to any accompanying comorbidities. So what is the comorbidities? The study have shown that elderly people in the age 65 or over had more hypertension, hyperlipidemia, retinopathy, neuropathy, nephropathy, coronary and the cardiovascular disease, and diabetic food compression compared to the age less than 65 years. Not only that, global survey also indicated that people aged 65 years and above had more hypoglycemia, hyperglycemia, and hospital admission compared to the individual less than 65 years of old. So another study also shown that they have not found any significant difference in the same frequency of the SNBG before Ramadan. Only 11% people aged more than 65 years perform 3 to 4 times SNBG during Ramadan, and almost 25% reported they do not perform any SNBG during Ramadan. So all these things should be considered when you are planning for the management. So what is the recommendations? Recommendation related to the medication and the regimens. We have an assessment and discussion with the people with diabetes, with their consultant prior to the Ramadan, to choose the medication that have a lower risk towards hypoglycemia, make dose adjustment to lower the risk of hypoglycemia. Come to the SNBG, increase the frequency of the SNBG, consider the using of the continuous means of monitoring blood glucose level if available. Regarding the diet, there needs to be an emphasis on staying properly hydrated, particularly in individuals prone to diabetes-related comorbidities. It is important to have an adequate intake of nutrient when breaking the fast. And third one, an individualized nutrition plan should be made prior to Ramadan and adhered to during the Ramadan fast. Now come to the physical activity. Physical activity level should be curtailed but not halted during fasting hours. Second one, activity should be planned ahead of the time and through thought of the
holistically. And finally, which is most important, adequate support mechanism should be in place to ensure the elderly individual with diabetes wishing to fast receive adequate support from family members, friends, carers, and community members. And this should provide greater level of safety and confidence. In general, elderly individuals are at higher risk of hypoglycemia, we know, and any medication treatment agent that increases the risk should be adjusted. And individuals that are being treated with oral antibiotic medications, the guidance for sulfonylurea use, glyclazide should be used instead of glibenclamide. And SGLT2 inhibitor dose should be reviewed in accordance with the advice from a specialist, and consideration must be given to benefit versus risk of adverse events, especially in elderly people with impaired renal function, or those are treated with diuretics. Finally, among individuals using insulin therapy, it is recommended that the analog insulin are considered over insulins. Now come to the finally cardiovascular, cerebrovascular, renal complications. So all of the diabetes is a risk factor for cardiovascular disease and stroke. Individuals with the pre-existing cardiovascular or stroke and diabetes are greater risk of complication when fasting and should be cautious. Individuals with chronic kidney disease, stage 3, and diabetes are high risk for fasting during Ramadan. Fourth one, individuals with chronic kidney disease, stage 4 and 5, and diabetes are very high risk for fasting during Ramadan. Therefore, fasting in these individuals should generally be discouraged. But some of the studies have shown that the fasting during Ramadan with stable cardiovascular disease does not increase hospitalization or worsening of the underlying heart condition. However, further research is needed into individuals with diabetes and pre-existing cardiovascular disease to carry any specific recommendation to individuals with diabetes and cardiovascular disease. Studies investigating the risk of fasting on a stroke are conflicting, and greater research is needed in individuals with diabetes with pre-existing strokes. The third one, fasting during Ramadan with stable CKD or having undergone kidney transplant does not increase eGFR, and any biochemical changes are transient. These may also apply to the individual with diabetes, but further research is needed into individuals with pre-existing diabetes and CKD. The last one, individuals that have undergone kidney transplant or have stage 3 to 5 CKD are at very high risk of fasting during Ramadan. This will require careful monitoring and a specialist to advise before fasting during Ramadan. Finally, large prospective studies are needed. These include randomized trial and a study assessing the effect of fasting in individuals with diabetes and its complications on microvascular and macrovascular complications. Thank you for the patient hearings.
Thank you, Dr. Bajbir. If there is any questions? Yeah, there is. I think I have seen some. No. Any questions to our 4 speakers? Okay, you can, you can conclude our session, please.
Okay, thank you, all the speakers. It's a wonderful session, learning about the practical tips in fasting. So to move forward, now we'll be going into the next session of about new advances in fasting. So we have a chairpersons on the board, Dr. F.S. Parikh, who is a fellow of American College of Endocrinology, Royal College of Physicians, and is also of an RSSDI. Along with that, may I also welcome Dr. Atul Goklani, who is the Managing Director of AHC Diabetes Care, Consultant Physician at JDPF. So I welcome both the chairpersons and to take over the next session. Thank you.
Thank you very much, Dr. Subhajyoti, for a wonderful session and having
introducing me. And now we'll move forward to the next session. And I don't have the chairperson today with me. Dr. Rakesh Parekh is busy somewhere and he can't join today. So our first speaker for today's session of newer advances in diabetes and fasting is Dr. Asma Deeb, is a clinical professor at Gulf University and the chief of pediatric endocrinology at Sheikh Shakbot Medical City. She is the president for the Arab Society of Pediatric Endocrinology and Diabetes. She is previous chair of communication of European Society of Pediatric Endocrinology and an advisory board member of International Society of Adolescent and Pediatric Diabetes. She organized a yearly postgraduate diabetes course with SPED since 2015, and she was appointed as a clinical lecturer in pediatric endocrinology at the University of Cambridge between 2001 to 2006 and obtained a CCST in pediatric endocrinology. Her special interest in disorders of sexual differentiation, use of technology in management of children with diabetes, and genetic of diabetes mellitus. It's aimed to ensure a high standard of care and development in the field of pediatric endocrinology and diabetes in the Arab region, extending from Gulf through the northern African countries. And I'm really happy and privileged to visit the center during last SPED meeting in Abu Dhabi. Over to you, Dr. Asma Deeb.
Thank you very much indeed. Firstly, can you kindly confirm that you can see my slide?
Yes. Your slides are visible, and you can put it on slideshow mode.
It is now in slide show.
No, we can't see it in. No. It is not on slideshow.
Okay.
Now
well,
in that case,
in that case, I will stop sharing, and if you kindly, I've already. Let me try once more. Otherwise, I've sent it to your administrator. And if you cannot see it in slideshow, it means that my computer is not projecting it properly. What about now? Is it in slideshow now?
No, it is not on slideshow mode.
Okay, well, I'll stop sharing in that case. And if you kindly get your...
So our technical team can help you to put it on slideshow mode if you are okay.
Yeah, my computer is slightly different. It has multiple screens. So okay. I've already sent it to Dr. Banshi, and he...
So, Rutul, I sent you the slide. Yes,
hi, Banshi.
I can see you. Hello, Rashma. So I just sent you, Rutul, on your WhatsApp, and you can send it to Mira or anyone. They can share the slides.
Ma'am, I share. I will share your slide.
Priya, also you have the slides.
Yes.
Slides. So you please share them.
Share them. Thank you.
How are you, Asma?
I do apologize. I'm good, Banshi. I do apologize. This is a new computer and it's very complex. Okay, that's brilliant. I can see them now.
No issue. Don't worry.
Yes.
All right. I'll stick to time. And if you kindly help me advancing the slides. So I'd like to start thanking very much indeed yourself, our chairman, for the introduction. And as always, I thank my friend Banshi, who asked me to contribute to this very important session, which is very well timed. We're all waiting eagerly for Ramadan, and we pray that it will give us peace and health and help our patient to fast safely. So this is an impressive slide. If you could click, please, on the next one. If you could click, please. Yes. So if we look at the previous 3 or 4 decades, there was not much of literature talking about Ramadan and fasting. And then from 2000 onwards, there has been a very interest. People had large appetite to look at what happens in Ramadan, and people felt that the human body is a very good model to test physiology, particularly when we are fasting. So there is an abrupt surge of the literature in Ramadan fasting. And if you could click, please. Now, the previous slide shows the literature in all the population, adults and pediatrics. But if we look particularly about what has been studied in adolescent, there has been lots. So things to do with, are adolescents really willing to fast, or will they take it an excuse for not fasting? Those ones. Perception, attitude, lots of psychology, lots of studies about Ramadan safety. What are the complications? The acute one, hyper, dehydration in particular. And people also study the metabolic effect of fasting, particularly on metabolic control as well as on lipids. And if you could click 3 times for me, then we can see that there are lots of studies on technology of Ramadan. Please click enter. And once more, and last one. Okay, so technology in Ramadan. Now go back, please. So technology in Ramadan, if you go back once. Okay, never mind. So what I highlighted in red in the previous slide, no, the previous one, please. Go back, please. One more. Okay, please stop there. Thank you very much for your help. So you can see there are lots of studies that have been done looking at the regime, which is the best regimes in Ramadan fasting. Is it twice daily? Is it MDI? Or is it insulin pump? And then again, many studies have been done about how to utilize technology for safe fasting. And what Banshi asked me to talk about specifically today is to how to adjust insulin pump therapy for those users who wish to fast Ramadan. And if you click once, please, I'm very proud to show you the latest publications that we have in the guidelines of Ramadan. If you click once for me, please. Can you proceed to the next slide, please? Okay, thank you. Please stay there. Thanks. So these are the ISPAD guidelines, which was in the previous slide. So we have put together a team of people from different countries, not only the Arab countries, but different Muslim countries. And we put together the guidelines for adolescents and young people, young adults as well, who are wishing to fast Ramadan. And for the sake of today's talk, I have a couple of studies that are published in highly reputable journals, and they are specifically answering the question that Banshi asked me to talk about. The first study is one of ours, few years ago now, I have to admit, in diabetes technology and therapeutic. This is the one that you can see flagged up or projected in the screen. So the question that people have always doubted, and we have seen previous speakers touching on it. If a person is using insulin pump and that person is wishing to fast, is it better to reduce the basal insulin, or shall we rely on the appropriate insulin pump setting if the patient is doing well before Ramadan and leave the settings as they are? And for that, we have studied this particular point, looking at how evidence-based it is to reduce the basal rate in Ramadan. And if you could click once for me, please, for the next slide. So our aim was to study if reducing basal insulin during Ramadan reduces the frequency of symptomatic hypoglycemia. So one aim, quite a precise point, because as I said, we hear many people advocating reducing the basal rate in pump users in Ramadan. So what we did here, we looked at those children and adolescents with type 1 diabetes who fasted Ramadan. If you go forward, please, you went back to the previous slide. That's it. Please stay there. Thank you very much. Okay. And then we asked those people to tick which days were fasted, obviously, because there are some females who will not be fasting during the menstrual cycle, as well as many people will break their fast. So we asked people to mark in a logbook the days they have fasted. We also asked them to mark any symptomatic hypoglycemia that they had and the dose of basal insulin. And then we have downloaded all the glucometers and insulin pump when patients came back after Ramadan. Next slide, please. And in this slide, I would like to summarize for you what we have seen in that study. So these are 75 patients, adolescents, older children and adolescents. Some of them are on insulin pump, 41, and 27 were on multiple daily injection. Their range of age varied between 10.2 to 18.9 with an average with a mean of 14.5. Now, 39 people had hypoglycemia during Ramadan, at least one episode of symptomatic hypoglycemia. 15 were users of multiple daily injection. 24 has been on insulin pump therapy. Then we looked at those who reduced their basal insulin versus those who did not reduce their basal insulin. And we counted how many of those who reduced basal insulin yet still had hypoglycemia. And what we found is 6 out of 15 of MDI users did have hypoglycemia and they did reduce their insulin, and 18 of those insulin pump users, they reduced their insulin and yet they still had hypoglycemia. And when we looked at the statistical significance between these two groups, there was no difference. And then when we looked at the hypoglycemia that happens in people regardless of MDI or pump, hypoglycemia happening in people who did not reduce their insulin compared to those who reduced insulin, again, we didn't see much of difference. If you go to the next slide, we have concluded from this study that reducing basal insulin in Ramadan doesn't really reduce the risk of symptomatic hypoglycemia. And maybe a side issue is that insulin pump does not appear to be different from MDI in the frequency of occurrence of hypoglycemia. And specific conclusion from this, if we as healthcare professionals have adjusted the insulin rate, the basal rate for the patients appropriately, then if the patient is fasting, he or she should not go into hypoglycemia because the basal rate is intended to cover the position of the glycogen release from the liver. And if I move to the next and the last study that I would like also to present on behalf of my colleague Nancy Berberi from Egypt. Now, we worked on 640G pump, the one I showed you, but Nancy worked on the more advanced hybrid closed loop 780G. And what Nancy did is she wanted to look at the same issue. To what extent changing the setting for Ramadan is useful for safe fasting? Do we really need to do much for these youngsters who are pump users before Ramadan? Or are we actually just confusing them and doing more harm? That was her question. If you could move to the next slide for me, please. So her aim was, she did it prospectively, far better than our study. And it's randomized controlled, was
ours was not. And Nancy wanted to look at the safety and the effectiveness of optimizing the advanced hybrid closed loop for those who wanted to advance to fast Ramadan. And let's move to the next slide in the method so that we can understand her methodology. So what she did is, as you all know, or particularly those of you who used advanced loop, it's quite an intensive way to use insulin pump therapy, and it relies on an algorithm that is quite strict and intensive, yet being safe. So what she did is she took two groups of those who are using advanced closed loop system. One group, the control group, she left them as they are. She didn't touch the setting. So everything there was quite intensive. The target is 100. The active duration of insulin is very short, only 2 hours, and left it as that. This is quite intensive. And some people might be scared about hypoglycemia with these settings. And then she randomized another group, and what she did with the other group, she made it a little bit less intensive. So she put the target from 100 to 120, and she relaxed the insulin time, the active insulin time, from 2 hours to 3 hours, with the theoretical aim of reducing the risk of hypoglycemia. And then she looked at these two groups. So if we move to the next slide. If you go to the next, yeah, that's the one. So it was very interesting, her studies, because what she found that the time in range in both groups was about 82%, very good control. Time above range is what you see in the screen. But the interesting part is that she couldn't see any increase in hypoglycemia, even in the intensive group, where their target is set very strictly at 100. So this is the key result from her study. Other things that are not exactly related to what we are discussing now, but she found that people are doing very well during Ramadan using the advanced hybrid closed loop, because most of the people remained in the smart guard mode. For those of you who did not use the advanced hybrid closed loop, you have two modes in this type of insulin pump. One is manual, where the patient has to be in control, and the other mode is the smart guard or the automatic. And if the patient doesn't follow all the instructions, then he or she will come out of the automatic mode into the manual mode. What she found here in this study is that the overall time spent in the closed loop, in the smart guard, in the automatic was incredibly high, very encouraging. And she didn't find many people exiting from the automatic mode. But again, I repeat, the most important findings in her study, which is relevant to what Banshee asked me to talk about, is there was no increase in hypoglycemia for that group whom she left with very intensive glucose control. So there was, when she looked at the statistics, there was no significant difference when she compared the relaxed group with low insulin, which was done to reduce the hypoglycemia risk, and with those who remained on the same intensive settings. If you go to the next slide, please, for me. So what she concluded, and her study was published recently, a few months ago, in Journal of Diabetes and Clinical Practice. So she concluded, if you have the ability to give patients advanced hybrid closed loop pump, do it, because it's safe and it's very helpful. And what she also said is, if you have that facility to use, leave them on their smart guard. Don't fiddle with their settings. Don't complicate matters for them, because the pump, according to her study, is really safe and the results are very comparable for both not only glucose control and the time within range, but also in the risk of hypoglycemia. So let me finish with one last slide. If you could click it for me, please. Now, my humble overall conclusion from these two studies, and I know two studies are not sufficient maybe to apply all the results on millions of Muslims, but these are the recent studies, the scientific ones that are included in guidelines for ISPAT, and use of insulin pump in Ramadan can facilitate safe fasting. But it's very important that when we use insulin pump therapy, we use it properly. We need to make 100% sure that patients as well as healthcare professionals are well trained on the proper use of pump. So it doesn't matter if you don't have thousands of dollars to give insulin pumps to patients, because we have many patients who uses top-notch pumps and they are not well controlled. The key is in the education and the proper use. And then my conclusion, the middle one, or the recommendation, if the patient is properly set prior to Ramadan and there was no excessive hypoglycemia and the time in range is acceptable, the conclusion is leave the patient on the same setting. But the last slide, which is the next slide, I don't think any of us will disagree that pre-Ramadan consolidation of education is the key, whether the patient is on pump or on any type of insulin. This is incredibly important. Training people on proper use of pump is important. If the patient is using technology, then carbohydrate counting revision is very important. And it's not only that. Some people have pumps and they are well educated on carbohydrate counting, but they are not entering data. This is common in adolescents. Compliance is very important. And my final conclusion for today's talk in relation to insulin pump adjustment, which is the title of my talk, is there's no solid data showing the importance or the recommendation of both. Reducing basal, I haven't yet seen a very conclusive study recommending reducing basal rate, leading to better control and avoiding of hypoglycemia. I personally do not reduce basal if it was properly done before Ramadan. Reducing insulin carbohydrate ratio, some people do it thinking that after Maghrib, people will eat more sweets. Again, you can try, but there's no strong evidence suggesting that you need to do that. And the last thing, prolonging the active insulin, doing it 3 hours, 4 hours, perhaps that will prevent the pump of giving more boluses and prevent stacking, might be theoretically an idea, but yet to see solid evidence-based studies about that. And with that, I think my next slide is just to thank you all for your attention. And I do apologize about the glitch in projecting my slides. Thank you very much.
Dr. Asma, that was really a wonderful talk. As in India, we don't use pumps that frequently in Ramadan patients, especially. But your first study that has been done by yourself, right, in your center.
Yes, that's correct. Yes.
Yeah. So that study, in this study, which kind of pump was used? Was it that advanced hybrid closed loop system pump, that 780G, or the previous generation pumps?
The study was published in 2016-17. We didn't have the advanced
that time we did not have 780G, right? Yeah.
Yeah, right. So it was the 640. Right, great. So that pump showed clearly that between a pump and MDI, multiple daily injection, there is no evidence that whatever is superior or inferior. So it's all about patient education consolidation, and this makes the difference only. And from your talk, we understood that advanced hybrid closed loop system pumps are way better than all other pumps, and they can be safely used and can be promoted if patient can afford or we can spend on a patient, then we should advise patient 780G, right?
If we can, but the main conclusion is education is the most important rather than the what technology you have. And the main conclusion is that reducing basal
insulin does not help. Yes.
Doesn't appear to reduce hypoglycemia, but of course, it's a debatable issue.
Great. But prolonging the active insulin time can help. Yes.
Three things that can theoretically help. Number one, reducing basal insulin. Number two, increasing active insulin. Number three, reducing insulin carb ratio. Theoretically. However, there are no studies to confirm the superiority of these three approaches. Definitely reducing basal, according to the studies I presented, does not prevent hypoglycemia.
Great. Okay. So that was really wonderful talk. If we have any question in the chat box, let me see.
Asma, just one question. How many of your type 1 who are on insulin pump and maybe pediatric or adolescents who are doing regular Ramadan or fasting? Your personal experience.
Banshee, I don't know about your clinic, but in my clinic, I would say 95 to 97% of people in general, the adolescent with type 1 diabetes, they fast. They feel very frustrated if they were told not to fast, and they have issues with psychology because they feel they are not up to it compared to their peers. Specifically about insulin pump patients, definitely I'm not going to deny that insulin pump provide extra safety. But again, Banshee, I wouldn't really feel disheartened if in a clinic you don't have many pumps. Education is far more important than money and technology.
Very true. But we don't have the similar experience in India. Because many of our type 1, either they are uncontrolled and they are not on, even they are on MDI, and most of the doctors, pediatricians, and even the endocrinologists,
they don't advise.
Yes, they deny them to not to fast. This is the, even not for the Ramadan, for any fast, they get the denial for that. So but I agree with you that, it will create a more psychological problem to them because they feel they are not up to the mark and they can't fast. I fully agree with that.
But for
my patients are not all well controlled. In fact, majority of the children that we have high HbA1c. But those people are the ones, it doesn't mean that they shouldn't fast. In fact, they do better. So what I'm trying to say, if the patient has high HbA1c, this is not the reason to advise them not to fast. In the contrary, we find children who have high A1C, when they fast, they get better.
Good, right, very true.
But in India, it is completely an opposite situation. Like our 95% of patients, they do not fast. With this, we'll conclude the session and we can move forward.
Thank you, Asma. Once again, thank you very much.
Thank you very much.
I asked already your travel plan for our diabetes technology meeting, and I am waiting for your itinerary for the same. You will have to come to India in month of May and apply for your visa. Thank you. Okay.
Thank you very much for that. Bye. Look forward to. Thank you very much. Bye-bye now.
Bye.
Goodbye. Yes. So Our next topic is newer studies which are done in Ramadan. And for that, we have Dr. Sheila Sheikh. She is consultant endocrinologist at Prince Michael Hospital, Safi Hospital, and Wockhardt Hospital, Mumbai. She's PI in international clinical trials, around 34, member of executive committee of ESI and treasurer of ESI Maharashtra, member of scientific committee CAD, and awarded top does Mumbai by T01 group from 2017 to 2020, and author of International and Diabetes Guidance and IDF DAR Guidelines 2021, published many papers, review articles, and speaker at national and international forum. Over to you, Dr. Shaila.
Shall I have the recorded talk, I think?
Yes,
so
yes,
you can
yes,
have the
yes,
talk.
yes, yes.
Good afternoon, everybody. At the onset, I would like to thank Dr. Bansi Sabu and the entire organizing committee for conceptualizing this lovely web meeting, because I think it is very, very important that we actually talk about the work that we are doing in Ramadan. And also it is very important that we understand that we have really moved a long way forward from the thought process where we always thought that it was very dangerous for our patients to fast in Ramadan. And it was also absolutely not allowed that our patients fast during Ramadan. Our conversations have changed. Our risk stratification has changed. We have newer molecules which cause less hypoglycemia, better monitoring facilities. So things have really changed as far as a patient who wants to fast during Ramadan is concerned. I think also Ramadan being a prototype of intermittent fasting has actually garnered a lot of attention since we have begun to realize that intermittent fasting could actually potentially help our patients reach goal. When we're talking about intermittent fasting, I understand that when you're talking about Ramadan fasting, it is more a religious fasting and it is associated also with feasting. But when you look at the entire concept of intermittent fasting, and though there is data which shows that it is not per se the intermittent fasting, but it is the calorie restriction which translates into benefit, it does remain a very, very fascinating area of research to understand what exactly are the changes that the human body, the human psychology, and of course the human spirit undergoes during this entire month of fasting. Today, when I'm talking about some of the newer studies being done in Ramadan, I would just like to start from a very, very simple slide, because unless we understand that Ramadan involves a period of fasting for a month, in our country this year, Ramadan is going to last for a period of around 14.5 hours. And during this period, fasting patients do not consume any food, any water, or any nutrition from the mouth, and they do not consume any tablets as well orally. What is very, very important for us to understand that the fasting in Ramadan is also a very, very spiritual need of the patient. And the reason I'm saying a spiritual need of the patient is because if you understand that it is very important for the patient to fast, you would also understand that why the patient sometimes, in spite of being in the moderate or high risk category, insists on fasting, insists on saying that, no, I want to fast. And that's the reason why we are at all points of time attuned to the fact that some of the risks our patients could potentially undergo when they decide to fast during Ramadan is hypoglycemia, hyperglycemia, diabetic ketoacidosis, and of course, associated dehydration and thrombosis. Now, with this background in mind, we would like to talk about two studies that we did last year. I think these are very, very relevant studies, and that's the reason I'm presenting it to this August audience. One of the studies that we did was the knowledge, attitude, and practices among 1,099 patients with diabetes across Southeast Asia who intended to fast during Ramadan. What is interesting about this study is it is a multinational study done not only across the four corners of India, but also done in Bangladesh and Pakistan. So Southeast Asia can actually make a very, very big difference when we decide to collaborate and actually contribute in a very, very big way to research. Although
authors who are listed over here contributed fantastically to this study. And I'm not going to get into the absolute details of the study in the interest of time. But what I would like to tell you, friends, about our patients, and when I'm saying our patients, it is both your and mine patients, is that almost 10.9% patients do not have suhoor. Now, what implication does that have for you and me? The implication it has for you and me is that if a patient does not consume suhoor, that means there's a higher risk of this patient going into hypoglycemia, which was talked about in the Ramadan study. 61.7% of patients have their suhoor as late as 30 minutes before the beginning of the fast, which is what we'd want it to be. 51% of patients do say we want to take medicine after suhoor. It is difficult, or we forget when we get up to take medicines before suhoor. So that is something which we need to keep in mind when we are readjusting our medications, and try to understand from our patients as to when they want to take medication. What was very, very alarming was that 33.8% of patients did not have a glucometer. That is something which is alarming, because we believe that you should not allow your patients to fast if the patients are not willing to monitor themselves, if there is any kind of risk as far as dysglycemia goes. What was also more interesting is that if patients did have a glucometer also, 58.4% did not regularly check their blood glucose levels. So that is an area of concern. That is an area which we do need to understand, that 38.4% patients had a glucometer and regularly check, but 27.7% patients do not check the blood glucose despite having a glucometer. Still, and you would be surprised, 21% of our patients believe that finger prick would break the fast. I thought the amount of information, the amount of education we've been doing from the last 5 years, it's been very intense, but we've actually been doing it almost from a decade, would have allayed this myth that finger pricking breaks the fast. But actually still 21% of patients in our countries believe that finger pricking breaks their fast. 38% would break the fast when the sugars are low. Now, that's again another worrying factor. That means approximately almost 62% would not break their fast. As far as sleep is concerned, daytime sleepiness was reported during Ramadan by almost 58.5% patients, and this was despite patients getting adequate sleep. The total sleep was supposedly adequate at 6 hours. And we concluded that yes, we need to improve the quality of care in our patients who choose to fast. We need to specifically emphasize on the importance of monitoring, of having a glucometer, the importance of breaking the fast if the patient is hypoglycemic, even if it happens just maybe half an hour before the actual time of ending the fast comes. And last but not the least, eating suhoor close to starting the fast. A lot more work needs to be done in this area, and I'm sure we're going to continue doing that. The second study which we did this year, friends, was the Prep Up study. This was preparing patients with type 2 diabetes using the IDF-DAR risk calculator pre-Ramadan for risk assessment. We all know in 2021, the IDF-DAR came up with a new risk calculator where specific points were given to different risk factors, and this is now available on an app. The patients were categorized according to the individual score system into mild, moderate, or high risk category. And the patients who were in the high risk category were advised not to fast. Why is this so important to you and me? This is important to you and me because when you say that a patient is in the high risk category and cannot fast or is allowed not to fast, even the religious authorities are saying the same thing. Even the religious authorities are actually at this point of time telling our patients that yes, if you are in the high risk and you've been advised not to fast, please do not fast. At the other end of the spectrum, if the patient is a low risk category and you can allow the patient to fast, then of course it's a patient's individual decision about whether the patient wants to fast or not. But the moral and the spiritual obligation on you as a clinician is in being to categorize your patient well. So we wanted to understand whether practically we can apply it in clinical practice, how easy it is, and how we can actually use it. 509 patients who were going to fast were subjected to risk assessment as per the idea of DAR 2021 guidelines. These patients did undergo pre-Ramadan evaluation and they were categorized into low, moderate or high risk. You would be surprised. Our site, and this study was done only in our site in Mumbai, it more or less reflected what was seen in this, transnational data. It was similar to what was seen in this multicentric study, which I just spoke to about, that SMBG is a major limitation. When we are stratifying our patients, even patients who are on insulin are not willing to monitor themselves as much as required. Again, I was actually pretty surprised when I looked at the data that it was such a similar reflection of what we were seeing. 25% of our patients did not have a glucometer, and it actually was embarrassing when we sat down and analyzed the data to realize that, we still haven't been able to reach out to 25% of our patients, and that is something that is simply just not done. What was interesting is that pre-Ramadan education is something that we are doing from the last 5 years very, very religiously in our clinic. And in spite of that, patients were still reluctant to monitor when we actually, ask them questions and try to understand where they stand. What was very, very heartening was that because now we have newer medication with lesser risk of hypoglycemia, and our patients are on this newer medication, some of our patients which were in the moderate risk category could be re-stratified to lower risk and could be told that they can fast absolutely safely this Ramadan. And that was really, very, very rewarding to be able to recategorize your patient and say, okay, you are monitoring yourself with the CGMS, you are on this medication, you are at very, very low risk of any kind of complication during this Ramadan and you can fast. This stratification also helped us understand better what was exactly the area of concern. For example, if the patient's SMBG was the area of concern, we knew that we had to concentrate on that. And we made it a point as a team to concentrate on concentrating on the importance of that particular parameter. Again, we concluded monitoring remains an area of concern, but the risk calculator, simple to use, easy to use, helps us individualize therapy and make very, very informed decisions regarding the risk of fasting. This is what we did. And now I'm going to go to another trial, which we were also a part of, optimizing Ramadan fasting. This was a randomized controlled trial in patients with type 2 diabetes during Ramadan. And over here, the principles of the ADA-ESD consensus were applied. This was a multinational study. This was the principal investigator was Dr. Mahmood, and our site was one of the sites who was part of this study. The total number of patients evaluated were 506. And the main reason why it was only 506 patients, because in this study, we had to actually request our patients to monitor themselves, to prick themselves 7 times a day for 30 days of the month. And that was not something which all our patients were willing to do. And that's the reason why you have these numbers. We had 2 groups. One was the conventional group and one was the intervention group. And at the end of the study, it was seen that the number of hypoglycemic episodes in the intervention group was definitely less than the participants who received usual care. Not only that, severe hypoglycemia was also lower. What is interesting is that these patients did have a significant reduction in glycosylated hemoglobin in both the groups. But yes, the improvement was significantly greater in the intervention group. Body weight reduced and HDL increased, but these changes were not significant, not different from usual care. So again, pre-Ramadan assessment mandatory, education mandatory, adjustment of glucose lowering treatment very, very important as per the updated 2020 recommendations. And this, mind you friends, can prevent acute complications and actually allow a safer fasting period for our patients. This approach not only reduces the risk of developing severe hypoglycemia, but mind you, it also improves metabolic outcomes in patients with type 2 diabetes. Going a little further ahead, a number of our patients now are on the insulin pump. And what happens to these patients who are on the insulin pump? The control group received basal insulin adjustments only,
or there was an intervention group which used temporary basal rates and extended bolus features in addition to basal insulin modifications. Very, very interesting. Is pump going to make fasting much easier for our patients, especially for those type 1 patients who really want to fast and we've not allowed them to fast? You would be surprised that with these kind of alternate insulin pump settings in patients with diabetes during Ramadan, the percentage of time patients spent within target did increase. Not only that, the percentage of time spent in hyperglycemia level 1 and level 2 met the criteria of significance. That means the intervention group did spend less time in hyperglycemia. What was reassuring is that there is no significant difference in the percentage of time spent in hypoglycemia. So yes, technology does make a difference. We need to apply it in the right patient. We are this year more confident about allowing our type 1 patients to fast, of course, under strict supervision, that goes without saying. After a complete evaluation, that also goes without saying. And of course, with a lot of family and parental or spousal support, whichever way it may be. But yes, we are definitely in a better zone. The reason I put this study up was because I found it very interesting. And the reason I said I found it very interesting is because one of the issues that we've always had is the risk of dehydration and whether that risk of dehydration does influence the renal parameters in any way. So these were 58 healthy subjects. They were divided into groups of 29. The hydrated group drank 2 to 3 liters of fluid from sunset to dawn of the next day. And renal parameters were measured before, during, and 1 month after Ramadan. And what was seen? Very, very interesting results. And the reason I'm saying very, very interesting results is because I really never thought when I actually picked up this paper or started reading it that it would actually make a difference as far as Ramadan fasting goes. But though is not associated with a permanent increase in serum creatinine or BUN, if patients increase their fluid intake, what was definitely seen that yes, serum creatinine and urea were lower than the controls. That means hydration does have a favorable effect. Very important that we emphasize on hydration. Very, very important, because this does compensate for the dehydration. The dehydration is responsible for the increased concentrations of urea and creatinine. And that means though Ramadan does not affect the renal system per se, fluid should be increased at night during the non-fasting hours. And this year, as a result of this study, we have told our patients that you need to keep your water bottle separately, keep your bottle of water separately, and consume water from that bottle. It is very, very important that you actually document, you actually monitor the amount of fluid that you consume during Ramadan. EMPA. SGLT2 inhibitors, we all know that we do use them during Ramadan. We tell our patients to increase their water intake and we tell our patients to shift the timing to iftar. But what happens to patients who are using EMPA on volume status, on ketonemia, and especially now with the increased emphasis on high protein in the diets and reduced carbs, and of course hypoglycemia? EMPA, patients who were on EMPA were on the molecule for at least 3 months. Control group, subjects not receiving SGLT2 inhibitors were recruited, and the baseline parameters were your anthropometry, blood pressure, and renal parameters. No difference was seen in the blood ketone group or hypoglycemia indices in these patients. But what was concluded is that yes, fasting does result in weight loss and reduction in eGFR. EMPA can be used very, very safely with no increased risk of dehydration, ketosis, or hypoglycemia. And yes, it can be continued to be used during Ramadan. When you look at some of the other SGLT2 inhibitors, what do you see? What you see in this study, which is again a very, very interesting study, was this is an observational, non-interventional study, 245 patients with type 2 diabetes, well matched. 3 groups, EMPA 87 patients, DAPA 85 patients, and a control group of 73 patients. Well settled on this medication for 3 months before the onset of Ramadan, and clinical and biochemical parameters of hydration were evaluated during the last week of Ramadan. What was interesting is that there was a higher prevalence of orthostatic dizziness and postural hypotension seen in SGLT2 inhibitor users. Mean arterial blood pressure was lower among users of EMPA and DAPA than non-SGLT2 inhibitors. And more importantly, they did show higher values of urine-specific gravity and BUN creat ratio. So though no dose adjustment is required, definitely stabilize the dose of SGLT2 inhibitors. And as I said, it should be administered in the evening meal. The reason I again put up this work over here is, again, I found it very fascinating. And the reason I found it very fascinating, to be honest, friends, is because, increasingly we tell our patients that you do not increase your activity during Ramadan. We tell our patients, of course, and I continue to tell my patients, no increase in activity during the fasting hours. But what about the non-fasting hours? When we are looking at patients with concurrent activity and Ramadan diurnal intermittent fasting, what did we see? Very, very interestingly, what was seen is that both groups showed a significant decrease in weight, fat mass, and fat percentage with waist circumference, and improvement in blood glucose, lipid profile, and inflammation. Fat-free mass also decreased significantly in the RDIF NCT, but remained unchanged in the RDIF CT. What was very, very interesting was greater improvements in body composition, greater decrease in lipid parameters, inflammation, and liver damage. So maybe we could use this window period of 1 month that we have to really cause better changes in body composition, in lipid profiles, inflammation, and liver biomarkers in these patients when you do concurrent training with intermittent fasting of Ramadan. A very, very interesting thought process. And the reason I said a very, very interesting thought process is because it is a change from what we conventionally have always thought about. And considering the fact that we are now increasingly accepting Ramadan as a period of intermittent fasting, the entire thought process about, you fasted all day, so you really need to rest after you open your fast, is now decreasing in intensity. That entire thought process is undergoing a paradigm shift. And we are increasingly telling our patients, yes, you are fasting, but your body is coping up fantastically with the newer medications. You are doing well with new monitoring, and definitely you can continue to fast and continue to stick to your old treatment, to your old exercise regimen, which we were doing prior to Ramadan, but of course do it in the non-fasting hours. 2 advantages, friends. 1, my patients continue doing it. So the benefit that they've accrued from the exercise stays on, of course. And most importantly, if patients do not drop it during Ramadan, what I have seen, most of my patients, when they stop exercising during Ramadan, it takes them at least 2 to 3 months to get back to their old exercise regimens. That means that these patients lose almost 3 months in a year if you tell them not to exercise during Ramadan. A very, very interesting thought process. And as I said, new data makes you really rethink about the advice you give, makes you understand better the advice you give, and makes you realize that maybe you need to re-talk the talk. So if I come to the last slide, I think Ramadan has become a fascinating area of research. It's an absolutely 1 month period where you can actually see what kind of benefit fasting has. You can also understand what kind of risk your patient potentially could have as a result of fasting. It helps you understand which patients should be allowed to fast and which patients should not be allowed to fast. And of course, we are now documenting it better. Before, we used to work more with personal experience, more with trying to understand on our own how, where, what. But now we have good data to back it all up. We are having fascinating researchers in this area who are looking at the minute details so very closely to understand what exactly is happening. Treatment has become very, very interesting, I would say, because we have newer molecules, we have better technology, we are being able to apply it, we are able to actually see the difference it makes. But of course, we need better research, we need more research, we need more multicentric trials to understand better how we could really make a difference to our patients in the clinical world. It's a pleasure talking to all of you all. I hope that you have had some benefit from the entire conversation that we've just had. And it would be absolutely wonderful to hear from each and every one of you. And maybe we could all collaborate on this and create better data, more data, so that we can make Ramadan an absolutely safe fasting experience for our patients. Thank you very, very much, friends.
So that was really enlightening talk about newer updates or newer data on Ramadan, where many of the studies she included, where the first thing that surprising was that more than 30% of our patients, they do not have glucometers. This is quite an eye-opening thing, and everyone should keep it in consideration. The second thing is about SGLT2 inhibitors that can be safely used, and data also suggests the same thing. Another thing is suhoor is very important to reduce hypoglycemia. This is very important. Suhoor food or suhoor meal should not be skipped. The third thing is dehydration she talked about, and dehydration is it is very common. So hydration should be proper. More than 2 or 3 liters should be taken in non-fasting hours. And diabetes education before Ramadan is very important, that Dr. Shaila has beautifully explained. And if we have any question or any comment, then if we don't have any question or comment, I would like to hand over the session to Dr. Bansi Sabu sir to conclude the meeting. You are there, sir? I guess Dr. Bansi Sabu is not here, and we may.
No, I am very much here.
Okay,
here.
Sir, I called you, but yeah.
I'm sorry. I'm sorry for that.
No problem, sir. No.
So I am at airport, and so any question related to this? Have you asked, or now we are closing the ceremony?
No, sir. We are closing the ceremony as I have concluded Dr. Shaila's talk as well.
Great.
Yeah.
So first of all, I would like to thank everyone, all the delegates, all the faculty from India, faculty from Bangladesh, faculty from Pakistan, faculty from Middle East, faculty from different parts of the world, because we have invited few from outside Asia also. I'm thanking IDF Southeast Asia, particularly IDF Southeast Asia Chair, Dr. Azad Khan from Bangladesh, who asked, and we have done this program under the banner of IDF Southeast Asia. I'm also thanking Dr. Abdul Bashid, who is President of Diabetic Asia Study Group from Pakistan, who agreed to support it. And this meeting, we could send the flyers across the globe, and mainly from Asia. I'm very happy to share with you that more than 1,100 doctors were registered, and that too from Bangladesh, Sri Lanka, Nepal, Pakistan, Middle East, and even Egypt also. So, I mean, this was really a very, very successful meeting, and on a global front, it was very much required also that we should do a meeting pre-Ramadan to talk more about the diabetes and fasting. We know that
it is not only the Ramadan is a fasting. We have different cultures, different religions. They also do the fasting. So here, primary idea was that we will be discussing about how to manage diabetes during Ramadan in a different population, but also for other fasting, which is like in Hindu, Jain, and Yehudi and other castes, they also do the fast and how they have to manage the fasting if they are diabetes. So this was a meeting which was primarily planned for those doctors who could not attend it. All the lectures, all the videos, they all will be on our website, on Southeast Asia, as well as an IDF website. They will be there. We will be also trying to put their link on Diabetes Asia website, and all will be available to YouTube. So all those doctors who could not attend, they can listen at their convenient time. This meeting is supported for India by Abbott India and also by USV and Lupin. USV and Lupin had supported me to get the doctors from Sri Lanka and from Nepal. So I'm really thanking Nirmala for Abbott and USV team as well as Lupin team for supporting and getting the doctors for this meeting, and primarily the flyer which they could send across the country and across the globe and across the Asia. I'm also thanking RX event, particularly Hardik, who is a founder of RX event, to make it more popular and registering many doctors, because he has a huge database of doctors and he had circulated this flyer to more than 90,000 doctors across the country. With these few words, I am thanking all the chairpersons, moderators, reporters, and particularly my close friend like Dr. Bharat, Dr. Rutul, Subhajit Ghosh, Amit Dey, Amit Gupta, Rakesh Parikh, all of them have worked very hard, and they were all the time, they were since morning to evening, they were here. The Purvi Chawla required special thanks because she was coordinating it from day one, and she was there since morning till afternoon as she was catching the flight. With this, I once again, thank you everyone. Thanks to all the faculty, all the delegates, and everyone who is involved in this Southeast Asia program on diabetes and fasting. Thank you very much.
Thank you and goodbye, everyone.
Thank you. Goodbye, everyone. Thank you.